जनगण जनगण मन अधिनायक जय हे भारत।
A very good morning to all the people present offline and online.
Good morning, everyone, to this glorious day. I, Dr. Ekta Jajodia, on behalf of the whole organizing team, would like to present a gracious welcome to you all on the second day of MPAICON 2022. We shall begin with our inauguration function. I would begin the auspicious event by inviting the following dignitaries on stage. The President of MPAICON, Dr. Deepak Kumar Mishra, the Secretary cum Organizing Secretary of MPAI, Dr. Nagraj Arora, the Organizing Chairman, Dr. Jwalan Shah, the past President of MPAI, Dr. B.R. Das, the Vice President, Dr. Usha Dave, Organizing Co-Secretary, Dr. Apurva Shah, the Guest of Honor, Dr. Ravi Gaur, Dr. Chirag Desai, and I'm extremely privileged to welcome our chief guest, Dr. Chaitanya Joshi. Thank you, sir, for giving us your precious time. I request Dr. Spandan to welcome the dignitaries with the beautiful saplings. Now, Ms. Pooja shall present the mementos to the dignitaries. I request all the esteemed luminaries on the stage to move forward for lighting the lamp.
शुभं कुरु त्वं कल्याणम् आरोग्यं
I'd request the Secretary of MPAI, Dr. Nagraj Arora, to please welcome the audience.
Very good morning, everyone. Respected Joshi sir, the chief guest for the day, thank you so much, sir. The guest of honors, Dr. Chirag Desai and Dr. Ravi Desai, sir. Ravi Gaur, sir. The President, MPI, Dr. Deepak Mishra. The past President, Dr. B.R. Das. The Vice President, Dr. Dave. The President, MPAICON, the Chairperson, Dr. Jwalan. The organizing co-secretary, Dr. Apurv. So welcome you all here, the delegates, faculties, and my dear friends. We welcome you all to this meeting and thank you so much for coming here. On behalf of the organizing team and the MPI, I welcome you here to Ahmedabad. This is to the 9th Annual Molecular Pathology Association Conference. The theme for this meeting is Precision Medicine Healthcare for All, and we have tried to engage each and everyone who have been interested in genomics, who's working in this area, has the drive and the intent. As a part of this meeting, we have tried to engage each and everyone to this. What I truly believe is we are in the midst of genomic revolution in the country, post-COVID. We have not had any meetings of such, and post-COVID the interest has been huge in this area. And truly we are now in the midst of genomic revolution with the lot of infrastructure being placed as we go along, which is going to drive this area further. And as a society, we need to engage each and every people to provide this as a platform where we can each contribute and grow in this area. And that is what the intent and drive has always have been, to make this as a platform where we can also learn from many people and other people can also benefit from this. And that is what the intent and drive in this meeting has been. Lot of firsts, lot of many things we have initiated in this area. There have been 3 workshops, parallel workshops that have gone through. One of them have been the virtual one, and this has been first time this has happened. This digital initiative on digital PCR, digital initiative on a digital PCR with huge interest, almost 150 registrations. And I thank the Thermo Fisher team for taking the care and taking it through. With respect to the lot of the faculty and the experts that we have been able to involve in a multidisciplinary way, that has been exemplary, and we intend and hope that you all learn and contribute to this meeting from the faculties that we have had. So thank you so much, and if there are any shortcomings, please forget for whatever things, because this meeting was planned in a very short time, in almost 3.5 months. This was put through with the only intent being to hold the meeting. That was the intent that we began with. So thank you so much and welcome you all to here. Thank you.
I request the organizing chairman, Dr. Jwalan Shah, to please address the audience.
Good morning, everyone. All respected dignitaries on the dais, the delegates, speakers. First of all, I like to welcome everyone. It's a formal welcome. We are already on the 3rd day of the conference. So what I have seen is tremendous interest from all the level, from resident till the high, the consultant, faculties, into the molecular biology, and the way the questions were coming, way the people were interesting, the people were curious about various other things. I think really I am impressed, and I'm very sure that we can make India as a hub of molecular biology and the genomics in near future. First, and I also like to thank MPI for giving us an opportunity to conduct this conference in our state and allowing people to interact with the faculty from across the country. When I was in residency, everything was purely based on the morphology. So whatever you diagnose is purely a morphology. So when with the time that with the newer technologies has come, say for example cytogenetics, still the NGS, and in future we're going to have a long range sequencing and 10x genomics, single cell genomics. So with each new technology, each understanding, what we used to believe was correct is wrong now. So the basic understanding is more you know, more you shift from not wrong to right, less wrong. So that is what I believe, and it's a continuous process to learn. And without learning, I think we will not be able to grow. And so I also like to thank MPI for conducting this kind of event and allowing people to meet each other and interact with each other and understand the newer technology, subject and all. I also like to thank Dr. Nagraj, Dr. Spandan, Dr. Ekta, Dr. Jigar, Toral, Pooja, an entire team of molecular biology of Unipath. Without that hard work, I think we could not have done this kind of event in a short notice. I also like to thank Mice Ideas, Mr. Rajesh, and all the sponsors who have supported us in conducting this event in short time. Thank you very much.
I request the chief guest to kindly unveil the abstract book. The abstract book is in the form of soft copy, which will be circulated to the members of the MPAI through email, and this will also be available on the official MPAI website. Thank you, sir. I would invite the President of Molecular Pathology Association of India to kindly deliver the presidential oration.
Very good morning to this august audience. Professor Chaitanya Joshi, the guest of honors Chirag Desai, Ravi Gaur, dignitaries on the dais and off the dais. At the outset, I must thank each one of you to have come over here for this conference that was organized within a very short notice. And I would like to extend my profuse thanks. Subspecialties of pathology, molecular pathology has found a place along with other subspecialties of pathology. Unfortunately, the National Medical Council, the erstwhile Medical Council of India, hasn't yet included it in the teaching curriculum of MD programs. Now, different institutions have fellowship programs, certificate courses in molecular pathology, and people are learning from the centers of excellence like PGI Chandigarh, CMC Vellore, Tata Medical Center, Tata Memorial Hospital in Mumbai, GCRI, and many such centers where they go and learn the nuances of this nascent discipline. If you see the current trend of science, the movement of diagnostics, it's all molecular genomics. So if you look at the classification systems, every day you have newer classifications. In my area of hematolymphoid tumors, every 6 years you are having a new classification, and this year again you are going to have a blue book, and the entire thing changes very rapidly. Previously it used to be once in 10 years, but now this has been shortened to almost 5 to 6 years. 2016 was the last one, and now 2022 you have the next one. So the science is growing enormously and we have to keep pace with it. And the young generation has to be primed with this subject, that this is the future of diagnostic medicine. I'm not saying morphology, other ancillary techniques will be out of place. They will be there, but molecular genetics, cytogenetics, and all other techniques will be greatly supplementing the objectivity to your diagnosis, the treatment, and the monitoring of patients. With that, I have a the other thing is that we now, after this COVID lockdown, we are going to continue with our pursuit of these conferences and periodic academic events. The next conference will be at the Sanjay Gandhi Institute of Postgraduate Medical Education and Sciences in Lucknow. The next year, 2024, will be at the All India Institute of Medical Sciences in Delhi. And possibly in 2025, we will be having it in the All India Institute of Medical Sciences in Raipur. So people are very keen and enthused to organize these conferences in their own institutions so that the subject develops in those centers. As part of the presidential oration, I have a short presentation, and what I intend to do is to drive home the power of genomics as to how it has greatly impacted the diagnosis and the treatment of late. I bring greetings from Tata Medical Center at Calcutta. We all know that molecular diagnostics is the pillar of theranostics. And theranostics is a terminology that is a conglomerate of diagnostics, therapeutics, prognostics, and the disease monitoring in a molecular manner. So, without wasting much time on this slide, you know that personalized medicine is the buzzword in oncology these days, and every individual is personalized in diagnosis as well as treatment. This is a slide that shows you the landmarks in the history of genomics as to when somebody observed chromosomes until now, how different generations of next generation sequencing platforms are on the bench. So again, I will not waste my time here because I have the instruction that we must finish the inaugural function well in time. So I will not read out the different years as to what had happened in those years in terms of the historical aspects of molecular medicine. We use various techniques in the institutions. All of you are familiar with that. Many institutions have all of them. Some institutions have some of them. And there are some future emerging technologies like single cell genomics, you have third generation sequencers, you have transcriptomics, you have proteomics, and everything is coming in a big way, not only in the field of diagnostic medicine, but also in the field of research and development. I will just illustrate. I had more slides, but then I had to cut it short because the time is short. I will just illustrate a single case by which you can understand and you will realize as to how genomics can help in diagnosis and treatment. This is a 37-year-old male, a resident of Bangladesh and working in Malaysia, presented with abdominal pain and fullness in stomach for 7 months, and he had severe weakness for the same duration, and he presented to us in May 2022, had splenomegaly, no lymphadenopathy. This is the peripheral blood which showed predominantly leukocytosis, 342,000 count, a little bit of low hemoglobin platelet count is on the higher side, and eosinophils of 12%. So absolute eosinophil count is significantly high. So this patient is having this problem. I'll show you the next slide. If you see historically that the patient who first reported to a hospital in Malaysia had hemoglobin 8.3, in Bangladesh 7.3, came to us 9.4, and his leukocytosis has been varying from 143,000 to 342,000. Platelets have always been little on the higher side. Ultrasonography of the abdomen showed and confirmed splenomegaly. Rather, he has a huge spleen, almost 21 centimeters. The bone marrow, the hematopathologist reported as myeloproliferative neoplasm, and when the patient came to us in December 2021 to a hospital in India, they also reported it as myeloproliferative neoplasm with eosinophilia unclassifiable. As we always do in any myeloproliferative neoplasm, the BCR-able transcripts, which was negative in this particular patient for all types of BCR-able transcripts, the E13A2, the E14 as well as the E1A2. So we always have the approach to a patient who has hypereosinophilia. In my MD days, in 6 months we would have termed it as hypereosinophilic syndrome, but not anymore. That hypereosinophilic syndrome gets characterized by multiple mechanisms, and we give a name to that eosinophilia. And this slide is a busy slide. I will not follow the arrows, but you know that how you would like to investigate them. The commonest cause of eosinophilia, of course, is the reactive secondary eosinophilia. There are multiple disorders which can produce it, and before you embark on labeling them as a myeloproliferative disease, you need to exclude all the causes of secondary reactive eosinophilia, and the list is quite exhaustive, and there are many more also could be producing reactive eosinophilia. So other significant details of this patient: the patient had nothing much in the history. There are no known allergy. Patient didn't have chronic fever, joint pain, vomiting, and nothing was very significant. Spleen was quite large. Patient had mild icterus, mild pallor, no lymphadenopathy. Chest X-ray was normal. This is the bone marrow, which shows myeloproliferation with increase in eosinophils and eosinophilic myeloid precursors, suggesting that possibly the patient has a myeloproliferative disease because of the very high count in the peripheral blood and a hypercellular marrow with myeloid hyperplasia. This is the bone marrow, which shows that there are megakaryocytic hyperplasia, and you can see that large number of eosinophils and eosinophilic myeloid precursors at 10x magnification. Just to highlight the megakaryocytes, we did a CD41 stain. The low power and high power illustrates that patient has megakaryocytic hyperplasia, which is also a feature of myeloproliferation. CD34 and 117, which are markers of immaturity, were however non-contributory. So myeloproliferative neoplasms, you all know, is a distinct entity. I will not go into the details of its definition. This is a clonal hematopoietic disorder where there is proliferation of either one or all three cell lines in the marrow. So this is the table that shows you the 2008 and 2016 WHO classification of MPN. Now soon you are going to have 2022. There are some subtle changes in this classification which I am not going to discuss because not yet the blue book is not out. It is just a publication in few journals where the group has published the recommendations. The mastocytosis was part of it in 2008, which is off the list in 2016. Otherwise, everything fairly remains the same, and you can find that there is chronic eosinophilic leukemia, NOS, and also you can have myeloproliferative neoplasm, unclassifiable, where also you could have eosinophilic disorders. So then when you come to, after excluding all the reactive causes of eosinophilia, if you come to primary clonal eosinophilia, which is nothing but hematological neoplasms of varied types and etiology, with clonal eosinophilia being there, where the eosinophils form part of the neoplastic clone. And in that you have myeloid and lymphoid neoplasms with rearrangements. Multiple genes are involved: PDGFR alpha, beta, FGFR1, PCM1 JAK2, ETV6 JAK2, or even BCR JAK2. So large number of genes are involved. Chronic eosinophilic leukemia is already there. Atypical chronic myeloid leukemia with eosinophilia, chronic myelomonocytic leukemia with eosinophilia are all entities of primary clonal eosinophilic disorders. Similarly, you can have many other clinical conditions and diagnostic entities where you can have clonal eosinophilia. So this is a table which summarizes that you can have this PDGFR alpha, beta, FGFR1 and PCM1 JAK2 with rearrangement of FLT3 or ABL1, most commonly along with ETV6. And there could be 70 fusion genes that could be present in these rearrangements. I will come to that a little later in this particular case. So this is a busy table that shows you the overlapping bone marrow findings that you can see in Philadelphia negative MPNs. So what we did in our center, that we did a flow cytometry, which was nothing significant. BCR-ABL for fish was negative. Karyotyping was normal karyotype. This is the karyotype 46XY. When we did the BCR-ABL fusion, which was also, there's a dual color dual fusion probe, which was negative for BCR-ABL fusion signals. And corresponding RT-PCR for BCR-ABL was also negative. So we also looked at the ABL1 gene rearrangement, because that is a partner in multiple rearrangements. So that was also negative by using the 5' and 3' centromeric probes, centromeric as well as telomeric probes. The RT-PCR BCR-ABL, as I said, was negative. We did a MPN reflex panel which looks for JAK2, which looks for CMPL, and which looks for the CALR, which was all three being negative, along with the JAK2 exon 12 mutation. After that, still we were not very convinced. We did the comprehensive myeloid gene panel, the 69 gene panel, which is a mixture of full gene analysis, some hotspots, and some 29 fusion drivers, and it shows that ETV6 showed a fusion signal with good read being positive. So we thought that yes, something probably we have missed in either conventional karyotyping or in the fish. So ETV6 could be there in eosinophilic disorders. And this is the Oncomine Myeloid Research Assay panel. I will not go into the details, but what we got is ETV6, which can have fusion partners which are multiple. You can see the third row, which has multiple genes written out there which can combine with ETB6. So we didn't find any DNA mutations. We got a fusion which was translocation 912 ETB6 ABL1, which encodes for TEL-ABL1 gene fusion. And this, if you review the literature, gives rise to clonal eosinophilia. Many times the fusion signals in the fish is quite cryptic, and they may not be visible when you do the fish. So it is important that you should use multiple complementary techniques. Mayur has already published it. So we adopt a 3-probe fish strategy to identify the ETV6 ABL1 fusion. I'll show you the next picture. In 2 patients, we could be successful. In patients of ALLs where there was eosinophilia, so we could say that it is ETV6 related. So one is ETV6 ABL1, and we also have found out that it could be with BCA ABL1 with eosinophilia. It is not the same transcript, but a different transcript. So something a little bit about ABL1 ETV6 fusion. So this is the one that I showed you, that they were negative for ABL1 gene rearrangement by fish, which must be quite cryptic to say that it is positive. This is a positive for ETV6 gene rearrangement. In another case, I just wanted to highlight that you can see the signal here. So the review of literature says that when you have the ETV6 gene, which is in exon 1 to 5, is quite close to the Notch1 gene, and this Notch1 gene actually is the gene which produces this myeloproliferation, and that is very close to the IL-5, so that proliferates the eosinophils. So the diagnosis of this case that we offered was pH negative myeloproliferative neoplasm with translocation 912 ETV6 ABL1 gene fusion. Such patients, they respond brilliantly to the first line TKIs, and the patient was put on just 100 milligrams of imatinib, and within 1 month his eosinophils disappeared to normal, and the counts also decreased, and the patient is under follow-up and doing quite well. Every 6 months he comes from Bangladesh and gets reviewed. So I have already told you about the treatment. Thank you. So the moral of this presentation is, this is the power of genomics as to how you can stratify a disease which used to be dumped as hypereosinophilic syndrome some years ago, but now you have characterized it, you have found the genetic signature of it, and you know how to treat it, and you know how to monitor it. After we found that there is no signals in the FIS, then how to monitor it. So you can do alternative sequencing in such patients, can monitor the fusion signals in terms of reads to monitor the response to this disease. But the response is so dramatic that I think the patient shouldn't waste more money in just doing NGSs for monitoring. So clinical molecular diagnostics is here to stay, is a powerful tool. It is better that you all get primed to these technologies and use it for your patient's diagnosis and treatment. With that, I thank the audience for a patient hearing, and in case there are any queries, I would like to take it at the end of the inauguration session. Thank you so much.
Thank you, sir, for your enlightened talk that underscored the importance of molecular biomarkers in diagnostics. I would request Dr. Nagraj Arora and Dr. B.R. Das to please felicitate the President.
Could I request the IT people to project that slide which gives the demography of this conference as to how many people have registered, attended, how many members. Have you got that presentation ready, Rajesh?
Sir, I'll give that.
You have that?
I will
Okay.
give an update
I
on
think Dr. Nagraj will give that update about the conference.
Sir, so this is the first time that we are happening. I mean, this is presidential oration is being planned and happening. Before this, this has not been happened. So this is something that, as a part of MPI, we will be doing further in that. So the president, Dr. Mishra, and the past president, Dr. B.R. Das. So we will.
I think this has been a great embarrassment for me.
I request the past president of MPAI, Dr. B.R. Das, to please address the audience.
Honorable Chief Guest, Dr. Joshi, respected guest of honor, Dr. Desai and Dr. Gaur, my friend, President Dr. Mishra, Vice President Dr. Dave, Organizing Secretary Dr. Nagraj, Dr. Purva, and my dear friends. It is an incredible delight for me just to be here and to experience since yesterday lots of very, very qualitative presentations. And I still very fondly remember the moment when MPI was conceptualized and when it was started in 2011. Few of us with great enthusiasm came together and we just envisioned and created this forum, and which was, the seed was planted 10 years back, and today the tree is fully grown. I'm only enjoying the blossom of the flowers and the sweetness of the ripening fruits. So I'm really, really very happy just to see this kind of the unfoldment of this creation. I would like to consider this as an opportunity for me to acknowledge the contribution of each member of this association. It would not have happened. It would not have happened. It would not have come to this height unless until each one of you would not have contributed. So many people think that there are very few people who are very active, and there are people who work on the behind the screen. But believe me, each drop counts. So each one of you deserve this appreciation. So thank you. I would like to just share a few good moments, and one of the major accomplishment that I would like to share is MPAI was identified as the first affiliate of AMP, Association of Molecular Pathology, which you must be knowing. That is the global body whose head office is situated at US. And I still remember the credibility which was shown by MPAI was identified by AMP, and AMP announced MPAI as, in the whole world, as the first affiliate to AMP. And that was a proud moment for each one of you. And I still remember those, I cherish those good moments. At the same time, I feel that it's a huge responsibility. It's a huge responsibility to maintain this credibility that was already created by the association. So again, let us think about it. And sustenance is always more difficult than creation. That's what we all know that. I still have the privilege of serving AMP as a member of the International Affairs Committee, where I represent India in AMP since last more than 8 years. So AMP is very much aware about all the activities, even the scientific program that has happened, and AMP has conveyed its good wishes for all our meetings. Apart from AMP, I would also like to tell that there is another we got also wonderful recognitions from Association of Indian Pathologists of North America, APNA. So that is also very closely associated with MPAI, and it needs again little bit of more strength and to nurture it so that our association is again maintain that relationship. Thus, there are so many such credibilities as well as a quite steady and satisfying evolution. I do not want to tell more because I also want to reduce the time so that we can finish up our inauguration quickly and maintain the timelines. But at the outset, I would just like to request one thing that please continue to shower your best wishes. Continue to shower your blessings so that molecular pathology associations really grow and move forward to the next level. Thank you very much. God bless. Thank you.
Thank you, sir. I invite the chief guest, Dr. Chaitanya Joshi, to address us all on this occasion. He is the director of the Gujarat Biotechnology Research Center, Ahmedabad. He has a special interest in the animal health and agricultural science.
Good morning, everyone. I'm feeling very happy to be over here at the 9th annual conference of the Molecular Pathology Association of India. The president of MPAI, Dr. Deepak Mishra, secretary, organizing secretary Nagraj Arora, organizing chairman Jholan Shah, past president of MPAI, Dr. Das, EC member Dr. Usha Dave, organizing co-secretary Apurva Shah, guest of honor Dr. Ravi Gaur and Dr. Chirag Desai. I feel very happy to be over here because the molecular biology is very close to my heart. I started learning molecular biology in 1990s and put it into practice in terms of research projects and continuing till to date. The task, vision and mission imbibed by MPI to spread the molecular biology in the diagnosis and practice is very much pertinent. I fully support the cause. I recall those days when I used to visit medical college and try to convince medicos how important and accurate the molecular techniques are for pathogenic and non-pathogenic conditions. Our lab was best equipped for that purpose. However, the medical colleges made best use of our laboratory during MCI inspection, Medical Council of India inspection. They took our PCR machine, electrophoresis to their lab and successfully completed the inspection. I'll tell you briefly about my institution from where I am coming, that is Gujarat Biotechnology Research Center. We are focused mainly on the biotechnological solutions, not only in the healthcare related issues, but also in animal husbandry, agriculture, environment, and industry. We also provide shared lab facilities to students, faculties, and industry at nominal charges. In shared facilities, users need to operate the machines themselves, and for that reason we provide the training to the participants, users on each and every instruments. Capacity building in terms of infrastructure and human resource is the main focus of our institute. As long as additional diagnostic accuracy do not influence the treatment regimen, it carries less importance. So what Dr. Deepak Mishra mentioned, if it has something relevance with the treatment that will be followed by that, then that diagnostic will carry value, and everyone will start giving importance to that one. The advancement that's taking place in molecular pathology is phenomenal. We need to keep pace with the developments. It will help in improvement of quality of human life. This advancement should be used to improve human abilities rather than masking or shadowing it. That is the word of caution, particularly for the medicos. So otherwise, they have very sound ability of diagnosing the disease with their experience. This should be only a tool to help or sharper their diagnosis. Tons of data in the units of MBs, megabytes, gigabytes, terabytes, petabytes are pouring in every hour. Though the bioinformatics and big data analytics are at our rescue. We have to prepare ourselves for forthcoming AI, that is artificial intelligence and machine learning based revolution in the diagnosis. Every time human intelligence would be challenged, and the same challenged minds will evolve more powerful algorithm for the diagnosis. The cycle will continue, and we'll be left with no option but to wait and watch the outcome. Once again, I thank organizers for calling me at this event. Thank you very much.
Thank you, sir, for giving your time, and we are sincerely grateful for your part in our event. I invite Dr. Ravi Gaur, a guest of honor, to address the audience. Dr. Gaur is the founder and director of the DRG Unipath Labs, Delhi.
Good morning, everybody. I think it's my pleasure and privilege to be here with the Molecular Pathology Association of India conference event. And it's all the more, I think it's my honor to share the dais with our chief guest, Dr. Chaitanya Joshi, Dr. Chirag Desai, and of course, the renowned faces, Dr. B.R. Das, Dr. Deepak Mishra, Dr. Usha Dave, Dr. Jalant is another founder, and Neelaj, who's the upcoming face in the molecular industry. I probably see the evolution of molecular biology. Somewhere, if you notice, the Sanger's sequencing, probably started way back in 2003, 4, 5. Probably it came in India in 2005 and 6. But its application was restricted to common thing, and the way it spread, it took almost 12 years. But around 13 and 14, the people started understanding the real value of molecular biology and pathology together. And then the NGS came. NGS came in 2013, 14 in India, and it's now today, it's almost 10 years, and we have 3 generations of NGS. We have coming 3rd generation NGS is now coming out. The way the NGS has taken over, that itself shows that molecular pathology is probably one of the futuristic diagnostic technology. And that's really probably what Molecular Pathology Association is doing, and it's a wonderful work probably to see how they have come up. And I was told yesterday that we have to, at one point of time, there were so many registrations and inquiries, probably they have to stop the registration. There's so much enthusiasm probably has developed now in the molecular field. Another thing which I have noticed right here is like I am basically a pathologist by profession, because somewhere when I was 2005 and 6, and we had molecular biologist. This molecular technologies was more of a R&D and more of a a trial kind of a tool. So this was that they're all working as standalone. We have molecular biologists doing the work and pathologists separately in the two components. I think both of them now married together. Now it's molecular pathology, and that's probably is driving the molecular pathology industry to very, very fast. And both of them has to work very, very close together, interact with the clinician, because unless we have a clinical feedback from the clinician, so this team of clinical faculty, the molecular biologist and the pathologist together, and this is where I think we should be thankful to all of you. In fact, I have been here since yesterday. I've seen many of the sessions. I've gone through wonderful presentations, great, I think, the faculty out here, and probably a lot of people virtually out in on the Zoom call, and I think all of them have contributed very well. Thank you so much for organizing such a wonderful conference. Just a few words before I think just shut down. It's like, almost all aspects of life, if you look at, they are emerged, this engineered but the molecular level. Without understanding molecular, we can only have a sketchy understanding of life itself. The personalized pathology is, it's a division for the, it is a vision for the future. Not really the future. I think it's become almost a present now. If you look at the past we have, I'm sure Dr. P.R. Das, Deepak Mishra, and they're all aware of that. In past, we had intuitive medicine and followed by sign and symptoms. That is how the treatment was driven. Currently, at majority of the places, I think, this evidence-based medicine and the clinical trials came up. Now, the future, which is, I think I'll say future right here, and I think we are moving forward very fast, it's precision medicine and the algorithms. A lot of AI and algorithms based on the inputs what we're getting in the genomics, that's deriving the diagnostic, and that's going to be the future. And that's the theme right here. We have precision medicine, healthcare for all, the rightly thought of theme. One thing I always remember, because these personalized medicine, molecular pathology was being used for oncology, but today it's really not. We have it's applied to all fields. What we have seen is the role of the NGS in COVID, infectious diseases. We are seeing now, in fact, non-oncology. And in fact, I remember one of the talk of Dr. P.R. Das sitting in the dais here. It was way back, I think, almost 9-10 years back. He has put a slide in the board which says molecular pathology, womb to tomb, right from pre-implantation and the post-autopsy. Everywhere he is the state of the application. And today, that is his dream has come true, and that's something what we're looking forward. And I'm sure much more is going to come forward. And again, I'd like to thank every one of you and thank the organizers for a wonderful conference, and the MPAICON, a very, very good journey. I look forward to Deepak Mishra. Please take it forward to Delhi, take it forward all across. There's a lot of enthusiasm, and people want to understand more about it. And I'm sure under the guidance of senior mentors and, of course, the new generation, they will club together and make it a reality. Precision medicine, healthcare for all. Thank you so much.
Thank you, sir, for sharing your experience. Now I request Dr. Chirag Desai, a guest of honor, to address us all. He is a consultant oncologist and director of Vedant Hemato-Oncology Clinic, Ahmedabad.
Good morning, everyone. Respected Dr. Joshi, the chief guest, Dr. Ravi Gaur, the guest of honor, Dr. Das, Dr. Mishra, Dr. Jwalant, and the other dignitaries on the dais, off the dais. I got the phone call from Jwalant before a few days to become the guest of honor in this meeting. And I was wondering that when a molecular pathology event is occurring in my city, that is Ahmedabad, and if the theme is precision medicine, whether I should be the host or a guest. But Jwalant, your one call made me an outsider. I became the guest from the host. And I will come back to that point in a minute. In 2013, I had the opportunity of meeting Professor Taylor Jacks, who is the director of Cox Institute of Integrative Cancer Biology, which is a part of MIT in Boston. And he said that in his laboratory, in his institute, there are 4 wings. one wing of biologists, one wing of chemists, one wing of biotechnical engineers, one wing of clinicians. And at the interface of each wing on each of the floor, there is a coffee room. And the maximum innovations are occurring in those coffee rooms. Right? So, the discoveries has to come from bench to bedside, then only it becomes successful. Otherwise, it just becomes a publication and nothing beyond that. So, on last Saturday, Dr. Joshi, we were together in GSBTM, Gujarat State Biotechnology Mission Conclave on cancer. And I had the opportunity of delivering a talk, and the theme of my talk was from bench to bedside and back to the bench, because going from bench to bedside answers several questions but raises many more questions, that why certain therapies are working, why they are not working, and when they are working, why they stop working beyond a certain point in time. And these are the questions which we should take from bedside back to the bench and rework on that, and that cycle should continue, going from bench to bedside, bedside to bench, and so on and so forth, right? So, congratulations, Dr. Jwalant and the team for organizing this wonderful conference. Molecular Pathology Association is an ideal position to be at the interface between the basic scientists, the clinicians, and the clinical laboratories. And I hope that this conference and the conferences and the activities of this association in years to come will catalyze the interaction between the clinicians and the basic scientists, and will help in taking the discoveries from bench to bedside for the betterment of our patients and betterment of the mankind. And I hope that in the future conferences I will be the host and not the guest. Thank you very much.
Thank you, sir. We are grateful for the time and effort you took to share your thoughts and experiences with us. I invite the Vice President of MPAI, Dr. Usha Dave, to come forward and address the audience.
Good morning, everybody. As a Vice President of MPAI, I take my memories back to the days in 2011, as our past president said, Dr. B.R. Das, the like-minded scientists, the groups, we were in a small cabin of SRL laboratory, and when we started, the MPI, now it's really a proud privilege to see and stand over here to see that it has blossomed into the current stage, and whatever our objectives and the goals, when I stand here and heard the earlier speakers, they had precisely elaborated on the same, and that was our goal of MPAI. Not to mention that Dr. Nagraj Arora and his team, and of course the backbone, I think you are lucky to have person like that, and that is an excellent model. I would like to share that is an excellent model of PPP, private and the partnerships, okay? And I think now we should grow up. Only my one appeal to all the people who have come here to share the knowledge. This is the organization where both the clinicians, scientists, biotechnologists are here for the molecular pathology. And I would request you to go back not only with these cherished memories of knowledge, science, but to share it with your younger colleagues. Because that is one of our goals, is the academics. We want to grow and help also the youngsters. So share it, this information, make them members, let them come out, and it's the, our request to all those who have please feel free to contact and write to the president and our team, whatever new ideas you would like to, bring it out. And that's how I think we are going to grow. Thanks again, the president, our teams, the guest of honors, and the UNIPATH team also to help us and bring us to this stage of the MPI, and let's grow together. Thank you so much.
Thank you, ma'am. I request Dr. Apurv Shah, the organizing co-secretary, to please deliver the vote of thanks.
Good morning, everyone. We are really thankful for all the dignitaries on the dais for that sharing their vision and wisdom with us. We are very thankful for all the faculties across the country, all the delegates who have participated in this event. We are really thankful for Dr. Nagraj Arora and their team for their workshop on the NGS, Dr. Amisha and Dr. Meenu and Cytogenics Lab for arranging the FISH workshop, entire molecular team for organizing this event. We are really thankful for the MICE Idea team to manage everything in the floor. Thanks to Narani Heights staff for the very good hospitality. And we are really thankful to all the sponsors who have sponsored this event. We are especially thankful to Dr. Ekta for managing the whole day in spite of having a very small baby. We are really thankful for Dr. Ekta. Thank you very much, all of you. Thank you. We are happy to have any suggestion, and we are sorry if you have made some mistakes.
Just to give you an update which was missing earlier, in terms of the number of registrations we have had, there have been a total of 360 registrations that we have got, and in the workshops almost 70. There were 3 workshops, 70 registrations for the NGS workshop which we closed 1 month back. FISH registrations also closed, 25 registrations, but we closed 1 month back. Online registrations for the digital PCR was continuing, and it was 130. As we speak, yesterday there was I think 500 people online viewing this. This was again an initiative that we go digital and try to connect with as many people as we can. So almost 500 people were online, and this was decision taken almost 5 days back. 5 days before this event, we kind of initiated that this is going to be like that. So thank you so much, and welcome you all to be here, and we keep learning from each other. Thank you.
Thank you all for joining us on this auspicious day. May I please bother you all to stand up in honor of our national anthem.
Jana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everyone. With that, we'll start with session 2. We now move on to the next session on histopathology in the era of molecular pathology. One lecture in this session will be in the live virtual mode. Question and answers will be taken at the end of each session. I invite the chairpersons, Dr. Anu Yadav, Product Head Genomics and Reproductive Medicine, Unipet
Very
Specialty.
much, I can hear you, Neera.
I call on Dr. Bibhaskar, Genetics and Molecular Medicine, Kokilaben Dhirubai Ambani Hospital, Mumbai, and Dr. Sandeep Sheth, Surgical and Hematopathologist, Cell Pathology Lab and Zydus Hospital, Ahmedabad, to come on stage and start the session. I request the chairpersons to start the first lecture.
Hello. I think she'll announce first. Hello. Should I start? Yeah. Oh, yeah. The talk of the first session is will histopathology survive in the era of molecular pathology? Being a surgical pathologist myself, it sounds very scary because even with the advent of immunohistochemistry, surgical pathology has remained the mainstay in tissue diagnosis. Now, with the molecular diagnosis advances, the next generation molecularly driven era in pathology has come up. Will histopathology will have the same importance, same charm it used to hold so firmly? I believe what will be the role of a surgical pathologist in this new era, and what modifications we will require in our medical education curriculum so that we can keep pace with this molecular diagnostics. We have no better person to tell on this than a legend in the field, a teacher par excellence, Dr. Anita Borges, madam. I distinctly remember in one of the hematology conferences in Mumbai, she called Professor Dr. M.B. Agarwal Amitabh Bachchan of hematology. Let me tell you, she is no less when it comes to surgical pathology. Dr. Anita Borges, ma'am. Thank you. Please, ma'am.
All right. Good morning, everybody. Let me at the outset thank Nagraj for having invited me to address a hardcore meeting of molecular pathologists. I really was at a loss to understand why I, who have been a surgical pathologist born and bred, was being asked to talk at this molecular pathology meeting. But anyway, he asked, and I decided that although I have presented this kind of talk, before pathologists and surgeons, I picked up the gauntlet and I said, let me just do this by walking into the lion's den and present this to molecular pathologists. And I hope at the end of it all, you will realize that there is something else that surgical pathology, or as many people believe, that surgical pathology and histopathology are synonymous, that there is much more to surgical pathology and histopathology than just, the HME. So let me get into it. So first, let me just tell you what is surgical pathology, and I've alluded to it. It is not entirely synonymous with diagnostic histopathology. We do a lot more. It is really about tissue pathology that is directly involved in clinical decision making. And it started a very long time ago, and I think it's just a couple of years now that one of the most famous surgical pathologists in the world, that's Juan Rosai, passed away. And anybody who's really interested in the history of surgical pathology should pick up a copy of the book, which I must say is very rare, and the few copies that are floating around should be grabbed by anybody who's interested in this history. But essentially, it is about more than just making a diagnosis. Okay, so what is it? And I use the word surgeons because really surgical pathology, the term came about because the surgeons who were frustrated actually hired pathologists in the departments of surgery. But today, I think you could replace that word surgeon by clinicians of all kinds. And since I have worked most of my life in cancer, we just don't deal with surgeons. We also deal with medical oncologists, radiation oncologists, and so on. So we could replace this title surgeons with clinicians. And I think this is important. It is information that helps them to decide what to do next. And they do this on the basis, yes, of diagnosis, a lot on staging, some decisions that are need to be made on adjuvant therapy, which are dependent on the completeness of the response to therapy, whether it's margins or it is, how the tumor has responded to anterior chemotherapy, etc. And of course, this huge, big area of prediction. Predictive oncology is a very big thing. And I think you can see that prognosis I have put really at the bottom of this list. Because once upon a time, yes, a lot of emphasis was given to prognosis, but I think that's gone a little into the background. Essentially, what surgical pathology is about is providing information that is relevant to patient management. Now, what is all this got to do with whatever it is that I'm going to talk about? Well, people have been criticizing surgical pathology for years. They say it's subjective, it is old-fashioned, it's outmoded. We are even supposed to be in competition with, the imaging mullahs, because I'm being told, day in and day out that, PET scans and all these very targeted scans, also EUS and others, can not only make diagnoses, they can do staging better than we can. And I just want to say a word about that. I mean, although that's not exactly what I'm going to talk about today, that ultimately the gold standard is what the pathologist actually says. But to leave that aside, I'm also being told that diagnosis, prognosis, and prediction is better refined by molecular techniques. And I agree, but let us see what exactly these molecular techniques are. And of course, now I'm being told that molecular analysis of liquid biopsies will replace tissue biopsies. So let's get into this. And I want to start by asking this question. What is a molecular test? Okay. And who is a molecular pathologist? Let's look at that a little closer. Now, you know this biological dictum, DNA makes RNA makes protein. And I'm talking to an audience of molecular pathologists, and these molecular pathologists somehow or the other seem to feel that there is only one or two aspects of this biological dictum that deserve mention. And that is somebody who is actively involved with testing DNA or testing RNA is a molecular pathologist. But I just want to make this point, and that's why I've highlighted it. Let's not forget protein, because nothing works in biology unless DNA makes RNA and RNA makes protein. So let's now think about protein. And you know, as a tissue pathologist, we've been through this. You know, there was macroscopic imaging, then there was microscopic imaging that came with Rudolf Virchow and his cellular basis of disease. But we are, whether we think about it or we want to push it aside, we are in the era of molecular imaging. We have been for quite a long time, but people don't recognize that we are in the era of molecular imaging. Histochemistry, of course, has been with us for a very long time, but let's remember that we are in this era of immunohistology and in situ hybridization. And whether we like to acknowledge it or not, that is molecular imaging. So we have the word there now, molecular imaging. And what is molecular imaging? Well, it requires a probe, and I'm using this in a very generic word. I'm not using it in the sense of a probe, a nucleotide probe, but it requires a probe of some sort and a method to visualize the presence of this probe, which we call a reporter or a signaling molecule. Okay? And these probes can be antibodies to proteins, which we generally call markers, or it can be, you know, like in situ hybridization. And I'm talking about tissue now, nucleotide sequences to a complementary sequence. And then we have reporter molecules, which are either fluorochromes or chromogens. And if we look now at the present status of molecular imaging, of course, it is being used a lot in diagnosis, okay? Particularly on limited material, because we are in the era of small tissue big diagnosis. We're able to tell tumor type, we look for pathogens in tissues, and a host of other things. But that's, again, molecular imaging. We are looking for proteins that are diagnostic in tissues. But leave that aside. You know, people say, oh, that's just a special state. Possibly. But remember, we are still imaging protein. But I don't know how often we stop to think that when we are imaging these proteins, we are making indirect inferences of genetic abnormalities. Think about it. Every time we are able to show, as I will show you now, that there is ALK1 being expressed in a tumor, we know that there has been a chromosomal translocation that has made this ALK1 protein now expressed, which it was not, because it was before that, it was under the inhibition of its, the promoter was inhibited. So expression of the gene as a protein was not possible. Every time we do a HER2 test, and I don't think that there is any dispute that so many labs are doing a HER2 by immunohistochemistry, we are actually talking about gene amplification. And as I will show you later, we are looking at gene mutations with enhancement or loss of protein, which we are able to tell on immunohistochemistry, right? And then, of course, sometimes there is no abnormality in the gene, and you are not seeing, or you're seeing altered protein expression, and that's as a result of epigenetic alterations. And let me just ask here, how many molecular pathologists are actually looking at protein expression in any other way, certainly we are all, they are not doing MALDI-TOFs and some other in routine diagnostic or predictive pathology. So who are the people who are looking at proteins? And I think it's tissue pathologists, surgical pathologists, histopathologists, for want of a better word, more recognizable word. And of course, I put there predictive pathology. Now, this was the example that I gave you, and this is ALK, and we all know that this is an anaplastic large cell lymphoma. We do a lot of other diagnostic tests, but in the end, if I had to prove that there is an ALK rearrangement, then I look for expression of ALK1, and there you see it. And this gain of protein expression tells you that at the genetic level, there is an ALK1 rearrangement, usually. Okay. Similarly here, microsite instability in colorectal cancers. We know that today, once upon a time, maybe one had to do, a hardcore molecular test to find out microsatellite instability in colorectal cancers. But today, loss of protein of these markers, and more than this, I've just shown you two, that's MLH1 and MSH2, but of course we do MLH6 and PMS2. With these four markers, you can get a very good idea of what's going on in the, at the genetic level. There's either total loss or maybe an epigenetic alteration that gives rise to loss of protein expression. And it is the protein expression loss that is really important with respect to whatever this microsatellite instability is going to be used for in the clinical context. Let me ask another question. Is a molecular signature, even if it is found by a molecular test in a so-called molecular biology lab, is that molecular signature specific to only one tumor type? And the answer is no. I've given you some examples over here. And you do need a histopathologist to interpret this signal. Is this actually an angiomatoid fibrous histiocytoma, or is it a clear cell sarcoma, or is it a pulmonary myxoid sarcoma? I don't think that a molecular biologist would be able to do this without looking down at the microscope. Albeit, let's get on to the next thing. Now, we are not only able to image proteins, we are also able to image nucleotides. And this is a case in point. Here we have a 10-year-old male, chronic upper respiratory tract problems, recent onset of cervical lymphadenopathy, and this came to us with the diagnosis of a Hodgkin lymphoma. And here is a test which was done actually by the referring pathologist, where EBRs, which is Epstein-Barr virus RNAs, were imaged by in situ hybridization. Okay? And this is on routine formalin-fixed paraffin-embedded tissue section, which we do on a routine basis. So here we are again, imaging RNAs. This, of course, didn't turn out to be Hodgkin's lymphoma because it's metastatic nasopharyngeal carcinoma, which, of course, we proved by another protein expression on immunohistochemistry, which is a combination of A1, AE3, which detects cytokeratins. All right, so that's as far as our diagnosis goes. But what about predictive pathology and theranostics? And I think it's a big word today, theranostics. It's a big, very important branch, particularly in oncology, which of course relies on molecular understanding of a disease in a given patient, and of course tailoring the treatment based on this understanding. It's about providing the right treatment for the right patient at the right time. Now, everybody thinks that theranostics is very new. No, we've been doing this for years and years, except that it was always considered to be some kind of special stain. I don't think it is just a special stain. You know that for years, how was estrogen receptor, in the early years of estrogen receptor, how was it being estimated. It was estimated by a biochemical test. You know, they used to do dextran coated charcoal assays. I don't know if there's anybody in the audience who even remembers that. I'm old enough to remember it. Today, who is doing any other biological, biochemical, or molecular test for estrogen receptor? We all rely on immunohistochemistry. Why? Because it's imaging the protein that is the estrogen receptor. Right, and I've already talked about HER2, and the amplification is being routinely done on paraffin embedded tissues, either by immunohistochemistry or, if required, by FISH. And that's all done in a histopathology, surgical pathology lab. We're routinely looking for CD20, which is a predictive marker for response to rituximab in the right clinical setting. And of course, you know, we've been doing CD117 for gastrointestinal stromal tumor, both as a diagnostic as well as a predictive marker. I do not for a moment think that I want people to believe that this is the end of the story, that, you know, that one never has to do something more than just immunohistochemistry for, say, a gastrointestinal stromal tumor. Certainly, as of now, I cannot tell you whether it is the exon 9 or the exon 11 has been mutated, whether you need to give a higher sort of dose of Gleevec. That I can't tell you. But certainly, all pathologists can tell you if the CD117 is overexpressed, that this is a gastrointestinal stromal tumor and it is going to respond to a TKI. Right, so again, you know, this brings us to personalized or precision medicine, and I want to talk about lung cancer because this is the cancer that everybody is talking about, and that's because it's been one of the the success stories of modern oncology treatment. This was a disease that left very few people standing at the end of, say, 6 months, 8 months, and now there are people going on for years. And I think that that's a great advance. And the reason for this advance is because of the underlying molecular pathology of lung cancer. And we've heard about activating mutations in the EGFR gene, ALK fusions, ROS fusions, and now, of course, immunotherapy with PD1, PD-L1 targeted therapies. And it was said for a long time that you needed molecular tests. And again, I bring this back to it had to involve RNA or DNA in some way. It was, you had to find mutations by sequencing the DNA of the tumor. And of course, this is still true. You can find mutations not only in EGFR or, for EGFR in lung cancer. And the NGS is a real advance, which I'm sure has been deliberated endlessly during the previous sessions at your meeting. But is that true that mutations cannot be imaged in any way other than by sequencing? The answer is no, because once again, I remind you about the central dogma of biology. And what is that? DNA makes RNA, makes protein. So if you have a mutated gene, it may just happen that that results in an abnormal protein. And it is quite possible if you have an abnormal protein that an antibody could be constructed to that abnormal protein. It's not that it could, it has been. And today I'm sure that all of you who are in the audience and many of you are pathologists know that now for the two, standard mutations of EGFR in lung cancer, we have the corresponding antibodies. And I've just shown you that in the bottom panels. And we don't have a molecular test actually to tell you whether you can use immunotherapy, and that's done by us imaging the protein PDL1. Okay, it's either expressed in large quantities, in small quantities, in medium quantities, whatever, but it is being imaged. Okay, let's go to what people used to call companion diagnostics. Okay, when EML4 ALK as a rearrangement was discovered in lung cancer, there was a translocation, and there was a FISH test, which again was done on formalin fixed paraffin embedded tissues on a routine section, and this was needed as the diagnostic test to use this TKI, which was known as crizotinib. Of course, we've gone a long way from there, and today, I think you don't even need to do this FISH. You can just use the D5F3 ALK1 antibody, and you image it on your routine immunohistochemistry lab. You don't even need a fluorescence microscope. You can do the same for Ross. Of course, there are some situations in which perhaps you do need to do a FISH, at least in the ALK situation. And of course, we use FISH for so many other things in the lab. So a lab has a FISH facility, then much of this can be done there, which again, I remind everybody, is molecular imaging, right? Now everybody's using this, at least I hope they are using this, because when you have a tumor like you have on the left-hand side, which has come from the bone, and you don't see as many giant cells as you expect to see, and your problem is this a real giant cell tumor of bone, or is this a portion of a aneurysmal bone cyst perhaps, which is showing giant cells and so on. Because today, of course, we get small biopsies, many of them needle core biopsies. Today, all you need to do is throw at it this mutation-specific antibody, one of the histones that is genes that is mutated, and you know for certain that this is a giant cell tumor of bone. Why? Because there is a mutation, and we have constructed on I mean that the world now has available to us a mutation-specific antibody. So I think I have made it very clear that immunohistochemistry is a molecular test that is fully integrated into a routine histopathology lab. I have answered the question, what is a molecular test? So also is a CISH and SISH, okay? Chromogenic in situ hybridization, or silver-based techniques for in situ hybridization. And when I say we, I'm talking on behalf of all surgical pathologists, histopathologists, if you wish to recognize us as. We are all molecular pathologists because of the central dogma. And what is that? DNA makes RNA, makes protein. And all of them, all of the above can be imaged in a surgical pathology lab, albeit that protein is the one that is imaged most often. So I can hear some people in the audience probably thinking, but what about molecular profiling? And I say, yeah, what about molecular profiling? All right, let's take breast cancer, which is one of the ones that are profiled most commonly, right? You have MammaPrint, you have Oncotype DX. One is a 70 gene signature, the other one is a 21 gene signature on gene expression profiling. I've just highlighted how much it costs, okay? And why do I say back to the future? Because what do these genes actually represent? Whether it's a 70 gene, 21 gene, and there are half a dozen other molecular signatures. You know what they actually represent? They represent ER, PR, HER2 new status, and proliferative factors. And have we not been doing ER, PR, HER2, and Ki67 for years? And I think that's now being recognized as IHC before. And you think, and I'm sure that people say, oh, but that's a very crude way of doing, something that can be so precisely done by this 21 gene signature and mammoprint. And I just like to remind you that when you do this, say, Oncotype DX, which I'm more familiar with, not that I do it, but so many patients who have it done, you have, those that are good prognostic, sort of, you have a good prognostic group, you have a poor prognostic group, and what do you have? You have something in between. All right, so let's not bash immunohistochemistry and talk about, oh, it's a crude way of deciding whether, you have a good or a bad, or to decide whether we should give chemotherapy in these early estrogen receptor breast cancers or not. And this is exactly what is being said by no less a person than Georges Reichfilio, who is considered one of the doyens of molecular pathology of breast cancer. And this is what he wrote, and he hasn't changed his opinion since then, and that is molecular profiling currently offers no more than tumor morphology and basic immunohistochemistry, right? And really, what he says is true. It constitutes a reproducible and quantitative, that is your Oncotype DX analysis of tumor cell proliferation. So if we as histopathologists could get our act together and quantify tumor proliferation by Ki67 or MIB1 or any other marker, well, we've cracked the jackpot. We don't need the 21 gene signature or the 70 gene signature or what have you. And as far as other cancer prognoses markers are considered, I just like to read this because I find it very funny. And that is on, which was written, okay, maybe in 2005, and we are maybe 17 years on, but just ask yourselves if you really find anything to contradict this statement. And that says that on close scrutiny in 5 of the 7 largest studies on cancer prognosis, this technology, and it means that is GEP, performs no better than flipping a coin. And the other 2 studies barely beat horoscopes. Okay, maybe I'm biased, but just dip into your heart and see whether this is not a little bit true. So how do I conclude about molecular profiling? Well, it does provide information on expressed genes. There's no doubt about that. But you have to ask, but at what cost? Okay? And protein profiles of these genes are being incorporated into immunohistochemistry profiles. And I've shown you some of these. Then, of course, therefore, the wheel comes full circle. But I did mention before that here you are, liquid biopsies for solid tumors. Oh, they're biopsies, for circulating, for MRD, for liquid tumors, etc., has been going on for a long time. And I don't think that a surgical pathologist can even talk about competing in that domain because it doesn't actually pertain to us at all. But these are solid tumors. And we all know, of course, that, circulating DNA gives you a much more comprehensive molecular representation of the tumor and all of its metastasis, including different parts of the tumor, because every part of the tumor is not the same as every other part because of this clonal heterogeneity. But I think claims for liquid biopsies have now gone far beyond what really people can use them for. And one of them is early detection. Now, just because I find an EGFR mutation in a patient, maybe somebody who's been smoking for a number of years, there is an EGFR mutation, does it mean that the patient has a dangerous tumor? And where and how would we start looking for this mutation? And I think a lot of these early detection molecular tests are a case of tumor somewhere, but where is that tumor? Anyway, I think liquid biopsies are here to stay without a doubt. And I think this wonderful paper about how to make to decide whether or not to give adjuvant therapy in colon cancer, which was published recently from Australia, I think is a great paper, which really emphasizes, apart from the usual lung cancer and the mutations, the resistance mutations. I think that's a very good paper for monitoring uh, disease and for looking for minimal residual disease in solid tumors. So I will admit that there is a niche market for molecular diagnosis. Okay, of course, clonality assessment in lymphoid tumors on FFPs, it's now being done by flow cytometry, of course, can be done. Diagnostic and classification MRD in liquid tumors, and I don't think surgical pathologists have got any say in that matter. And I would say mutation analysis for some targeted therapies where we don't yet have IHC or FISH or ISH available yet. Okay, yeah, I've already mentioned genetic profiling of circulating cancer cells, and of course, estimation of tumor mutation burden, which is something that's a recent addition to this whole armamentarium for targeted therapy. And finally, it's a fertile hunting ground for peddlers of omics. And I hope I'm not going to, I'm not stepping on the toes of Dr. Hegle, who's going to speak after me. I believe that there is so much of this omics or big data science that is being sold to desperate patients who really hope against hope. Finally, let me say that this was what one Rosai said a long time ago, and I think it is still true today. There is no technique in all of medicine that provides so much information so quickly and for such little cost as the H&E technique, right? In our colloquial Hindustani, it is Sundar, Sasta, and Tikau. And I will give you an example. Every pathologist in the audience will recognize this kidney tumor as a clear cell carcinoma of the kidney. Just doing this, and maybe in today's world, adding a CA9 diagnostic immunohistochemistry, what does that tell you? It tells you that this is a clear cell renal cell carcinoma. Of course, you can grade it. It tells you by just looking at this, that there is a potential for lymph node, lung, and bone metastases. Rare regression of metastasis with removal of the primary. It tells you where the abnormality is in the molecular makeup of this tumor. It also predicts response to anti-angiogenic agents, mTOR inhibitors, and TKIs. And folks, all for the price of a histopathology report. Okay? I beg any molecular pathologist who is not also doing histopathology to be able to trump that. Okay? Now, I think I've told you that surgical pathology achieves a lot. It can do all of this. It also directs ancillary testing for molecular imaging. Don't forget that it is molecular imaging. So how does it do it? Well, it does it because surgical pathology is about synthesis, seeing the whole picture. Most other tools are reductionist, missing the forest for the trees. And the kind of molecular imaging that is possible in surgical pathology, histopathology, is that you can actually see where this is happening within this tumor, or maybe multiple different areas of this tumor. So I agree entirely with Elliot. Where is the knowledge lost in information and the wisdom lost in knowledge? I think surgical pathology is a lot, not just about knowledge and information, it is about wisdom. And over the years, I've seen that this is true. Surgical pathology has changed. Even I know that. I mean, I certainly don't belong to Rudolf Virchow's generation, although I might look decrepit. But surgical pathology has moved from gross to microscopic, the H&E, which everybody decries as being old-fashioned, etc., to immunohistochemistry. We also do a lot of fish and ish. And I'm looking forward to the day when quantum dot imaging will arrive, where we can look at a myriad of proteins by fluorescence under a fluorescence microscope, except that we will not be eyeballing this, but a computer will be, which is exactly what GEP is doing, right? If those bioinformatics is going is going forward in leaps and bounds, but a lot of it will also involve surgical pathology on FFPE. And I think that this is the way forward. So, ladies and gentlemen, I think the reports of the death of surgical pathology are greatly exaggerated. This is something that Mark Twain said when he read an obituary about himself in the newspaper, of course, when he was very much alive. So, with that, I will just end by saying that in a time of drastic change, it is the learners who inherit the future. The learned, those who think that they are learned, find themselves equipped to live in a world which no longer exists. I think I've made the point that surgical pathology has endured and evolved to meet many challenges. And I think that molecular imaging has redefined the meaning of molecular pathology. So, ladies and gentlemen, thank you very much. Thank you, Neeraj, for having invited me to this meeting. And I hope I've contributed something to the philosophy of what is molecular pathology. Thank you.
Thank you, madam. Thank you for keeping it very simple. We are
That is fine. I'm happy to. You're welcome. Thank you, Neil.
Thank you, madam.
Hi, am I audible? Yeah. It's my privilege to introduce the next talk and the speaker, as both the topic of the talk and the speaker are close to my heart. Molecular biology started by just analyzing a small region of a gene with the help of the PCR. Now we are in the era wherein we are able to analyze all the genes by utilizing next generation sequencing. But with that, we are also generating a huge amount of data, which is in gigabytes. And then it gives us a lot of information. So our next topic is integrating large-scale omics information for discovery and clinical practice. And who can be better than Dr. Madhuri Hegde to deliver this session? She is not only the adjunct professor of Department of Human Genetics at Emory University School of Medicine, USA. She is one of the core members of American College of Medical Genetics. She has more than 2,000 international publications under her name. So now, without much ado, I will ask the organizer to begin the session.
Good morning and greetings from Atlanta, US. I want to thank the organizers for this invitation to speak in the meeting today. I apologize I cannot be in person there, so hence this virtual presentation. I hope everyone is staying safe, and we are just sort of coming out of this COVID era, so it is a good time to start looking at really what are the technologies that have technological advances rather that have happened in the past 3 to 4 years and how we are bringing them to clinic. And that's why my talk is titled accordingly, where to integrate omics-based information for discovery and clinical practice. But before we get into the full integration of how we are going to go about it, and I intend to show some case examples too, it'll be good to kind of just spend a few minutes talking about the genomic milestones, because this has become the most important technology we are using in the clinical laboratories now. And there are so many advances that have happened. It's amazing to look at this timeline, starting with 1975, where we were using the southern blot, and today where we are using these high throughput technologies for sequencing. And those advances continue to happen, where now different chemistries are coming on the market, moving away from the standard and the most used technology, which is the instrumentation using NovaSeq as your primary method. But as a physician, I think it's really important for all of us to know which test to order, because it does get confusing when you're looking at the different technologies that are available out there. And this is a figure from one of my publications in anatomic pathology, where the editors had asked me to compare side by side the technological advances and how they would apply in oncology and rare disease diagnosis. So on the left-hand side, what you see is in rare disease diagnosis, where whole genome sequencing is really the most important method now, which allows us to detect the entire spectrum of different pathogenic variants, from copy number variation to point mutations to deep intronic mutations to inversions, deletions, duplications. And in rare disease, especially, this comprehensive methodology is very important. But you flip that when you come to oncology, where now we are using NGS for targeted mutation detection, such as the clinically actionable mutations at the bottom here. And a good example is the KRAS and the NRAS mutations, which are now routinely ordered for lung cancer and some other types of cancer. So this flip of technology is important to understand, because that's what drives how we design our tests, how we validate our clinical tests, and how we offer them depending on the patient's clinical presentation. Now, if we take the same concept and take it to another level, which is comparing side by side of what would happen in the laboratory for rare disease and oncology, is what I have shown here is the starting with a germline sample in rare disease to going down to mutation detection and then essentially disease management. At times, especially in inherited cancer, the histopathological information and the clinical information has also to be integrated into the patient folder, because that becomes important for the additional family members who are going to receive the testing as well. Whereas on the left-hand side, you will see for cancer, the approach is a little different, where you really have to integrate a lot of different methodologies and bring it all together for therapeutic intervention and disease management. And then on the side, you're constantly looking at clonal evolution and metastasis. For the purposes of the presentation today, I'm going to focus on rare diseases, but I think it can, the methodologies described here on this slide can have a broad application across pathology. So when we talk of omics and moving away from genomics to most omics-based technologies, an idea to present here is what would a clinical laboratory look like? And what you see here is the sort of the complete setup we have done in our laboratory. I come from academia, was starting with my training at Baylor, then Emory, and now eventually at Perkin-Elmer. So I've sort of bridged both sides of the world, let's say, from academia to industry, and I still continue my academic appointments. But I've really learned a lot from being in this sort of the bridge setting, if you can call it, where you are looking at a laboratory solution which has a multi-omics approach, starting with looking at, starting with just basics of newborn screening and then going down to transcriptomics, proteomics, microbiome, methylomics. But then what are the key considerations? And this is very important, right? We hear a lot about robotics and artificial intelligence. One of the most important things here to know is variant classification, sequence variant classification is a skill, an art, and a science. And what I'm showing you all here is the different laboratories we have globally. But the point of showing you this slide is that we are able to gather data from all different types of populations, integrate in our database, which allows us to make our interpretation very powerful. So sitting in the US here, in the US, no longer the population is homogeneous. It is a heterogeneous population. People from all over the world live here. So any patient sequence in the US, I should be able to interpret the sequence variant. And that was a basic premise of us having these global laboratories, which helps us. The second thing is whether you're doing oncology, infectious diseases, or inherited diseases, flexibility of sample type is very important. And what I have personally learned is a tremendous amount from newborn screening programs where dried blood spots can be used across the board. Today, we can do dried whole genome sequencing from dried blood spot cards and look at the microbiome and the virome of that individual too. So we have made tremendous advances in our ability to use dried blood spot cards. We are also using dried blood spot cards globally so that we can get the samples globally. It's easy to transport them. The next one is how to improve the efficiency in a laboratory where you can go from DNA extraction and straight to the sequencer in a rapid format and then do interpretation of the sequence variants. So what I've shown here is 4 things. One is your ability to interpret the data, different sample types, optimizing your laboratory operations, and then the last one is optimizing your interpretation engine to allow you to do rapid interpretation. These 4 components are critical for translating or transforming a laboratory in an omics-based application for patient care. So let's spend a few minutes on the power of whole genome sequencing, and you will see that I've made that transition on this slide from whole genome to genome. Of course, now we know that that last 8% of the genome which was not sequenced, that sequencing is complete now. But we are only now starting to push that into clinical practice. Very often when I give presentations, a question is asked that is whole genome really beyond exome sequencing? And what I've tried to show you on this slide is the difference between the exome and genome sequencing. Essentially, where genome is allowing you to capture the entire genomic sequence of the individual, now we can do PCR-free sequencing, so it is unbiased and more uniform. You're sequencing the entire full genomic sequence of the gene itself, so you can detect deep intronic regions. We can report pharmacogenetic alleles. Many of these alleles sit in repeat regions, and then polygenic risk scores, which is the newest and the greatest application that is coming into clinical practice. And then the last 4 items, which are really focused on moving away from a microarray to the sequencing-based approach to detect copy number variation, repeat disorders, allows you to detect uniparental disomy and regions of homozygosity. So this is a significant shift from exome to genome sequencing, and I'll show you some examples. But one of the things we have to remember that when you're doing genome sequencing and you start detecting these deep intronic changes, you have to then bring in this omics-based technologies to prove that that deep intronic change is actually causative of the disease or the disorder in the patient, and that requires that integration of technologies. So just looking at genome sequencing, what we have done in our laboratory is fully automated the pipeline, starting from sample type to clinical reporting and essentially writing our own software. You know, coming from academia, I have always had this approach of doing very comprehensive analysis. And I was able to write a new program when I came to PerkinElmer, which we call ODIN. And ODIN really stands for Ordered Data Interpretation Network. So what you see here is all the automation tools and then the data eventually flowing into analysis by a board certified director. Just want to quickly touch base on the power of genome sequencing at 30 or 40x compared to the microarrays. And I think this is one of the confusions. I know that in India now microarrays for inherited diseases are quite often ordered, but there's a fundamental shift in the depth of what you get from whole genome. And even at a 5x genome is the higher density than the highest microarray, which is a million probe array or Affymetrix array. So what you look on this slide is really the low pass genome at 5x gives you better coverage, more uniform coverage across the genome compared to a microarray, because in microarray you are just targeting locations and you are going to have gaps. The depth and the uniformity also allows you a higher resolution. So compared to the microarray, you are getting a better resolution doing a 5x genome. With whole genome sequencing, now we are able to report repeat disorders, and here's a list of repeat disorders we can now interpret and report on a genome. We use an approach called rule out versus rule in. So what we can do today is that we can rule out repeat disorders. When we see two heterozygous alleles in the normal range, then you have ruled out. But if we see only one allele, which could be homozygous, or there is an expansion happening, we cannot rule in, and that would require confirmatory testing if the clinical presentation of the patient matches with any of those genes. Another exciting advance is ability to report genes with pseudogenes. And here I have shown an example of SMA, where we can now report SMA and the copy number of SMN2. As you all know, there is now therapeutic advances for SMA. And in some approaches, the increase in expression of SMN2 is important. And that's why you have to know the copy number of SMN2. We are able to report both SMN1 and SMN2 copy number using genome sequencing now. And last but not the least is the pharmacogenetic alleles. I think pharmacogenomics has sort of not received the attention it deserves. Very important, we know there are many hospital-based deaths based on the reaction of the individual to the drugs they are exposed to. And in the US, at least, FDA has limited to reporting only those risk alleles which fall, pharmacogenetic alleles which fall in the CPIC1A list. So what you see here is what we report from our laboratory. And then the next one which is coming is the polygenic risk scores. We are still not reporting the risk scores from our genomes, but that is the next obvious step, and we are kind of moving towards it very fast. So I think having shown you the four fundamental elements such as the global presence, the global variant database assimilation, sample type, automation, and the AI-based approaches to software, it's important to show you that does it really result in increase in diagnostic yield. So what you see here is a side-by-side comparison of microarray, exome, and genome sequencing. And you can see that we go from a 15% diagnostic yield to close to 50%. Now, if I start breaking this data down further into diagnostic yield across pediatric and adult cases. So we have done now close to 5,000 cases in our laboratory, but I've just chosen 386 cases to show you the diagnostic yield. And what you can see here is our yield is close to 45%, but actually it could be significantly higher if we are able to resolve the variants of unknown significance. And this is again where the omics-based technologies are very important. Now, if we just split that again and look at it a little differently from pediatric and adult cohort, you can see that our diagnostic yield in the pediatric cohort is higher, but again, that box of 30% or so of variants of uncertain significance is very important, because I can tell you in many cases, we know that this variant is possibly the diagnosis. As a physician, it is frustrating for you when you see a clinical report which says variant of unknown significance. So how do we go about resolving these variants using these omics-based technologies? One of the things which a laboratory can do is obviously trios, especially for inherited conditions. And you can see there's a slight increase in the diagnostic yield when you do trios. But going back to this pie chart, you can still see that the variants of uncertain or unknown significance are still a problem for a clinical laboratory. In our lab, we have been doing healthy genomes for about 4 years now, and I've chosen 110 cases. We are actually writing our manuscripts right now, so that's why I'm not showing you the full data. But what you see here is all the different types of variants we have found from healthy genomes. These are individuals who have chosen to do their genomes, wanting to know if they have a possibility of an inherited condition which has not yet manifested. So you see, we have seen everything from hereditary cancer syndromes to neurodegeneration, skeletal dysplasias. Now we also report carrier status. This really tells you the power of doing genome sequencing in adults as well. And as I mentioned, when you do whole genome, we are running our genomes at 40x, but the 5x genome, which essentially replaces the microarray, if we call it the CN genome, and even in that, our diagnostic yield is about 17%. It could go up to 40% if we are able to get the parental samples in. But we have detected everything from aneuploidy to microdeletions and duplications, intragenic variations, UPD, and unbalanced translocations. So with that background, let's jump into the last 15 minutes or so of my talk. I'm going to spend on showing you examples of how we are moving from genomics to omics-based applications. So the first case here is a 5-year-old male with suspected lysosomal storage disease, MPS2, which is also known as Hunter syndrome. The biochemical diagnosis was done before the genomic diagnosis was done, and now you can put the biochemical methods in this bucket of omics-based technologies, which already showed that there was a reduction in the iduronate sulfatase level. Now, they had already done sequencing of the gene, they could not, of the IDS gene, but they could not find a variant. So obviously there was something going on which was deep intronic. Now, could be two approaches, right? Why don't we just sequence the entire IDS gene, and that would have meant a significant expense to design an assay, then sequence, and it would have wasted a lot of time. Instead, in this case, they went and ordered genome sequencing. We looked at the IDS gene, it was a minus 72 A to G change. The family pursued this further, and we were able to show that this is, because this is X-linked, it was a de novo change. So that really tells you this opposite application going from biochemical to genomics. Now let's look at RNA sequencing. This is a case of Duchenne muscular dystrophy. Again, an 11-year-old male, toe walking, delayed motor development, and they had a clinical suspicion of Becker muscular dystrophy, and an increased CK was already noted. Again, a creatine kinase, you put this in the box of omics-based approaches. They had done MLPA, they had done sequencing, it was negative. They went on to order genome sequencing, and we found a minus 10 variant. Now, it is not enough to just find a minus 10 variant and say just blindly that, yes, this is the pathogenic change. We were able to do RNA sequencing and show reduced expression, a frame shift, displacing the splice site, and therefore reclassified the variant as likely pathogenic. The next case is again a omics-based supporting method using the method of enzyme-based assays. And this is for GAA. And what you see here is, we all know that GAA is responsible for Pompe disease. Pompe disease is neonatal to adult onset. In adults, it's muscle weakness, and therefore takes a long time for diagnosis. We had found a missense change. Enzyme analysis was performed. Now, in this case, it is genomics to enzyme, where we did the sequencing for GAA gene, we found the missense change, and then we did the enzyme to prove that this is pathogenic change, and therefore the diagnosis being Pompe disease. The next example is a really difficult one. This is the gene ABCD, which causes X-linked adrenoleukodystrophy. Now, this gene is very difficult to sequence because it has a homologous sequence of the pseudogene, which has got 100% homology with the active sequence. Only one or two nucleotides are different. So in this case, for newborn screening, the approach is to do the biochemical profile where the biochemical profile was abnormal. Then they went and sequenced, and we were able to find the missense change and in the active ABCD1 gene and classify as likely pathogenic. This next one is RNA sequencing, dysferlin, which causes limb-girdle muscular dystrophy or dysferlinopathy. And we were able to find a single pathogenic variant which was detected by sequencing, but we were able to find a duplication of exons 10 to 35 by RNA-seq, which we then went and confirmed by microarray, and you can see this duplication nicely demonstrated on this picture shown from the microarray. So, these are disorders where omics such as enzyme-based analysis, RNA sequencing can be integrated with just plain DNA sequencing. But the question is, there are still many disorders which we cannot detect. And what are we going to do about that? So there are many new approaches, as I mentioned at the very start of my presentation, that there are new approaches coming to sequencing or looking at the nucleotides. And one of them being digital genome imaging. Long read is still coming. There are many publications now. We are also trying to bring long read in our laboratory. And then different sequencing chemistries which are becoming available. So let's look at one disorder, FSHD1, a very complex disorder. FSHD1 is the third most common muscular dystrophy. The incidence is about 1 in 10,000 to 1 in 25,000. So if you think of the global population, it is really not that rare. Now, 95% of the cases are FSHD1 and about 5% FSHD2, which is diagenic inheritance. The difficult part of diagnosis of FSHD, which was usually done using pulse field electrophoresis, is the basic biology of the disease itself. This results in a D4Z4 contraction, and you're going from a normal repeat size to a contraction of the D4Z4 repeats. But it is further complicated by the background on which allele it sits on. So the D4Z4 repeats on 4q35, and you're talking of which allele it maps to, the 4qa and the 4qb, with the presence on 10qa. We do not have time to go into the sort of the basic genetics of it, but essentially we are looking for contraction, which is not easy to do. So the optical genome mapping is a phenomenal technology which you can use. Essentially what we do is, because you need high molecular weight DNA, you extract the high molecular weight DNA, label them at specific sequences, run them on the machine, which is a Sapphire, and then you looked at the linearized DNA to look for the contraction. We have done many cases now. We have just submitted a book chapter to the current protocols in human genetics, and we are right now working on the publication. We have resolved many cases faster and more precise compared to doing a Southern blot analysis. So I'm going to finish this off by presenting to you. We looked at FSHD, which is a complex disorder. We looked at intronic changes, or changes which are just in the splice site region plus minus 100 base pairs. But I've been talking of genome sequencing, which means you're doing deep genome intronic sequencing. And how do you go about resolving those? So this first case is about dysferlinopathy. And what I want to show you, this is a homozygous pathogenic change, and we call it pathogenic. It is a minus 824 base pairs into the intron 50. This was a great collaboration with the Massachusetts Medical School. And this is actually a very most common way, pathogenic variant we find in the Indian population aside from a missense change. We were able to do RNA sequencing and demonstrate. This paper is actually published. You will see this publication at the bottom of this slide here. We were able to show that with RNA studies, with parental studies, that this variant is actually pathogenic. And now what we have been able to do is tag this variant in gene panels. So we have added a bait in our smaller gene panels, which will also detect this variant in the Indian population. The next case is a 13-year-old female with neurofibromatosis. And what you see here is neurofibromatosis is autosomal dominant. And we found a variant which is about 1600 base pairs into the intron. Fortunately, this variant was already published by RNA sequencing, and we were able to reclassify this variant after the publication came out as pathogenic. And you will see here that it results in an aberrant inclusion of an out-of-frame cryptic exon, and that was demonstrated by RNA sequencing. Again, this is a case of Duchenne muscular dystrophy, and you'll see many neuromuscular disorders on this presentation is simply because my research interest is in neuromuscular disorders. So this case is about shows a variant which is 36 kb into the intron. Duchenne muscular dystrophy is the largest gene in the human genome, about 2.4 megabases. It is largest gene by size, not by number of exons. It has got 79 exons. The Titin gene and a couple of other genes have 300 plus exons. But what we were able to show by RNA sequencing is that this deep intronic variant causes an insertion of 149 bases into the exon, thereby causing a frame shift by abolishing the splice site, and we were able to call it pathogenic. Again, we have to make sure that when we find this deep intronic changes, we go and bait them or tag them and add them to our smaller gene panel libraries so we do not miss these variants. And then this is the last case with Sandoff's disease, a 4-year-old male with clinical suspicion. This was a case in India actually. Biochemical results showed Hex B reduced and Hex A and B reduced levels. Typical clinical presentation of cherry red spot and neuroregression. Nothing was found by by exome sequencing and by microarray, and then they were able to order genome sequencing, and we found this deep intronic variant, 985 bases into the intron. Again, doing RNA sequencing, we were able to reclassify this variant as pathogenic. So I'm going to finish off my presentation with these cases. I hope I have demonstrated to you the utility of enzyme testing, RNA sequencing, and different methodologies which really support the omics-based methods, which support the genomics-based methods using sequencing and thereby doing clinical interpretation and diagnosis. But one thing which happens very often is still reporting of variants of uncertain significance. How can we go about beyond omics-based technologies now? And this is where you as physicians and the collaboration between the physician and a laboratory scientist becomes very important. So when I'm going to use the example of an autosomal recessive condition where we report one pathogenic and one variant of unknown significance. But you as a clinician know based on the clinical presentation, this is very likely the diagnosis. And very often we receive calls, can you classify it because the clinical presentation fits this gene? Unfortunately, we cannot because we do not have the expression data of the gene itself. But if based on the clinical diagnosis, an effort is made and where there is a treatment available to go ahead, as epilepsy is a great example now where there is treatment can be started, and based on that in vivo physiological function, that response, which really acts as a functional assay, If that information is given back to us, if you see patient improvement, then we can work on reclassifying that variant. I got together with Joseph Shen at UCLA and Clara van der Beek in Amsterdam, who's really known for this work. And we have published this treatment-based criteria for reclassification of variants. And we are working on a new consortium to start this effort to create a database of variants which are classified as uncertain variants, but then we collect the data to from the physicians, which is the in vivo data, to reclassify the variants. So this effort is ongoing. If anyone in the audience is interested in joining this effort, please email me. So just in summary, I think the NGS-based technologies have helped us identify many variants, intronic and intragenic variants. But the classification of these variants is important. NGS-based methodologies are used both in oncology and inherited diseases. And how we go about the classification using these omics-based technologies for discovery and for clinical diagnosis is very important. The Truth VC initiative, the collaboration I mentioned just now, is to use the in vivo information to inform variant classification. We have just started this initiative. Please feel free to email me if you have any such cases which will be of interest.
You can see the details. I'm not going to go through everything on this slide because we're running about 30 minutes late, and I know you all want to have your cup of coffee. But what you can see here, the most important point, is that the classification is based on genetics, and essentially if someone is 46XY with DSD due to various causes including gonadal development, gonadal function, or other syndromic forms of DSD, and the other side of the coin are those who've got a 46XX karyotype and who have various degrees of virilization that may be due to enzyme defects or again may be due to problems of development of the ovary where a testes has actually formed. And many of these conditions fall into the category of rare diseases. But in this definition, defined by the consensus statement, this consortium, it does not include simple hypospadias or cryptorchidism, which I think is an error. I think it should be included, but formally it's not included within DSDs. So what I have to say is, what do we actually do? So I'm a speaker. I'm not coming from a diagnostic lab. I work in a research lab. I have to make that very, very clear to you. So what we do, you can see from the top here, is that we analyze individuals who've got DSD. We've done over 1,000 exomes. We've done about 150 genomes. We're looking to see if, in that analysis, we can identify new genes that are causing DSD. And then we do various functional studies. We do cellular remodeling. And all of this is aimed to understand a very precise research point, which is mammalian sex determination. So we're using the analysis of patients to try and understand a very fundamental aspect of developmental biology, what determines if a gonad is to be a testes or an ovary. And obviously, this information can then be translated back to the clinic in terms of new genes that are causing DSD. And also, our research over the years has shown that many genes that cause DSD also cause infertility with no evidence of DSD. So there's a lot of information that's translated back to the clinic. And also, this genomic analysis, we do it in a lab. It's a research analysis. It's not diagnostic. But for anyone that's interested to do this, we do it free of charge. It doesn't cost anybody any money to send it, and we will do it. But it is not a diagnostic result. It is a research result. So this is a very interesting slide because we've been doing this for some time. So as you can see here, around about the year 2000, the first human genome cost about 2 billion euros. Since then, the price has obviously come down. But in 2009, I did my first exome, and it cost 12,000 euros. Yeah, I can see some people shocked by that. But we had a little bit of money. We did 2 or 3 exomes, and we were really disappointed by the result. We got no genes that were involved in the phenotype. Since then, the prices have come down. And now in the lab, we can do a human genome sequence, and this includes all data analysis. And again, it's not diagnostic, it's research. It costs only 500 euros for an exome, a complete analysis, all data analysis. It's only 200 euros. And that's commercially. So at the Institut Pasteur, they will not consider doing any human genome analysis in-house because it's too expensive. It's actually cheaper for us to use a private company. And also, this is interesting. It's developing really fast. And I'm going to tell you a very short story, which is with Professor Rina Das here. A few years ago, I think it was 2015, 2016, we had a dinner in Rina's house. And there was a big discussion about exome sequencing, genome sequencing. And Rina, together with Anu Bishambu, who's at the back here, we all said that this is going to arrive in India. We'd all be doing it very soon. And there were other people at the table who said, no, it's never going to arrive. It's too difficult. It's too complicated. It costs too much. And now coming to this meeting, I see that everybody is doing exome sequencing. It's everywhere. So that's interesting because you've heard this morning about robotics. You've heard about artificial intelligence. So I think another 5 or 6 years from now, you'll be doing it as well. All of these technologies will arrive, so you have to prepare yourselves for it. Don't say it's too difficult, it's too complex, or it's too expensive. All of that will disappear. You will be doing it. So whenever I was young, I never thought I'd be doing human genome sequencing at all. Okay, so back to DSD again. So a little bit again about the phenotypes. We're interested in errors of sex determination, which are extremely rare diseases. They're indicated at the top here. But one of the problems whenever you're doing any of this type of work are phenocopies. So for example, if you've got an XY karyotype, but you're female, that could be caused by errors of sex determination, but also problems of the production of androgens from the testes, or you could be insensitive to androgens. So phenocopies are really difficult. So it's difficult to diagnose in the clinic. So for example, here we've got 46XY newborn. The genitalia, The external genitalia may be female or maybe an undervirilized male. So traditionally what happened was you do hormonal data, endocrine results be given, but that's also quite tricky because with a newborn or very young individuals, the hormonal data is not that informative. You'd also try and have an idea through visualization about what's happening in the internal genitalia, i.e. is a testis present or not, is there a uterus, and that might give you some idea of the underlying pathology. But more and more, this is driven completely by genomic data. So the first line of analysis is usually now genomics. So this is a summary, for those of you who are interested, of the different types of DSD that I mentioned at the very beginning, and as of today, what is the diagnostic yield that we've got. So for the 46XY DSD, in terms of genetic causes, so unexplained is in blue, in red we've got a genetic diagnosis. About half of those that have got a problem of sex determination, a very early gonadal development, we can explain the phenotype. But as the phenotypes start to get milder, and in particular, the most common phenotypes, which is simple hypospadias or cryptorchidism, in the vast majority of cases, we do not know what is the genetic cause. The other side of the coin is 46XY DSD, and this is kind of inverse. So for those cases who have got, for example, congenital adrenal hyperplasia, that's one of the most common causes of 46XX DSD, we can understand what's causing the phenotype. And there's genetic analysis that's available for that. But for those individuals who've got DSD due to disorders of gonadal development, that's XX males, for example, the vast majority of these cases are unexplained. So now if I do a quick summary of the diagnostic yields that have resulted from both exome or targeted panels for DSD, we can see that starting from about 2015 up until the present day, the diagnostic yield has been slowly increasing. One of the reasons for that is that our work and the work of others, we're identifying about 1 or 2 new genes causing DSD every year. So obviously in the old panels, they did not cover these new genes. And obviously as new genes keep arriving, these targeted panels become out of date. So for DSD in particular, and this applies to many other pathologies, we would always recommend doing an exome, so you can then go back a few years from now and reanalyze the data, because new genes are always appearing. So now you can see in the last 2 studies that we've been involved in this slide, we're around about 50% of the cases. And as I said at the bottom here, there are biases in this because most of the published studies are using panels and not exome. There's also recruitment biases, which includes, as I mentioned earlier, the 46XY undervirilized male, including hypospadias and cryptorchidism, where we know very little about the genetics involved. So if more of these cases are included in studies, the diagnostic yield is reduced. And there's also some evidence of regional or ancestry differences in particular genes and variants that cause DSD. So in terms of the genetics of DSD, there are a lot of challenges. And I don't have the time to go through all of these today, but I'm going to talk a bit about the first 2 here, which is trying to understand the genotype-phenotype relationship and also doing predictions of genotype outcomes, as well as determining new genes and variants involved in DSD. So if we go to the first one, trying to understand the genotype-phenotype relationship, it's extremely difficult. And I'm going to talk about one particular case, which is NR5A1, which is also known as steroidogenic factor 1. It's one of the most common genetic causes of DSD in the human. And the data is summarized in this slide. So on the left-hand side, you've got the various phenotypes. You've got XY DSD with a range of phenotypes, XY DSD plus spleen anomalies, XX female infertility, XX individuals who've developed a testes, and also XY individuals who are infertile, all due to variants within the gene, and sometimes the same variant, so variants that are shared are indicated in red. So with the same variant, you can have a wide possible spectrum of phenotypes. And for the moment, we simply can't explain that. In terms of genetic counseling, we can give no answer as to why a particular variant is associated with a particular phenotype. And even within families, we've got some examples here, you can see a wide range of phenotypes between affected SIBs or other members of the family. So the first speaker in this session was talking about the use of, or the lack of use perhaps, of omics in the clinic and also in a diagnostic lab. So now I'm just going to mention, just for our lab, what has omics actually changed in the past few years. Okay, so and this is only looking at the exome, what has it done for us? So this is a summary of what we've been doing at the Pasteur Institute. So the first thing I want to say is that since we started doing this, we've identified new genes that cause DSD. And there's a list of them here, and this is just from our lab. If we did not do exome, we would never have identified these genes. It didn't come through mouse studies, didn't come through anything else, it's from only through exome. The second thing is that through exome, we've identified atypical clinical presentations. So someone sent a sample to the lab, there's a clinical description, we did an exome, and found, hey, we found a variant that we think is pathogenic, but your presentation you described doesn't really fit it. But then we do further studies and we can show that that variant is actually pathogenic. And then what's really important, I say to you in this room, it's really important to publish that, get that information out so other people can see it and know about these atypical clinical presentations. And associated with that is expanding the phenotypic spectrum. So, for example, the two genes that are shown here, NR5A1, WT1, were known to cause XY DSD, but we were able to show through exome sequencing that they also caused XX DSD. And we would never have known that if we hadn't done the exome sequencing. And finally, in terms of DSD, we've got emerging evidence that I'm not going to go into today that in some cases, more than one gene is actually involved. And that has come through exome sequencing. So the other point I just want to talk about briefly is determining the genes and variants that may be involved in different DSD phenotypes. So I've just said that establishing a genetic cause is really difficult for the mild DSD phenotypes. So if we look at XY complete gonadal dysgenesis, which is the most severe XY phenotype, it's a lack of testes determination, it's essentially monogenic, but there are many genetic causes that have been identified. The ones that are indicated in blue are the ones that we've identified in the lab at Pasteur. But whenever we move towards hypospadias and cryptorchidism, very few genetic causes have been identified because this is well known, it's been published that there are other factors that may be involved, environmental factors, but it is known that there is a very strong genetic influence. And I think one of the reasons why we know so little about the genetics is that familial cases of hypospadias and cryptorchidism are underreported, but they exist. So for example, there's a paper here published recently, well published this year actually, in the Orphanet Journal of Rare Diseases, where just in a very small family, they've been able to identify candidate genes for hypospadias cryptorchidism. And also, we've got a paper that's in press where we have identified candidate genes in monozygotic twins where one twin had hypospadias, the other did not, and we were able to identify through exome sequencing very subtle changes in only two genes in the exome that were different between these two individuals that are candidates for hypospadias or cryptorchidism. So please, if you have information about hypospadias or cryptorchidisms, really try to see if there's a family history associated with that. It would be really useful to go further for this. So I've talked about the genetics, I've talked about these variants, I've talked about how difficult it is. Now I want to talk a little bit about functional studies and in particular about how we can try to model what's going on here. So the first thing to say is that we are beginning to identify regions outside the exome, so we're moving towards the genome, and about 10% of cases of both XY and XX DSD are due to variants in regulatory elements. So we know they exist, and also this is another family which is, this happens to be from the Mumbai region, where we've got XY complete or partial gonadal dysgenesis, And this family is very unusual because the transmission of the phenotype, which we can show here, is actually following the Y chromosome, which is it was the first time I've ever seen this. So it's something in the Y chromosome. The only thing in the Y chromosome we know that's involved in DSD is the testes determining gene SRY. So for these individuals, we did an exome sequencing. The exome sequencing came up negative. The SRY gene was negative, but we knew it was something in the Y chromosome. So we moved towards genome sequencing. And to cut a very long story short, we identified a point mutation in this family that's an enhancer element, a regulatory element that's about 5 kilobases upstream of the SRY gene. And that's through genome sequencing. So we are moving routinely, I would say, towards genome sequencing as the prices continue to reduce, and we are identifying new variants outside the exome that's explaining the phenotype. And this is going to happen for many other rare diseases. And one of the problems with DSD is that for many of the genes we identify, we cannot model them using a mouse. And that includes that SRY enhancer I've just described that's not present in the mouse. So these are some of the genes that we found are listed here. I'm not going to go into the details, but whenever a mouse knockout has been done or a mouse knock-in of specific variants, there is no phenotype whatsoever. Okay? So if we find a new gene causing DSD, we've got collaborators who are quite happy to do a mouse knockout for us. They spend all the money, we don't have to worry about that. But there's a good chance they will not find anything at all. So that's a problem for us if we want to understand DSD. Is this variant, is this new gene really causing DSD or not? So one of the things that we've developed in the lab, and it's Anu that's responsible for this, is to try essentially and create a gonad on a chip, starting with human pluripotent stem cells. So what we want to do is trying to replicate what's happening in utero. So we know what's happening in utero, that if you're XX, an ovary will form, so the first lineage is the granulosa cells. If you're XY, you'll form a testes. The first lineage is Sertoli cells. So what we want to try and do is, can we do the same thing in vitro, in a test tube, simply by changing the medium in which the cells are growing? So we're not adding anything to the cells, we're not changing the cells, we're just changing the medium. And then the cells that we get out, do they resemble Sertoli cells or granulosa cells? So again, to cut a very long story short, we could give a long lecture just about this. We can do it. So, and it took 7 years to find the conditions to be able to do this. So at the top of this panel, we've got 46XY male. In the center is a 46XY female. And
That I'm going to stop and take any questions. This is a slide I always finish many of my talks on. This is the ACCS wheel
is happening here is that these cells have
CDC,
gone
which
through
really
all the different
stands
medium
for analytical validity, clinical validity, clinical utility, and ethical, legal, and social implications for all the diagnostic
make tubule structures, an individual with 46XY DSD with a known pathogenic mutation in NR5A1. AMH, so what is happening here is that these cells have gone through all the different medium. So basically what we can do is we can make, yes, you can see at the top right-hand panel cells, and you can see here also that these tubule structures make tubule structures, a marker of the testes, a marker of Sertoli cells, which is the gene SOX9. These cells will produce the middle panel AMH will secrete a Sertoli cell product, and also I just go back hormone to this panel. So basically what we can do is we can make, and the bottom panel cells, or something that resembles coming from a healthy XY individual, these tubule structures to form tubules, a marker of the testes, a marker of Sertoli cells, which is the gene SOX9. The individual who is, you see this in the gonadal dysgenesis with mutation NR5A1. And also we do not see the spontaneous aggregation of tubule formation either. Center panel and the bottom panel, so we can clearly see from the cells coming from a healthy XY individual that mutation, which we already knew about, to form tubules, is actually pathogenic because in this system, and also with the individuals from that patient cannot gonadal dysgenesis with mutation NR5A1. We do not see the spontaneous aggregation what we can do formation either. The patient cells go back and so we can clearly see from this only that missense variant that mutation, and when we do that, the phenotype goes back to the wild type because in this system, so the cells from the patients can make Sertoli cells, they express Sertoli cell markers, and as far as we can see, to prove the point, these are healthy. What we can do is cells. The patient cells go back and specifically correct pathogenic. So this is all a proof of principle because we're working with. And when we do that, something that we already knew, the phenotype goes back to the wild type. The system actually, the cells from the patients can make Sertoli cells. So I just want to end with a summary of all of this about the and as far as we can see, these are healthy. All of everything I've said is applicable to almost any that variant is pathogenic. So this is all a proof of principle because we're working with of all of the something that we already knew about molecular diagnosis, but the system 46 under-virilized meal is a problem. So I just want to end with a summary of all of this about the there's a wide range of phenotypes associated with DSD all of genes. Everything I've said is applicable to almost any correlations remain poor, but as we get more data, we may be able to have more information about DSD cases of a molecular diagnosis. Functional studies are not available. I didn't go into detail, but functional studies and animal models are not available for most DSD genes. Detecting the variants there. We've got evidence. There's a wide range of phenotypes associated with DSD mutations and regulatory elements that contribute towards phenotype correlations remain poor. But as we get more data, we may be able to we're moving more information exome to genome sequencing. Functional studies are not available. I didn't go into this in detail, but functional studies and animal models, gene panels, because simply they're out of date very, very quickly. We've got evidence so you're missing for elements. And also for those of you who are using targeted gene panels and also exome sequencing. And also you have to be very careful. We're moving from exome to genome sequencing. That's been done. We do not recommend for DSDs to use targeted services that are because simply they're out of date. For example, the coverage of the exome, so you're missing a lot of information. Times coverage and also for those of you who are using targeted gene panels and also exome sequencing, you have to be very careful about the quality of the data for exome sequencing services. Not all exome sequencing is the same. It's cheap, not all services that are offered for your money are the same. Just check that. So, for example, the coverage of the exome, what times coverage is offered families for what you're doing, and patients because of your exome sequencing without this has been impossible to do any of these studies, and also. So everyone in the lab, in particular, and Bishamba, who's sitting in services, and all of our collaborators, if it's cheap, and specifically those from India, we've got a very old, long-term collaboration with Jayesh and Freddie by thanking all the families for Human Genetics and Ahmedabad, also our collaborators in Mumbai, impossible to do any of these studies at Nagraj, and also CCMB, everyone in the lab, in particular, and Bishamba. Thank you very much for your attention there. All of our collaborators, and specifically those from India, and we've got a very old, long-term collaboration with Jayesh and Freddie Seth at the Institute for Human Genetics in Ahmedabad, also our collaborators in Mumbai, and also with Professor Nagraj at CCMB in Hyderabad.
Thank you, speakers, for deliberating exciting presentations, and the chairpersons for moderating the session smoothly.
Thank you, Professor Ken.
With that, we start with the panel discussion on future in genomics. I invite Dr. B.R. Das, Chief Evangelist, President, Founder of Molecular Pathology Association of India, Medas Healthcare, Germany, to come on stage and deliberating exciting presentations, and the chairpersons for moderating the session smoothly. With that, we start with the panel discussion on future in genomics. I invite Dr. B.R. Das, Chief Evangelist, President, Founder of Molecular Pathology Association of India, Medas Healthcare, Germany. The panelists for this session are requested to please step up on the stage. Dr. Somashekar SP, Dr. Arnab Roy, Dr. Abdul Rab, Mumbai, Dr. Hitesh Goswami, and Dr. Vinod Skaria. The panelists for this session are requested to please step up on the stage. Dr. Somashekar SP, Dr. Arnab Roy, Dr. Abdul Rab, Mumbai, Dr. Hitesh Goswami, and Dr. Vinod Skaria.
So welcome once again to all of you, and it's required. Dr. Arnav, you have to be there. Oh, there is no chair. Actually, I should have seen that. So welcome. Welcome once again to all of you. It's always required a cup of tea and coffee to resume. Dr. Arnav, and they have cancelled the tea, but people are outside. They are getting refreshed. However, actually, I should have seen that. So we're ready to dive into the interactive session. Let me also extend a very warm welcome to all my esteemed panelists. They have cancelled. Thank you very much for taking out time, and people just are outside. They are getting refreshed. Since yesterday we have been hearing going out and lots of tea and coffee and good lectures here. So it is very exciting to have already taken so many such kind of lectures in different fields: oncology, infectious and genetic disorders. While reflecting back, I just felt that it is my great good fortune that I had that opportunity to see the birth of genomics, rather say that it is a birth of molecular diagnostics. And while say so, I have been working, why I say so is I have been working since 80s, and so it's really a big journey for me. And while going through it, I have gone through lots of ups and downs, and which every organization goes through, but now it has taken a very different shape. It has made our work easy. Without going into the past, let me just make a statement that there is a paradigm shift which has happened during last, say, 2 years. And when I say paradigm shift or 360-degree change, what actually I mean is not the technological advancement alone. It is not the indigenous kit development alone, or the ICMR or the government of India's involvement. It is also due to the increase in the acceptability. Acceptability by the clinician is a very important factor, which has increased during last 2 to 3 years. So, even if you have lots of confidence, convictions or clarity, you cannot make it happen unless until the users or the takers are convinced to use it. That is the reason why I say that acceptability by the clinicians is a very important factor, number one. Number two is there are lots of innovations happens unless until there is a very specific way of commercialization and validation, it is not going to make a success. So based on that, we have created a panel. I'm not going to deliver any slides. I was very tempted. I deleted all my slides because I felt that today is not my day. It is the day for the panelists to interact and to answer your questions instead of telling my own perceptions about genomics. But however, I always believe that active collaboration between academia, industries, research institute, diagnostics lab, hospitals, startups on innovative products are required. That is the reason we have created a panel. And I have esteemed panel, and I have taken this privilege to introduce my panelists. My organizers wanted to announce their names. I told, no, let me just tell, because I want also to introduce them to you. It is very important that after the meeting also to interact with them. It is not always that we all know all of them. I'll take just 2 minutes to tell about each one of them. First, let me introduce Professor Somsekhar, who is the chairperson, chairman of Manipal Cancer Center. He is in Manipal Hospital, Bangalore. He is also the head of the department. I'm not going to read everything because it will take a long time. Only I will highlight the thing that they have really done extensive work and known for. He is the head of the department of the gynec oncology, surgical and gynec oncology. He is also the fellow of Royal College of Surgeons from Edinburgh and president of Association of Breast Surgeons of India, editor-in-chief, Springer, Indian Journal of Gynec Oncology, and also he has got the prestigious Dr. D.D. Patel Gold Medal for Excellence in Oncosurgery. He has more than 300 publications in several journals. Welcome, sir. We are really thankful to have you here. Let me introduce Dr. Hitesh Goswami, who is a CEO and co-founder of 4 Base Care which is again a precision oncology company using advanced genomics and digital health technologies, which is very important. Nowadays, digital health is really bringing a very new dimension to the healthcare. You will be happy to know that the world's first Indian population specific cancer gene panel was developed based on research on more than 1,500 Indian cancer patients' tumor samples. And they have really done a wonderful work on this and work on exome and transcriptomes. After extracting, they created this panel, and if I'm correct, in the month of June, they are invited to interact with the Prime Minister Modi for their good work. So welcome, welcome Dr. Hitesh Goswami. Now, there is another very unique, all my panelists are very unique for me. Wadhwani Research Center of IIT Mumbai, and he has a very important, sorry, I am not going through the slides. He is playing a very important role because he oversees the technology translation and commercialization across diagnostic. Important for all of you also to know, I have seen very closely the work of Wadhwani Cancer Research Center because I worked in the expert panel of that center for more than 5 years. He was also a part of Genome Institute Singapore. He also created two new, he was the founder of two organizations. One is Crida Biomedical, which is at Singapore. Another one is Xcode Life Sciences. That is also, he is the founder. Next, Dr. Arnav. Dr. Arnav Rai is the head of applied digital health research at Reliance Jio, where his team is building a global digital health and artificial intelligence platform. He leads GeoHealth external collaboration, including one biomedical research with Microsoft Health. We worked together more than a decade, where I had experienced and witnessed his brilliance, his dynamism, his meticulousness, and mainly his out-of-box thinking. Welcome, Dr. Arnav. Lastly, Dr. Vinod Skaria, and I do not want to tell much about him. He is known because he has both a medical degree as well as a PhD degree. So he has both academia, clinical, as well as the industry experience. He is associated with the CSIR Institute, which is Institute of Genomics and Integrated Biology, which you must be knowing that is the most leading institute of the country who has contributed significantly in the field of genomics. And he is a principal scientist of that country. I had again the privilege to work as a SAC member, Scientific Advisory Committee member of IGIV for nearly 5 years. With these few words, I would like to again welcome all of you, and just to take the forum, I am going to ask few questions, but after that I expect each one of you to ask the question that you want to ask. And if you are not going to ask question, again I'll take the platform and I'll ask whatever I want to ask. So it's all up to you. Now let's start. My first question is on infectious disease, because we have been hearing since yesterday lots of questions on oncology. Though Dr. Somsekhar is here, but still I would just want Dr. Somsekhar that I will ask a very small question because he can answer so many things pertaining to oncology, but we have been hearing since yesterday. We'll start with the infectious disease question, which, let me start from Dr. Vinod. This question is for you. How can genome sequencing enable clinicians to prescribe the right antibiotic to the right patient at the right time? And this is mainly keeping AMR in mind. We all know that AMR is really scary in India now. And we want solutions from people like you all to tell us whether genomics is going to help us to address AMR. Over to you.
Yeah, thank you for the question. So when we talk about the right drug to the right patient in infectious disease, there are two aspects that we need to talk about. The first aspect is, of course, of the pathogen and the sensitivity of the pathogen in terms of the antibiotic that you're going to give. And second is especially the metabolism of that particular antibiotic in the host, what we call as the pharmacogenomics. I'll not delve the second part, I'll delve into the first part of it. Now, practically, antimicrobial resistance spans all pathogens, whether it is a microbe, it's a bacteria, a virus, a parasite, or in many cases, much more recently, emerging fungus diseases, which are also antibiotic resistance. And this resistance could be coded either through plasmids, which are small DNA pieces, circular DNA pieces, which could be transferred between organisms, or could be also coded by specific gene mutations in the bacteria. The best examples would be Mycobacterium tuberculosis, where you have antimicrobial resistance mutations. Now, the principles of antimicrobial resistance typing is essentially either identifying a particular plasmid or looking for a specific genetic mutations in the genome of the pathogen. And both of them is today amenable to NGS sequencing or highly parallel, high throughput sequencing. And many of these could actually be built cost effective. But nevertheless, we don't still have it widely used and widely prevalent today in India, largely because we don't have indigenous panels built for our specific pathogens and our specific mutations.
Okay. If any question is there related to this, you can interrupt. Otherwise, I will shift to the next question. Yes.
So, sir, we have been hearing a lot of antibiotics which is being prescribed mainly in the COVID times. Do you think genome sequencing with respect to COVID also will help in identifying those?
Yeah, absolutely. So when we talk about COVID, there are two aspects that we need to keep in mind. One is the specific therapies for COVID that has been coming out, like for example, monoclonal antibodies, right? And monoclonal antibodies specifically act on the spike protein. And today we have spike protein mutations which can escape monoclonal antibodies, and that is very well known, at least for the newer variants BA4, BA5 and BA2.75. They practically evade all monoclonal antibodies, almost all monoclonal antibodies that are presently in the market. So that's of course of relevance.
Okay.
Thank you.
Thank you. Let me go to the next question. This is for you, Dr. Somsekhar, if you can please answer. What is the current role of liquid biopsy in oncology and its current clinical applications? Because so many people have been making a big noise when it comes to clinical applications of liquid biopsy.
The whole concept of liquid biopsy is because we moved from a tissue biopsy to a precision oncology. Not many time, like when I was in UK, when I was in Mayo Clinic and also Pittsburgh, stage 4 cancer means 11 to 12 months survival. But then we understood all patients, same cancer, same stage in 2 different patients is not same. So we understood that what is more important for me is not the primary tumor sequencing, that may not represent all the aggressive biology and the malignant potential, but what is there among them, which is the aggressive cells which can potentially metastasize outside. That's one of the reason, the liquid biopsy came. Now the main problem in oncology is we have deep-seated tumors, we will not be able to get the biopsies. Second thing, what is there in a primary tumor today may not be actually representing the entire aggressive tumor which has a malignant potential outside.
Yeah.
That's why the concept of liquid biopsy totally came, because it's not important that all the tumor in the primary, 99% may not have any impact on intervening. Patient may just live with the tumor lifelong, but that 1% of the tumor is important. That's why the concept of liquid biopsy came for us. It gets me that aggressive cell which is already in the blood, tumor ctDNA or any of them. Second, I don't have to run around with adequate tissue biopsy from a deep-seated area, especially take like lung, RCCs, all this. So this concept has totally changed for us to get it from liquid biopsy, very easy, friendly. It is so much so that it is a non-invasive technique.
Yeah.
But there are certain very, very important concepts. See, like I'll tell you how liquid biopsy changed everything for us. Take for example lung cancer. A lung cancer with one metastatic site was 11 months. But now if you can do liquid biopsy, sequence what it is and treat them, average 5 to 7 year people live. But it's very important, everything, just because we have a hammer, everything is not nail. Liquid biopsy has got low sensitivity and precision in compared to primary tissue. Standardizing in a lab is a very difficult area. It's not something which is very, very easy. Even along various platforms, how to standardize liquid biopsy itself is not that. So much so that, if you see all other molecular pathology, precision pathology, so many approval from US FDA is there, but only 2 sequencing platform is approved by US FDA in liquid biopsy that go on to say that how difficult it is. A improperly done test is worse than not doing a test. So liquid biopsy is revolutionized for us.
Okay.
It picks up everything. And its clinical application now, what happens is time is also very low. See, suppose I'll give an example, lung cancer, RCC, endometrial cancer, or suppose, I have a colorectal. I don't have to do a core biopsy, make a block of it, then I need to send it for sequencing. No. Liquid biopsy, day 1 he takes it, and average turnaround time is 11 days now by most of the good labs. So treatment duration is shortened. But it still, as of today, has an inherent problem of standardization, sensitivity. But however, it has revolutionized in lung cancer, predominantly in lung cancer, endometrial cancer, and recurrent and advanced cancer. So it's coming up very well, beautiful. More and more institutions have now started using it, understanding its pros and cons.
What do you prefer, plasma or serum?
Yeah, we would definitely prefer a serum. Yeah.
Okay.
Yeah.
Dr. Hitesh, would you like to comment on something related to MRD, liquid biopsy with MRD in rare cancer?
Definitely.
Yeah.
Like what Dr. Shomashekhar said, there's one more thing I'll add to what he said is that we strongly propose or we strongly suggest that even when the tissue is available, it's better to do a tissue and liquid together because that will effectively let you take care of the tumor heterogeneity.
But that's not always available.
Right.
For that only we prefer to have
right.
a liquid
No,
biopsy.
but even when you have, I think we should do both.
Yes.
So that kind of takes care of tumor heterogeneity. From the MRD perspective, there are 2 applications.
Okay.
One is where we are looking towards adjuvant treatment, right? Where before the adjuvant treatment is started, before starting the way we have for breast cancer today, we have a lot of tests available which tells you whether adjuvant treatment has to be done or not. Similar applications we are seeing, especially in colon cancer recently, where a good publication was there, which essentially tells you whether you should do an adjuvant treatment or not. So that is one of the application from MRD perspective. And second is disease progression, right? How we can use liquid biopsy. So if you do a baseline biopsy profile, liquid biopsy profile, that profile can be used for multiple times over a period of time to do a baseline comparison with post-treatment to see if the disease is progression or a new clonality is coming up. So there are a lot of applications of liquid biopsy which is actually revolutionizing cancer care to a large extent.
Okay. Thank you. Thank you. Let me now switch the gear. We all know that the genetic test can be best interpreted in conjunction with other clinical data of a patient. We know that. Going forward, what steps do you think are already being taken or at least being contemplated to be taken for integrating genetic test data into patient records? And I think Dr. Arnav is the best person in this panelist to answer this.
Yeah, thanks for the question. And yeah, it's very pertinent, the discussions that I have been listening to over the last 2 days, particularly the second half of yesterday and today. I was just thinking whether we have a kind of a appreciation of the enormity of data that we are generating every day. And how do we, going forward, go from a personal level or maybe a community or institute level to a higher aggregated level data analytics. So that is very important for a larger population health application. Maybe Dr. Vinod will be talking about it later. But at the same time, you have to appreciate one thing, that the first decade of NGS has been mainly exploratory, technical advancements, etc. The second decade, in this century itself, has been more of insight generation from the data that we kind of generated over the years. And then this decade would be more into integrating this data into other data that's coming in. So that's kind of a patient data, the physicals data that will be coming in. Now, once we move towards that, we'll be finding it very difficult to interpret data in a scale which is unfathomable. Just to give you a reference point so that the youngsters are here, the 4 most data-intensive industries in the world are starting with astronomy. The data that you'll be getting from Hubble telescope or other telescope. Like one example is there is a pathfinder in Australian hinterlands. Okay, it is Australian square kilometer array pathfinder. It generates 7.5 GB of data per second. And what we are looking at is 1 exabyte of data per year in 2025. So that means 1 billion GB of data from one instrument of astronomy. Now, let me give you a comparative figure. In 2025, we are expecting 2 to 40 exabytes of data from genome sequencing. So that's going to be the most intensive kind of a data analytics platform that's going to drive integration into the medical healthcare. Now I'm talking about only genome sequencing data. I'm not talking about the medicals data. I'm not talking about the physicals data, the lab tests that are coming in. Now some of the organizations have already started doing it. Most of you have heard of eMERGE platform. In 2007 it started, and eMERGE is trying to develop some data standards for that. Unless you develop data standards, you cannot really integrate into other standards. So eMERGE, in 6th of July, they launched an ISO standard, ISO 4454/2022 recently. It will be coming in data in your laboratory domain as well very soon. And what it does, it's an HL7 FHIR standard which will be used for coding all the genetic sequences that you are generating, the VCF files, and from there, the reports that you are generating. So once that is there, then it is easier to integrate your data into an EHR.
Okay.
So say, for example, for Dr. Somsekar, it will be easy to interpret the data in context of his patients.
Thank you so much, Dr. Arnav. Dr. Rab, if you can please, can you just get back to it again after this one round of questions? What do you feel is the role of consumer genomics? Because we really want to touch upon different areas. So when we talk about consumer genomics in preventive medicine, what have been some success stories in consumer genomics from your experience?
Thank you, Dr. Das. So, you know, post genome era, post 2000, one of the most lucrative applications to industry was consumer, because you can then bypass everything, right? No regulatory, no physician, you can go directly to the consumer. I think the largest segment to emerge was ancestry testing, 23andMe, family tree DNA, ancestry DNA, and so on. And that eventually led to, ancestry led to nutritional testing and so on, certain levels of micronutrient variations among individuals and so on and so forth. But everything led eventually to health genomics, right? Predicting carrier testing, predicting predisposition to different types of conditions and so on. I think the preliminary analysis that was presented wasn't very definitive, so that gave way to PRS, the risk, genetic risk scoring concepts and so on. And there are some examples of companies like Color Genomics that specifically marketed the breast cancer test to companies directly, not even consumers. It was B2B type of a model. But I think the market potential for all of this is limited to a certain degree, but eventually this is all going towards clinical. So genomics' role in direct to consumer is going to be a tool to non-physician practitioners like nutritionists and fitness trainers and so on and so forth. But I think that segment is going to be far smaller compared to what it's going to do for clinical genomics.
Okay. So any success stories from your
So 23andMe was a great success story, market valuation of more than $3 billion. But the consumer segment itself, like ancestry testing, was a significant portion of it, but a good deal of their valuation actually comes from their deals with pharma companies, where they are selling data to the companies, right? So that segment has to be taken into account. Again, eventually it's clinical, not the consumer side that is the cash cow.
Yeah. So just to again go back to comprehensive genomic panel, Dr. Both of you. First is Dr. Hitesh, if you can say that, how does comprehensive genomic panel help in addressing rare cancer management?
I think again now we are more moving away, especially in the rare cancer space, right? Rather than the other cancers. The rare cancer space specifically, we are more moving away from doing a targeted panels
Yes.
to, there were a lot of talks which were talking about this today.
That
right?
is why I just focused on rare cancer
Right.
management.
We're moving away from doing targeted panels to doing a whole exome and more whole genome sequencing. But of course, there are challenges in terms of whole genome sequencing. One is the depth at which you do, whether it's 30x, 40x. Maybe Dr. Vinod will be able to share more insights on that. And the quantum of data which is being generated, right? The cost is something which is prohibitive in terms of using it in the clinics compared to you doing a targeted or this. But so those are the things that we have to look into when we are looking at whole genome sequencing being used in the rare cancer space.
Okay. Wonderful. Now I open this questions from your side, if you have anything, but please be succinct, both to panelists to answer succinctly as well as to ask. Yes. Give a microphone, please.
So how are we also equipped to answer and put into place measures which will address data privacy concerns, the HIPAA compliance and so on? Are we at that stage where both of them are mature enough so that we are addressing that?
Yes, very good question.
Actually, when we are talking about FHIR standards, which is kind of Google Cloud is fetching and also Microsoft is promoting, they were started by IBM. Can you hear me now? Yeah. So when we are talking about standards, standards should be having the data privacy bits already built in. So when we are talking about HL7 FHIR, we are talking about data privacy as a module inside that. So since it is kind of a US based, it will be HIPAA compliant. But at the same time, because FHIR is being promoted as a standard for all the data analytics, it will have GDPR elements built into it. So it will be compliant with the DPB or data privacy bills or laws of whichever country it goes in. So that's one aspect of it. And the second aspect is so this is a data privacy for the genomic data that you are getting. Now, when it comes to multitude of data coming in, say for example, the digital health platforms will be getting you data from the observations of daily living, the ODL data that we call, or we are getting data from medical histories of people. Now, these are not on FHIR standards always. So these might be on piecemeal standards which others will be building it. Now, one of the things that the Global Alliance for Genomics and Health is doing is that they are trying to create some smarts. Smarts is SMART. So these are kind of a substitutable medical applications for reproducible technology. So what they will be building is that whether you can create one data standard for any stream of data, plug it into an FHIR. So it's like a plug-in technology you are using on your phone every day. Say, for example, if you are using a Paytm, UPI is a plug-in there. So similarly, these plugins will be built in once we start building those different streams of data coming into a single standard.
Okay.
Thank you for
I
the
would
question.
like to just add it. It's a beautiful question. What he told, almost like, trillions of genomic data is being generated. We as a clinician get appalled by 10 pages of report. I had a honor of presiding over as a multi-institutional principal investigator for Watson Genomic. You know that are the most proficient artificial intelligence for cancer genomic interpretation in the world. And I did a multicentric randomized trial, you can Google in Annals of Oncology, of over 1,000 patients. The beauty of that is, like, I would request all my clinical colleagues to give it in a VCF file, and I just put it into Watson of Oncology. Then I don't have to worry. It gives two types of things for us to analyze this large amount of data. An established drug for that disease. For example, I may say a erlotinib tablet for a lung cancer, or I would say that BRAF mutation for melanoma. Also, there are drugs which are available in market, but not for that disease. See, like for example, you can say I have an aspirin for pain, but aspirin could also be used in colorectal cancer. So then those particular can be used. So I found this extremely useful, that an AI platform to interpret this vast amount of data and then able to tell, see, ultimately if there is no translation research to day in a patient, there is no use. So that's something which is used. Second, the one which is on there, Dr. Das who has put, how is comprehensive cancer genomic helps in rare cancer. One of the biggest dilemma for us clinicians is a metastasis of unknown origin. You don't know where the primary is. There is a systemic disease and you biopsy them, they are poorly differentiated cancer. You heard Dr. Anita Borges talk. So initially then we had to trace from where it is it epithelial, mesenchymal, then do. Now I just don't worry it. I just request them to do comprehensive genomic panel. It doesn't matter to me, it's bone, lung, liver.
Yeah.
As long as they can clone me, which is not aggressive, and give a genomic sequence and match the drug, that has totally revolutionized for us. You know, this is the biggest boon for us in comprehensive genomic panel in rare cancer is no longer now I have to worry, is it rare, not rare. From where it came, I just close my eyes and I ask this and I have an answer. It doesn't matter, right? You came from Ahmedabad, Delhi, Bombay, what route you're taking. As long as you know you can reach the destiny, it's through for me.
Wonderful,
Also,
wonderful.
Dr. Das, I'll maybe the data security and privacy that you're talking about, right? Of course, as a country currently, we don't have any strong and stringent laws. But as a startup and as a company who's dealing with this kind of a big data, I think it's a moral obligation for the companies who is dealing with this data to use this data in a very ethical and responsible way. Although there are no guidelines, but it's a moral obligation of the company to use it in a very ethical and efficient way, such that it leads to better innovation and better outcomes for the patient.
Wonderful. Looking into the time, I would like to shift to the other question.
Is going very interesting.
Please keep it. Yeah, but I cannot just focus on this area. Let me now just go to a very, very general question. What are the challenges in adoption of genomics by the healthcare stakeholders? It is a very important thing that we all must know that what is that we are facing. Questions can come from both panelists as well as from you all. Answers, not questions. Yes. What are the challenges?
Maybe I'll take this.
Okay.
I'm sure Dr.
Okay.
Somashikar
Everybody is open to take no
agree,
such binding.
To this, that one of the biggest challenge as a clinician for you is that if I do a genomic test, right, the drug which is coming, will my patient be able to afford that drug? So a lot of companies like us are working and on the side of reducing the cost of the test for diagnosis, but what about the cost of the treatment? Now that is one of the biggest challenge which is there in terms of making it a standard of care or adopting genomics as a standard of care practice in the clinics. I think that is one of the biggest
for me
challenge.
as a clinician, I see a sea of revolution last decade. For me, number one, I'll keep a cost afford because, you know, in a science forum, cost will take it, yes, cost is universal. More than the cost, standardization of a test is something which is worrying to me. You know, like you take it specially to India. The genotypic and phenotypic mapping of Indian population is not at all done. We just don't have it. So by default of this, when a test is done in India or an Indian patient done anywhere else in best of the best lab, I'm not 100% sure that this genomic data is translating into clinical part of it. I'll give an example. Routinely, I have P53 mutation or 10 or whatever, all the mutations are there. So I have a drug already approved, but they don't work the same way. We know that once you do a comprehensive genomic paneling, only 30% you identify a mutation, 70 no. Now, of that 30, if they show these three are available in Indian patients, since there is no database comparing genotypic, phenotypic representation in India, it may or may not work. So I'm really worried about this standardization, applicability of genotype to phenotype in the Indian patients, keeping the cost separately, and then standardization. You know, like it is extremely very, very difficult. I'll give an example of, we treat ovary breast cancer now based on the BRCA. You just do BRCA, even in somatic and then germline, nothing is standardized. It's now people have moved to that, but we pick up only 20%. HR or HRD, if I do it, it is 50%. How many in India are done? So I would say that the challenges keeping cost apart is that every company should pool together, share their genotypic, phenotypic data and a comprehensive network of India. So if I have a VUS, my biggest nightmare is I convince a patient to do this will help me, the report comes as VUS. You know, I'll give a classical example. Myriad VUS rate is 1.2%. Cost is what? 3.5 lakh. Now in India, average centers have 10 to 20% VUS. Now how do we break this VUS? All of the people who are doing genomic or molecular pathologies on one platform and identify which VUS is pathological, which not. My biggest worry today is this in India, which needs to be sorted out.
I fully agree with you, Dr. Sekhar. Any of my lab colleagues, friends here who are offering genomic test, can you please answer that? It is very easy to only tell that I'm doing this panel, I'm doing that panel. How you answer this question, and which is very, very relevant.
Hi sir, I have been interacting with Somsekhar sir for last more than 5 years. What, as a lab person, the biggest challenge is the lack of clinical histories which is being shared. Many a times, almost 90% of the requisition which we get, we don't get any of the background clinical information. So if I identify a variant and if I don't know the background, whether it is a lung or whether it is a colon, so that time the correlation with the genotype and the phenotype is a biggest challenge for me. So I don't know how to answer this, but this is for me is the most difficult thing to handle, and that affects the quality of the reporting also if you don't have the real background of the case.
Wonderful. So these are the points MPI also can take though my president friend is not here, Dr. Mishra. Hello. Dr. Mishra, can you please come? There is a question, there is a challenge in genomics applications, and we want MPAI also to help how to address genotypic and phenotypic association work. So what Dr. Somsekhar, you can just repeat that once more succinctly, Dr. Somsekhar, so that Dr. Mishra now he's heading MPAI, he's the president. So if he can also help.
The issue which I told is the phenotypic genotypic cross section applicability from lab translation research to clinical in India is not mapped out. That's why when I have a test where only 1/3 of the time I have a positive mutation available, that doesn't mean that the drug acts, because in India it is never done. And the most common problem I have is the VUS, which is coming because, you know, the moment in India it is 20-25%, it is because we have not gone through a comprehensive pooling. See, every company wants to keep their data. A company which started 20 years is today stronger than a company which starts 10. But if you keep patient in mind, there has to be a common non-commercial, non-conflict of interest database where everybody can say which is pathological. In India, it is lacking. Either, even if you read, Niti Aayog brought a specific guideline for genomics and molecular pathology. Not many people know that. There is a specific white paper from Niti Aayog on how the genomic data and a common database in India should be made, keeping in mind the ethics and confidentiality and helping patient-centric rather than lab-centric. I just know, if I do from genomic from one VUS, the same thing give to another lab, you say, you give it to me, I will tell you that VUS is pathological or not. So this is where an association like this should step in and do it. So just because we have identified a genetic mutation doesn't mean in Indian patient it is going to work as of today. Like classical example is I told Myriad, 1.2 to 1.3% is VUS. So I sometimes ask it, even though it is 3.5 lakh, because I know they know all the characterization, they have the largest database. So if in India, everybody can join together and build up a common, registry where everybody can help is something which is very useful.
Yeah, we cannot answer that. I just wanted you to listen to it so that we can work from the association perspective, if we can support this and to.
I think yesterday when Dr. Sareen was speaking,
yes,
he also raised this issue of US, and he showed that in their data, 25% is VUS.
Yes. Yes.
And he said that this should come down if there is more database.
Yes.
Presently what is happening, people are all using databases which are in the public domain, which are not our ethnic population. So we do not do the sequencing of normal individuals, and nobody supports that kind of work. So we haven't created a large database, what my esteemed panelists have said. I think that is the way forward, and I think that should come with governmental support.
Yes. But
otherwise it is not possible. I think if I understand correctly, remember correctly, MedGenome was supposed to have studied 10,000 normal individuals, whole genome sequencing, and they would have.
Even IGIB, I think, has studied a lot.
IGIB has done how many, Vinod? 1,000 plus. Yes. I think the MedGenome had targeted for 10,000 of them.
Yes.
So similar initiatives should come from all the molecular diagnostic companies. I think that will be a good, that will be a service to the country.
Yes.
If they can do that along with their diagnostic work. And the in silico prediction that we do when there is something which is not pathogenic, but there is a phenotype which is pathogenic. So many times the clinicians are also not happy with the results, saying that here is someone where the patient is showing these features. How come there is nothing in the whole genome or whole exome sequencing? Because when there is a rare disease, we send for whole exome sequencing and it comes as VUS or not likely pathogenic.
Yeah.
Whereas the patient has the phenotype of the disease. So those situations.
So I just want to summarize the challenges, if I understand correctly. One is cost, which is fine, that is universal. So we should not talk much on cost. Second one is this phenotypic and genotypic correlations. Any other points, just points please tell so that we have time. We don't have much time. Any other points so that we identify those points? Yes.
I wanted to raise this because at the Broad
Quickly.
Institute,
Yeah.
And with Verily, Post-study Verily Life Sciences, we have heard of it. They had started this concept called phenopackets. It is already built in some data standards. And what they are doing, they are connecting the WGS and WES profiles collected across 7 countries, including in US, and marrying those data to the phenotypic data. And that's what is known as phenote packets, and that's what most probably Dr. Somsekar is mentioning. And this is doable. It need not be a government initiative. It's a Broad Institute initiative. It was not funded by a US government kind of a fund. So, but at the same time, it has to be on a federated structure. It has to be on the cloud. Otherwise, if it is on-prem data, you are mentioning about data with a single lab or a single institute, it's not going to solve the problem. It has to be on a cloud structure. It has to be on a federated kind of a very much access control database. Then only you can build this. And this is possible. This is what I wanted to bring.
Great. So now let me straightway jump into the related questions. What are the current growth drivers? I'm not talking about the challenges. Growth drivers mainly in the area of clinical genomics. And second part of is, what are the key asks from the clinical labs apart from cost efficiency? I know that everybody is talking only on cost. Forget for a minute about the cost. What are the other things? To the panelists. Anyone can take up.
So I think one driver's perspective, what are growth drivers? One of the largest growth driver has been COVID, which has created a lot of awareness in everyone, right? Individuals. Today, I think even the patients are coming and they are asking for genomic test or the genetic test. So there's a lot of awareness which has happened regarding the technology, regarding the whole science, which is kind of driving. Secondly, I think we have fantastic.
Sorry, Dr. Hite, that means, do you mean that surgeons of such kind of pandemic is a growth driver?
In terms of awareness, yes.
Yeah.
In terms of awareness, yes. When such an event happens, is when you get a large scale awareness. Correct? That's why today even a 10-year-old kid knows about the PCR.
Mm-hmm.
Correct? Which would not happen otherwise. So there are, of course, it's a catastrophic event, but there is always something good coming out of everything, right? So one of the things which has happened is a lot of awareness regarding the healthcare and the technology has come in the regular people, and which is one of the reason why there is a growth. And government is taking a good understanding of this and taking steps in the right direction.
So government has also accepted it and really helping it to take it to the next level. Okay, yes.
I would say as a clinician, the most important reason for growth drivers, we first find a machine and then we find an indication for treatment.
Right.
No, it is the other way around. You may be doing million tests. Your capability is phenomenal. If there is no therapeutic option available in that, it is not. According to me, the single largest growth driver for clinical genomics is availability of a therapeutic option for
Wonderful.
the disease.
Yes.
I'll give an example. There are 6 genomic-based therapies available by US FDA as a level 1 evidence in lung cancer. Now it is crime medico-legally not to do a next-generation sequencing, either liquid or this, before you give a treatment. So I'll give one more example. Thyroid cancer, nobody ever thought that there is a role of genomics. What is there? Just other than doing red proto-oncogene, what was it? Now there are 4 therapeutic options available for anaplastic carcinoma and routine cancer. So the moment you have, suddenly there is a growth driver.
Yes.
Because technology is always there, but they don't know what we need. The moment there is a drug available, now you have, see, like, you imagine there is one specific area in Antarctica, which is a beautiful place. Suddenly 10 companies will start flying down helicopters there. So the main growth driver is availability of therapeutic option for that particular disease. Then suddenly there is a boost of a growth drivers in that genomics.
Wonderful.
In fact,
I
last, I think,
Sure.
2 years, most of the FDA approvals has been based on the molecular markers. And we have pan-cancer markers like NTRK, TMB, MSI, and a lot of KRAS is now coming into a pan-cancer space itself.
Telling you now, directly, we have this immunotherapy for colorectal cancer. After that paper, a patient walks in with stage 1, stage 2, where I can do a robotic surgery. First he asks, can I just know my MSI, MMR? Am I eligible for that? So can you imagine? So the growth driver for the test now is a therapeutic option which is approved by FDA today. So then you don't need anybody. It's like what do you say? It is a sudden outburst of request from patients and everybody.
Okay. Dr. Mishra.
You see, I think the biggest growth driver is the constantly changing standard of care. You see, today what is standard of care, tomorrow the standard of care has changed. And with that, you have addition of genomics. Constantly the classification of tumors, the classification of diseases are changing, which are again genomic driven.
Yes.
So
Yes.
all these are
Also adding the
stimulating the clinicians to ask for this test. What he has said that many of these are pharmaceutical driven. The moment a drug is introduced, like the asciminib has been introduced, the allosteric inhibitor in CML. So suddenly there is a immediate need of doing TKD mutation by NGS. So similarly for lung cancer, you have so many drugs. PIK3CA for breast cancer is now every breast oncologist's desire. So it is all driven by the clinicians, driven by the drugs, and driven by the constantly changing standard of care.
Guidelines also, yeah. So based on this, if just tell me when it is related to the expectations from the clinical labs, if there is such a kind of need in the growth factors, definitely, because while I was going through the data of NABL, few years or 1 year back it was in hundreds, now it is 2,500 labs are accredited. CAP is also significantly increased. What does it mean? That means so many labs in India have started doing molecular tests. If that is so, can you please tell that what is that is expected from the clinical labs apart from cost efficiency? Because everyone only talk about the cost efficiency, which I do not want to talk. Please tell what is that expectation, Dr.
I will give to everybody, but
I
would like to take this question just one line. I'm scared the way things are mushrooming out here. Everybody is looking into commercial angle. What I would expect from a clinical lab before they start this test is, have they put up a pre-test counseling? Have they mandatory done a counseling after the test? Have they taken clinician? Clinicians' knowledge in this is extremely poor. Don't think just because somebody is top. The things change so much. I always tell in my forum, you go for a vacation 1 month and come today, the standard of care has changed. So how well this system is set up by clinical lab? Mandatory counseling before, mandatory counseling after, and the report not just giving 10-page, comprehensively understand the database of what are the drugs available as standard of care, what are the drugs available as a clinical trial group, and its impact. The proof of pudding and the strength of clinical lab is their moral responsibility to fill the glass before and after, not doing this. So this is something which is very, second is following them up. You have done a VUS today, how often after 5 years you are moved up, call back the patient and the clinician, this which I said VUS, today I would classify it as pathological. These 5 things are seriously lacking in current labs. I can't blame them because of the cost, everyone want to keep it very low, you can't do that, but this is a moral responsibility of lab, clinician towards the patient, which is mandatory.
Wonderful. Anybody would like to add anything? Doctor?
I'll just probably add a couple of points. One of the key asks for a clinical laboratory, in my opinion, would be largely quality and reproducibility.
I'm sorry?
Quality and reproducibility.
Yes.
And this is indeed a very big problem because almost every other week I do get half a dozen cases where I am asked to compare two reports. I mean, it is sad that individuals and patients are having two reports, right, genetic test reports, which is in my opinion criminal, because the patient has paid twice for the same test. And when two tests of the same kind give two conflicting reports, that is something that should be avoided at any cost. And that can happen only with education, awareness of the quality standards of variant calling, variant interpretation, which unfortunately none of the major service providers offer in the country. I mean, all of them go through databases, none of them go through a manual curation of variant evidence, right? In fact, I've interacted with many people, they don't even know what a manual curation of variant evidence means. Now, that comes to the interesting question of why I'm emphasizing on this point of quality is because the real driver for clinical genomics is actually screening, right? When I say screening, that necessarily means that we are in a point in time where we could actually impact lives of individuals who are apparently normal, like you and me in this room, but we all are carriers for one or the other disease, which is either treatable or which is preventable. And to give rough numbers, I would say 10% in this room would be carriers for a treatable genetic disease, like for example, thalassemia. Do we have a test for thalassemia? No. Do we have it cost effective? No. Can it impact all of us? Yes. Right? We can talk about things like familial hypercholesterolemia. The prevalence in the population is around 1%. Are we doing anything about it? No, because we don't have a test. Right? We should stop aping the Western world, buy a panel from the Western world and think that that's the end of it. That's not going to solve our problems.
Wonderful. Yes. Yeah, we have 5 more minutes. Do you think, yeah.
See,
sorry, sir.
Could I
just Dr. Mahajan, please. So after that you can tell. Yeah.
I just wanted to add one small point which goes with this ask from clinical labs, and also a major challenge that we face is the defined guidelines for reporting of incidental findings in our country. We do follow ACMG guidelines wherein apart from the good 50 genes which are to be reported even if it's incidental, what if a patient comes to us for a clinical exome and the reason for which the clinician has referred is something else, but I find something incidental. So is it as a lab, it puts me in an ethical dilemma whether even if in pretest counseling I dig in deeper into the history, it sometimes doesn't go well with the clinician. If a patient is referred for a certain kind of cancer and the patient wants a clinical exome, but I do find something, a gene which may be related to cardiomyopathy. I don't know if if I should report it or I should not, because there are no standard guidelines I think we have in our country for such reportings. What do you, if any one of you can put some light on that?
Yeah. So the principle of reporting incidental findings is that the patient benefits from that finding because either there's a treatment or way of prevention, right? Now, in all ways, it is a right of the patient to know that he has or he or she has a particular condition which is either treatable or preventable. Let's keep aside the clinicians, right? So if I am a patient, it's my right to know. Now, of course, this is a very changing field because the incidental list has now more genes included, including hypercholesterolemia, channelopathies, etc., etc. It's a changing world. And that's why it is very, very important to actually adopt digital technologies to adapt to this changing world. And of course, counseling is very much part of it, both pre-test as well as post-test, so that the patient is aware that the genome that he is going to do or an exome or a clinical exome that he is going to do is going to be constant for his life, and every variant might be important tomorrow as the new evidence emerges.
You agreed?
Yeah, I agree.
And I think, Dr. Sayala, you and Dr. Vidur, you are quite well equipped for that digital part.
Yeah. Like Dr. Skaria said,
Yes.
the thing with genomics is that it's an evolving science.
Yes.
So something which may not be actionable today may become actionable 5 years from now. And being genetic data, it doesn't change over 5 years. And if somebody has gotten a clinical exome done today, the person will not even think about getting a genetic test again for decades. So very rightly answered, sir. Thank you.
Thank you. Over to Dr. Mishra, please.
You know, a lot of clinicians these days are asking for Foundation One medicine
Yeah.
assay. It is an extremely expensive, hardly 1% of the patients probably can afford it. It's a 28-page report. There are some actionable mutations where the drugs are available in India. Most of the annotations that are given the clinical trials, those drugs are not available in India. So many times what happens, some intelligent patient, because these days people Google the thing, yeah, I have this mutation, what is there internationally available? So it is extremely difficult to counsel people after you have the result in hand as to what you do with that Foundation One medicine report, because they are all US based. They are either, as someone said, that we should not all the time copy the West. But unfortunately, we don't have such database to annotate based on the Indian labs
Phenotypic
testing. So that is our lacunae, and we constantly ask for like Thermo or Illumina, they give the annotation pipelines where you pay per test a certain amount of money and it annotates. But again, those annotations are Western based. So you don't get those clinical trial drugs even in India. So what are the views of the panel?
Yes, maybe I will take this. I think this is the problem that as a company that we also wanted to work on as a part of Illumina Accelerator program. In fact, when we got selected for the Illumina Accelerator program, our objective was to make this data, but the data is not available, right? So we in fact did around 1,500, now we have 3,000 whole exome and whole transcriptome of tumor tissues of Indian cancer patients. Now, what becomes important is that how do we as one organization work with other organizations, both in industry and in academia, to increase this 3,000 to 10,000 to 20,000 to 50,000. And I think that's where all of us need to come together, collaborate, and figure out ways where this can be used in a collective way such that all of us can benefit from that. So I think a society like yours and even IGIB and other places, I think it's very important for you to play a central role in this, to build something like this, to build a platform or an ecosystem where this collaboration should happen.
Okay, any other question? Yes, yes, please. I think this would be the last question. Any other person has any questions?
I think
No.
I'll
Okay.
not ask you a question, I'll have to add on something.
Okay,
You know, the two questions what you have.
Yeah.
And for last, what Dr. Shelley asked for it. I think
Yeah.
my understanding, if there is an incidental finding, in routine pathology we report, we find a malaria parasite in the slide, we report in CBC. But when it comes to genetics,
Yeah.
I think it's very important to have a post-counseling session.
Yes,
Because that's the
what
confidential
she also
information.
Yeah.
But without that, any incidental finding, go back to the patient, talk to the patient, take his consent, inform him, and if required, they can communicate to the clinician. I think that should be the standard practice we should be following in such findings.
Yeah, yeah.
And the growth driver you're talking about, I think what rightly you said, in fact, that the COVID actually, pandemic actually accelerated. The learning right here is, because unless the academicians, research, scientists, the labs, clinician, therapeutic, preventive, and the patient, all of them have to come together. That's a driver, because today that's exactly what we're doing. We're talking to clinicians. We are getting the genomics from the R&D lab to the diagnostic centers. We are talking to pharma companies. They're coming to us to develop a specific drug for that, actionable information. Then the IT industry, I think all of them, even the patient, the consumer reading, Googleization, so their contribution is adding to this. So I think that's the driving factor today.
True.
Everyone is aware, and unless all of them are involved, till now, before COVID, I think many of them, you know, like Dr. Das, they're working in isolation, R&D lab with this thing. Now I think many of the diagnostic center have a R&D right inside the commercial lab. And that's going to be the future.
True.
Thank you.
Wonderful. I think we had a wonderful sessions, and looking into the time, I am getting indication from the organizers because it is lunch time and there was no tea break. I do not want to drag anymore. I cannot tell you how happy I am to see this kind of interactive session. Everybody interacted very actively. Thank you so much to each one of you for your kind presence and wisdom. Thank you so much, and thanks a lot to each one of you for your questions and interacting and taking the advantage of their presence in this dais. Thank you.
Dr. I'll just give a thing, the message would be the strength of any test is pooling of the data. Why these companies in US have a monopoly and they charge left, right? Because they have a data of a whole world where patient pays, clinician writes, but they keep it for themselves, not for the mankind. India has the largest number of data. See, like for example, I'll say EGFR in lung in India is 60%. ALK is 2.8%. And now no NEMJ Lancet accepts any paper unless a Asian cohort of patient is done. So all of them come running to us, please do a clinical trial of genomics to us. So India is the large country, 1.4 billion, overtaking China. If there is a common registry which has to be mandated by everybody, imagine in 4 years, we are the largest. All Foundation One, Guardant, all of them will pay to us to do it. And the strength of the test is not test per se, the large pool of it. And we have that, and which we are not doing it. Just because everybody is thinking of their own lab, and there needs to be coordination and cohesiveness, where there will be the largest genetic pool in the whole planet, and then we can dictate and comment for the benefit of patient.
Wonderful. Thank you so much for this last comment, sir. Thank you. With this, once again, I thank all of you, and let's invite you for lunch. Thank you. Another session. I'm so sorry. It's not my job. My apology to you, Dr. Nirav and Dr. Ekta. Please come over and take your session. What's the next one?
Thank you all for that wonderful session. Very disappointing, but we have one more session left, and after that we'll break for lunch. So the fourth session is on role of artificial intelligence in genetics and healthcare. I invite the chairpersons, Dr. Viral Shah, consultant microbiologist, Unipath Lab, Ahmedabad, and Dr. Ravi Gaur, director and founder, DRG Unipath Labs, Delhi.
I think, good afternoon, everybody, and I think sorry for holding you back because I think all our buds were, stimulated by announcement of lunch. But I think we're holding you back for a not very interesting session. Because we have been talking about a lot of things since yesterday. I think today we are talking about what's going to be the future and what is artificial intelligence and artificial intelligence in genetics and healthcare, where it's going to have, especially in genomics involved. With this, I'll have the pleasure to chair the session. I have Dr. Viral with me, and in fact, I'd like to invite Dr. Shaili Mahajan. Shaili is, please Shaili join the stage. I'll just, I have your small. Dr. Shaili Mahajan is a lab director and clinical lead genomics, Center for Advanced Research in Imaging, Neurosciences and Genomics in Delhi. She has been doing a lot of work, especially in the areas of artificial intelligence, especially with the Mahajan Diagnostics in the, in Delhi. And they have done a tremendous work, especially when it comes to the AI application in radiology, and now, of course, doing a lot of work in molecular imaging for them. She has also serves as she's almost like she worked with very 60 global collaborators. She has done her medicine from LTM Medical College, Mumbai, pathology residency from Himalayan Institute, Dehradun, and masters in genomics and arts, Cancer Institute, London. She also served as a visiting scholar in molecular pathology of University of Pennsylvania. Welcome, Dr. Shelley. I think without wasting, we'd like to start this session.
Thank you so much, sir. It's always very humbling to be introduced by your mentors. I know I'm keeping you away from your lunch, so I'll try to make it as quick and interesting as possible. So I'll be talking about artificial intelligence in healthcare and genomics. Artificial intelligence and genomics both are sort of the hot topics and the buzzwords these days in healthcare industry. So I'll be dividing my time into essentially two parts: introduction to artificial intelligence, what is artificial intelligence, how the algorithms are made, and what are the applications in genomics for which we are here right now. So what is artificial intelligence? Essentially, artificial intelligence is not a new term. It was coined some 7 decades back, and it refers to the ability of computers to learn without being explicitly programmed. It has gained recent popularity because of the smartphones, essentially, which you have in your hands. The computing power of a smartphone right now would be at par with the computers which were used to send Apollo 11 to moon. So, so that's why we, in the current era, we are living with artificial intelligence without even knowing it. Basically, artificial intelligence is using high-end computing to find hidden patterns in data. Data and hidden patterns. This is what genomics is about. Genomics produces immense amount of data, and there are so many patterns in the data which we analyze and interpret and come to whatever conclusion. So this is Tesla's theorem. Basically, it tells artificial intelligence is something which is not yet discovered. Basically, for example, if I ask you, have you used artificial intelligence? I'm sure most of you will say no, but my answer is yes. All of you are using artificial intelligence currently. If you have Amazon, Netflix, Uber, Google search, all of this is made of artificial intelligence. How does my phone know that I want to buy a particular kind of toy for my child right now? I think about it, even if I talk about it, Google knows that I'm talking about it, and it starts showing me the results for that shopping. So that is artificial intelligence. There are broadly three kinds of artificial intelligence: narrow, general, and super. Narrow artificial intelligence is when a machine does one job but does it really well, like playing chess. Or general intelligence is something which us humans do. We can do a lot of tasks, but we may be very good at only one of them. And super intelligence is something which basically merges both of these. The opinion is divided on the fact whether it's a good thing if it happens, if it's a bad thing, because of course everything comes with its own challenges. Today, right now, where we are practicing, we are dealing with artificial narrow intelligence. In my opinion, there are two broad categories of AI applications. What humans can do, but a computer can help us do it faster or better, and what humans cannot do. What we can do is, for example, humans can monitor CCTVs. But if I train a computer to do that, a computer might be able to do it more efficiently, in a better way, and make less errors, right? Versus Google Maps. Humans just cannot do it. A human cannot tell me with minutes of accuracy how long it may take me to reach airport from here, right? So we apply artificial intelligence broadly in these two applications. Now, coming to how does a computer learn? How does a computer become intelligent in one particular task? So I'll just give you a little example here. There are two ways I can teach a computer to identify numbers. One way is I just tell a computer or program a computer and tell him that, okay, if there is a straight line going from top to bottom, it's number 1. But versus I give the computer 10,000 images of different numbers and I label each number. Labeling part becomes very important because that becomes the ground truth. like for example, in the morning, if we heard Dr. Borji's lecture, that's where an expert cannot be replaced, because ground truth is the most important thing in artificial intelligence. I'll upload this data and the computer learns by itself that, okay, these are the 1,000 ways in which number 1 can be written. These are the 1,000 ways in which number 2 can be written. Whatever pattern it may find, that is beyond us. The computer may understand in its own manner that, okay, these are the 10 ways. So that is called supervised learning. And that is the most important way of learning when we come to genomics. We give computer lots of data, huge amounts of data, and the computer identifies, or for example, if I take a very simple example of digital pathology, I give a computer 1,000 images or 10,000 images of a normal prostate and 10,000 images of a diseased prostate, BPH or prostatic carcinoma, and the computer finds by itself ways to identify what is normal and what is abnormal. This is called supervised learning. This works only when the labeling is correct, the ground truth given to the computer is correct. Now, how is an AI algorithm created? These are the 4 very important steps. First is, of course, data. Find enough data and as heterogeneous data as possible. If I'm, again, taking the example of prostate, if I'm giving 10,000 normal prostates, we try to make it as heterogeneous as possible from various parts of the country, from various ages, from various, like for a human eye, maybe I don't find any difference between a 35-year-old prostate and a 45-year-old prostate, but maybe the computer finds some patterns and it can even tell me that this is the age of the patient. So heterogeneity of data is very important. Then we train the model. Now, for example, I collect 10,000 such slides of divided into a prostate carcinoma and a normal prostate, and I divide it into 2 sets, training set and validation set. Typically, the ratio is 70-30. So if it's 10,000 sample data set, I take 7,000 and I use that to train the computer. I label the slides and I train the computer. And once the computer says, okay, I'm ready, we validate that model on the remaining 3,000 cases. And then we see what's the accuracy. Now, for example, during validation, I find that there is 80% accuracy. In terms of healthcare, it's a very bad accuracy. So we again tell the computer, like, look, Mr. Computer, this is your accuracy, now you have to retrain yourself. Then the same data is again put in and the computer trains itself. And so this cycle goes on multiple times till we find the accuracy that we want, and then comes the testing the model phase. Now this is actually something like a 16, 17-year-old pampered child goes from home, goes out in the real world and starts living in a hostel. The question is, will he survive or not? That's what happens here. We have validated the platform or the model on known data. Now we see that if I take this model and take it to some other country, like entirely different population, will it work there or not? That's the testing the model phase. And once that's done, then we say that the AI algorithm is ready. So AI is percolating in all the aspects of healthcare, prevention and population health, diagnostics, therapeutics, So, but again, the thing remains the same, that it has to be properly tested and properly validated. And properly taught. The data on which it is taught, that's the key. Now, coming to applications of AI in genomics and digital pathology. I'll take a couple of examples where AI is being used or AI is being prepared for or studied on certain applications. So if I simply talk about our NGS workflow, there are multiple steps, but AI comes when there is at the stage of data processing and interpretation. Now, it's been almost 2 decades since the human genome sequencing project got over, and the amount of data that was produced was huge, and it's ever evolving. So if we send, if we try to count the zeros, this is where we are. There are exabytes of data, 240 exabytes of data, which is a huge amount of data. So the role of AI here becomes, how can you help a human to sort of analyze and interpret this data, make interpretations out of it, apply it to the real world, make predictions, make predictions which a human cannot do. That's where AI can help genomics. So talking about AI in variant calling, variant analysis is time consuming. We do have bioinformatics pipelines, but still it takes hours to do different levels of analysis, and then it may take days to do the clinical analysis of the shortlisted variants. There is a huge amount of data. Cancer genome complexity and technical artifacts make identifying real variants challenging. So again, of course, that's a big challenge because it's not very simple. The cancer genome, it's not very simple. Knowing whether a particular variant is causing the cancer or can it be a biomarker, so to help in all of that, AI can find certain patterns which maybe we may overlook. A machine learning method for classifying variants detected by NGS from different types of tumor specimens, such as colorectal, melanoma, lung, and glioma cancer. This is a study which was done, and random forest is a machine learning algorithm, a system for predicting oncosomatic variant analysis. So it essentially helps the neural. So how does a human brain work? By neural networks. Same networks are being used by artificial intelligence, and it can help in oncosomatic variant NGS analysis, predict whether a particular variant, which may not be as per current databases a benign or a pathogenic variant, can it be based on certain patterns? It can predict that, okay, some years from now, it may cause some kind of disease in the patient. AI also enables automated interpretation of rare genetic diseases. Clinical interpretation of genetic variants in the context of phenotype. Again, huge amounts of data is there. AI simplifies genome interpretation by integrating predictive methods with growing knowledge of the disease. Now, in this particular study, AI was trained on multiple or huge amount of data on NICU patients, where they were compared, who had been done, where whole genome sequencing was done, and phenotypic data was available. So, they found that AI helped to predict approximately 15 to 20 cases where there was no symptoms or no phenotypes earlier, but eventually a genetic disorder was present. So a machine learning method provides a clinical support tool for expediting genome interpretation and more accurately. So now, another application can be liquid biopsy in AI. We know that liquid biopsy, especially in in colorectal malignancies with circulating tumor cells concept, is a very important tool now to almost in real time assess the progression of the disease. So there is a possibility, and there is work going on liquid biopsy, where using liquid biopsy, a machine learning algorithm can tell the primary, can tell the progression of the disease, and a pattern which the machine can predict of how the disease will progress and what's the prognosis of the disease. It's actually a liquid biopsy that combines Illumina's ultra-deep sequencing with Grail's machine learning. So ultra-deep sequencing was done on liquid biopsy, and Grail's machine learning algorithm was tried on that, and the first data showed about approximately 50% detection of early stage lung cancer, where of course, with liquid biopsy, what's the issue? With liquid biopsy, the problem is that we have to go much more than somatic. The depth of sequencing has to be that much to get some information, and especially with something like an early stage lung cancer, the circulating tumor DNA or cell-free DNA is so less that not much information can be given on liquid biopsy. But something like lung cancer, where the biopsy is anyway difficult, it can be a real boon to be able to, detect early stage cancers on a simple liquid biopsy. There is another, it's a GPU, graphic processing unit based AI tool for quicker genomics analysis. It's actually in testing stage, where the algorithm can help us in differentiating between a germline somatic variant or any RNA variants, and of course also tell us about the drug availability for in extracting biomarkers for therapy decisions. On performance comparison, it was the main finding here was that whatever was done in hours can now be done in minutes using AI algorithms. Now, digital pathology and AI for IHC. We know, of course, that IHC is probably one of the oldest tools of diagnosis and risk stratification in cancer diagnosis. But there is a lot of work done by AI on this as well, where AI can detect the not just single marker. We can use AI to predict on H&E slide where on multiple markers. It can be IHC and also FISH. This is another interesting study which is done by Lunit. They've come up with a AI algorithm called Lunit Scope, where what they are trying to do is detecting oncotype DX status using just the H&E slide. So also what they do is that they identify what is oncotype DX doing. They are studying the progression genes, they are studying the mitosis count on cancer epithelium, and all of that. So what they do is they taught the system, the computer, on multiple cases which were done by oncotype DX. The machine was shown the raw data, the H&E slides, and the machine was the slides were labeled with oncotype DX recurrence score, and the machine was taught on huge amount of data of that, and the machine taught itself. So eventually what was found was that it is to some level of accuracy able to detect what the recurrence score can be. The benefit is that it can only straight away be done from H&E slide. There is no issue of nucleic acid extraction, which may be affected by formalin fixation, and also early stage hormone receptor positive cases, where if the lymph nodes are involved, obviously we know that the recurrence rate is high. But what if there is an early stage breast cancer with hormone receptor positive? There it has been found that oncotype DX also has its limitations sometimes. So that's where these prediction tools can help us. Also, there are commercially available prostate histopath AI algorithms, where the AI algorithm can detect prostate cancer in an early stage, or predict the progression of prostate cancer from relatively normal looking prostate slides. Also perineural invasion. So of course a pathologist can do it right now, but what AI can help us is with relieving the pathologist of some sort of triaging the slides, that okay, doctor, this is, if somebody would tell me that out of these 10 prostate slides there are these 2 which have perineural invasion, according to the AI algorithm, I spend more of my time on that. So one thing we always say is that AI is not there to replace any of the experts. And AI is not there to replace a radiologist, a pathologist, a surgeon, or dermatologist, whatever. AI is only there to augment the efficiency of an expert, and that's what these algorithms do. Similarly, there is a commercially available breast histopath AI algorithm where, of course, it helps in detecting early stage cancers as well. This is also a very interesting paper. It's beyond cancer genomics, using AI to detect rare genetic diseases using photographs. Now, what was done here is many such images were shown, photographs were shown to a computer with labeled genetic syndromes. What the computer does is identifies landmarks on the face, similar to like pixels in a photograph or pixels in an image. The computer identifies these landmarks, which we don't know what exactly the pattern the computer identifies, and processes the images to in its GPU, and then gives this kind of result. It tells us that this particular child is closest to these particular syndromes. Now imagine doing this with genomic data. So the kind of possibilities in terms of accurate diagnosis of a rare genetic disease, it's endless. Now coming to radiogenomics, detecting EGFR KRAS status from CT scan images. Now we know that how important EGFR is for patients of lung cancer treatment. Now what AI does here is it identifies certain patterns in CT scan images to detect or predict, sort of, not detect, predict the EGFR status in a patient. In this particular example, the features used were emphysema and ground glass opacities. So such things become important because, again, I am getting a CT scan done for a lung cancer patient, and within minutes telling that, okay, this is probably EGFR positive, because because we in our practice find that sometimes it becomes very difficult to find a lung biopsy in a metastatic lung cancer patient. Another example from radiogenomics is detecting IDH mutation status from MRI using AI for glioma patients. Here again, a machine was given multiple images of MRI in glioma patients and tagged with their IDH status. So machine again learned itself, found some patterns in MRI, and started, to some level of accuracy, started telling the IDH mutation status. This is predicting COVID surges from using machine learning. This is actually done in IIIT Delhi at Dr. Tapritesh Sethi's lab. They tried to predict the COVID surges based on the data that they had. So till now here, if you can see this particular surge, very aptly the machine predicted, but it sort of missed this surge because this was the Omicron variant, and the machine didn't have any data on Omicron variant on which it was taught. So that's again the importance of the kind of data we are teaching the machine with. Similarly, there are about more than 150 approved FDA healthcare products, healthcare AI products on artificial intelligence, and the possibilities are endless. These are just very few studies which are tried to bring to your notice to just imagine the possibilities that we can have with AI and genomics. So I'll just quickly finish my talk with certain issues which are not, which nobody is essentially thinking about: technical issues, ethical issues, legal issues. what are the consequences of AI going wrong? Who will take the responsibility? What are the clinical consequences? What are the commercial consequences? I don't think anybody has an answer to that yet, because this has not been explored yet. AI algorithms need to be tested on real-world independent data. Like I said, there is one thing to validate an AI algorithm on one particular data, and another thing of it working in a completely different environment, completely different setting. This is something which we have been doing in our lab. This is a published paper where we actually proposed a framework for algorithmic auditing to avoid such issues. Ethical issues in AI are the hottest topic of research that no one wants to do, because we don't even know who actually owns the healthcare data. Does the patient own the data? Does the healthcare provider own the data? Does the government own the data? And what about de-identified data? Is it actually, there are no policies on that yet. In fact, when it comes to data privacy, data protection, the government has recently, in fact last week only, withdrawn data protection bill and is to come up with another policy which is not yet disclosed. Again, legal issues are also open. Who takes the blame for AI going wrong? With that, I'll end my talk with this is my team of brilliant scientists and researchers in Delhi. Thank you so much for your patience, and I hope I made some sense. Thank you.
Thank you, Dr. Shelley. It was a very interesting talk. I'll just take 1 minute before we end. I think all of us are waiting for the lunch, I'm pretty sure. Like what we learned is summarized for it to the point is, AI is the, you can say, the simulation of intelligence in non-living agent. That's exactly what we've done. In context of clinical diagnosis, AI framework enable the efficient interpretation of large complex data, number one. There's a time series analysis, or could be the forecast, future and prediction. Then phenotype to genotype mapping and genotype to phenotype. There are regulatory ethical challenges I think we all need to address. One of the questions probably he's coming to us is like, will it replace human being? No, I think that's very, very clear. It's going to be artificial, probably going to be augmented intelligence. It's augmenting what we know so that we have a better time to ourselves to use that time for more productive information or better information to the clinician. There's no reason today that human mind can keep with AI, keep it with the AI machine by next decade. I think artificial intelligence is intelligence and normal intelligence? No, I think that's one. But it's equally important because change is important. We had to adopt it in the practice. That's what the learning, what we're writing here. But two things I like. One thing I've seen, I have to add what you say, the face. There have been developed in the Stanford University in US, they have developed some kind of a mirror, actually. If you're a smoker, based on your face, you just go there. They will say, look, you're looking like this today. 20 years later, your skin will be like this. And that's something, this is, probably that's where the help will be, the prevention of cancers and smoke. If you smoke, this is going to be your face. And if nothing like looking at a bright face and a skin, if you see that change is happening, probably that can help you. Similarly, there are many, many things which have already been developed in the world. Also, I think the very fear is, like, if I feed my all data into my system and an AI comes out of the analysis, you're horrible. What will happen to that? I think, but we should be ready for that. I think this is going to be the future. And I think more we learn, more we understand from each other, I think that's the futuristic. But the last question is always, I think, that is when it comes to the diagnostics, because the molecular, so today's prescription will change. Doctors are writing symptoms, features, this, 5 tests, 15 tests, all kind of a thing, and then the medicine. But will it be like that? We just go to a lab or diagnostic center, give our sample, and it comes out of the real-time sequence. And that sequencing is the code. We go to a chemist, this is my sequence, give me my drug. I don't know. I think that's something the future should be. But this is going to be. But I think there's a lot of human intelligence have to go into it before we actually reach that stage. With this, I thank you so much for the call.
Sir.
Anything more?
Yes. Sir, one of my experience is that, there are multiple point of care instruments like multiplex PCR, like BioFire, Cepheid, in case of infectious. They are giving results within 40 minutes of 30 bacteria, viruses, and they are giving whether it is positive or negative. But the human intervention come, and our role is come over there, that we interpret that data and then guide the clinicians to start the right treatment at the immediate current time. So it helps really the patient and reduces patient cost also. Like one of the example is when we are running the sputum sample in case of BioFire pneumonia panel, we got multiple organisms positive result in single sample. Like it shows positive for Klebsiella, positive for Pseudomonas, positive for Acinetobacter. Within 40 minutes, it gives the results. But now the role comes of us that we have to guide the clinician whether which bacteria is significant for that patient. For that, we require history. For that, we require the patient's prescription, which antibiotics are going on. So there, our role comes, and then it helps.
Yes. I think we can only take one question. Or Sandhya, you want to have, and after that, let's give you one minute.
Sir, I also have one question.
Dr. Mahajan, that was an excellent talk. I think you very simply put it. Just to add to the experience, I think I agree completely with Sir when he said human intelligence is required. I did a small project. I mean, I did my PhD from IIT Madras last year, and the second part of my project was AI. And I looked at CD8 that you showed very briefly in breast cancer. And what he said is very, very potent, because I had to train again and again the MATLAB software to look at the CD8 stained cells. And I think that is where the intelligence lies. So you have to train the computer till it gives a validated report. And I don't think the replacement will happen, but a pathologist or any diagnostician aided with AI will be the future. I think that is what I want to take back from the
Thank you so much.
Thank you so much, sir.
I have one question for Dr. Sherry. So you showed one slide where you showed the rare genetic disorders, and so when you say that we do not know what the computer sees, I just wanted to understand, is it not the humans who tell the computer, look, these are the 100 images of Down syndrome, you just have to calculate the interpalpebral fissure, the distance between that, or you have to calculate the width of the nasal bridge. So is it not we that we feed into the computer?
No, so that's exactly the point. So when I am putting in the label data, when I said supervised learning, we are telling the computer that these are the, for example, 100 patients of the faces of 100 children who were diagnosed with Down syndrome. Now the computer will find those patterns. Why are these 100 patients Down syndrome? Why are these 100 faces normal or not Down syndrome? So it's like a binary classification that the computer will do for itself, Down syndrome versus no Down syndrome. So it's like that. So computer basically trains itself to, and then of course, like Madam just said, when we retrain the computer till the time we find we get the accuracy which we want. So yeah, that's the thing.
So thank you so much, and I think now break for the lunch.
Yes.
And I think probably the learning right is, artificial intelligence. Based on yesterday morning what we had, yesterday afternoon what we had in the lunch, what we had in dinner. Let's guess what we're going to have in lunch today. That will be probably the algorithm coming up. Have a good time. Thank you so much.
Thank you, Dr. Shelley, for such an exciting talk. I thoroughly enjoyed every bit of it. I'm sure the audience did too. Thank you, Chairperson. We'll break for lunch and we'll start at 2:30 sharp.
Hello.
Welcome back everyone. We'll start with the fourth session on infectious diseases. This will have two plenary sessions. I invite the chairpersons on stage, Dr. Kalpesh Sukhwani, infectious disease consultant, Apollo Hospital, Ahmedabad, and Dr. Sanjay Rathore, associate professor microbiology, COVID nodal officer, AMC, Medical College, and Seth LG General Hospital, Ahmedabad. We would request the chairpersons to kindly start the session.
Good afternoon, everybody. I hope after the very nice and high-calorie lunch, it would be very difficult to attain the topic on whole genome sequencing. But at the same time, it's a very important topic, especially for me and I think anybody right now in our country. So, because antibiotic susceptibility is a major issue right now. So, our first topic would be now role of whole genome sequencing in antibiotic susceptibility by Dr. Madhvi Joshi. She is a joint director at Gujarat Biotechnology and Research Center, Ahmedabad. So welcome, ma'am, Dr. Madhvi Joshi.
So can I have my presentation over here? Okay, yeah, that's it. So good afternoon all of you, and I'm sure that this would be quite a sleepy session, so I'll just try to speak as less as possible and not to bore you with lot of terminologies, assuming that there are a lot of doctors here and bombarding them with the genomics information. So I'll try to simplify the things. I have taken little liberty in my topic over here. So basically I represent State Government of Gujarat Institute, that is Gujarat Biotechnology Research Center. The core strength of our center is into genomics, and we apply genomics into all aspects, that is into healthcare, agriculture, environment, industry, everywhere. And one of the major issues that slowly we are now all realizing is the importance of One Health. And when we say One Health, because the human health is also connected in many ways with the environment and with the animal health. So in that connection, we are running two programs in my center. One is One Health Poultry Hub. That is a very big program. I'll come to that. And second program is the state government has initiated, and probably this is the first program in India, where 39 laboratories, including clinical labs, environmental labs, and from animal husbandry, fisheries, as well as dairy colleges, they have come together, and we are doing an explicit survey of the antimicrobial resistance in all these domains. So I'll be talking mainly about the role of genome sequencing in AMR, but in that we would be focusing on two aspects. So One Health, briefly I described that human health, which is also connected with environment health, and it is connected with the animal health. We all know due to COVID, which is a zoonotic disease, how the entire mankind was affected. And similar way, it has been predicted that the next pandemic is going to be the pandemic of antimicrobial resistance, where you would be seeing a lot of infections where we are unable to treat the patients because they are either having infections from MDR or XDR isolates. So in that connection, we are working as far as in this project is concerned. Primarily everybody thinks that due to human consumption AMR is increasing. But the fact is other way around, the animals which are raised for meat, for example like poultry and in fisheries, they are heavily fed antibiotics so that their health can be sustained. So in this diagram, if you would see, this is the antimicrobial consumption for food and animal production by country. This is in 2013, it's the light red, and the dark red shows the projection by 2030, and it's going to be a very huge challenge. The global antibiotic resistance hotspots, if you look at them, so in that also, as you see, I mean, India is having a very high threat when the AMR is concerned. So in this One Health Poultry Hub, what we are trying to map is that we are identifying the poultry distribution networks. This is one of a very big program which is funded by UK's Official Development Assistance ODA program under Global Challenge Research Fund. And the role here is to understand what are the threat points from the poultry value systems that could affect the mankind in future. One that is for sure that everybody would know over here is bird flu. I mean, we all know that bird flu is one of the major factor of zoonosis. In this project, we are basically running this program with the help of 25 organizations from 7 different countries. And we are studying from India, Sri Lanka, Bangladesh and Vietnam. In this program, we are primarily trying to understand 2 factors. One is the risk of zoonotic diseases, and second is the risk of antimicrobial resistance, how it is spreading from one value chain to the other value chain. And that is where probably, at the end of the session, you will realize that why this talk is also important to understand, because we need to understand how the AMR is migrating into the whole community. So this is basically some investigators. I mean, from India, we have people from JNU, CMC, Vellore also. We have clinicians like you who are working on foodborne pathogens and specifically focusing on Campylobacter coli and jejuni. We are also working on non-typhoidal salmonella and E. coli, which are high pathogenic E. coli from the poultry value system. And we are tracking it down to how they are reaching up to consumer level. So primarily, in GBRC, our role is to understand. So it's a very big project, and in that there are 4 basically, programs. But here our role in GBRC is to understand the prevalence of antimicrobial resistance in the poultry samples as well as in the poultry environment samples, and how they are transmitting from there to those who are closely working with the poultry systems. So that is there, and also to analyze some of the pathogens, as I mentioned, Campylobacter coli, jejuni, non-typhoidal salmonella and Escherichia coli. So in this project, what we have done is, first of all, antimicrobial resistance, I mean, there are many genes which are deposited into national or international depositories. From that, we have taken, the gene panels. And I think for the last 2 days, all of you would have heard about genes and custom gene panels. So for antimicrobial resistance, it is a metagenomics study basically, wherein we are trying not to look at an individual patient. Usually what happens, when you deal with clinical samples, you are only looking at one individual and what is happening to that individual in terms of gene. To an extent, in terms of cancer, we go for germline mutations and mutations which are in tumor, somatic mutations. But in metagenomics, basically we are trying to understand the whole of a community, how that community is playing a role and how it is interacting with each other. So in this, basically we collect samples from humans, farm animals, as well as the soil samples which is prevailing in that. We take out the community DNA rather than individual DNA, and that is called as a metagenomic DNA. Same pipeline, I mean the library is prepared and then it is run through sequencer, and through bioinformatics, you know, the analysis is performed. So here, I mean, with the literature we could identify two panels. One is AMR panel, that is antimicrobial resistance panel. This panel actually contains 478 antimicrobial resistant genes which are reported in the NCBI CARD database. Another panel is called as a pan-bacterial research panel. In this basically there are 32 different antibiotic classes are covered, and along with that some of the bacteria, their identification is also covered into this panel. So we validated this. So this is the detailed list of the 29 class which are covered in AMR gene panel, including carbapenem, chloramphenicol, quinolones, and all that are being used in different these things. Similarly, for the implicit pan-bacterial community panel also, as you would see that the genes for MDR efflux, methicillin, all vancomycin, phenicols are covered. Along with that, 21 species also you could identify. So this is meant for use primarily in the clinical samples. So our study was little tricky, so we did some validation, and for that validation of both the panels, which is going to work better for our system, we have collected samples from the chicken fecal, poultry soil, and chicken Zika sample. So chicken Zika is basically something like our gut, where the majority of the microbial diversity of the poultry is present. So we have taken sample from that, and we have used in this Thermo Fisher S5 platform to run the next generation sequencing for both the panels. So as you can see that sample wise we have taken almost 0.5 to 2.6 million reads, same for the pan-bacterial research panel as well. And this is a typical analysis pipeline. So basically in metagenomics also you have to do the quality filtering, and then after the quality filtering, because this is a targeted panel, so there are already available databases where you know the antimicrobial resistant genes are deposited. For example, One Codex is a paid software, then Cosmos ID, AMR Finder, and the NCBI CARD database or RES Finder using the Galaxy Abricate tool. So as you can see that when we are looking at antimicrobial resistance gene, this is basically the heat map. So heat map tells us the abundance of a specific antimicrobial resistance gene in a particular sample, and we have compared here across the soil, Zika and feces. So more or less, you know, we were getting more genes covered in AMR panel. So we narrow it down that we would be doing bacterial panel separately and AMR panel separately at the end of this study. So once the panel was finalized, then we also worked on validation of the platforms, because this was a cross country and multi-country study. So it's not possible that everybody would have the same platform, but when you are doing a study at such a large scale, you need to compare between panels and platforms also available. So we have run some samples on both the platform, that is Illumina S5 and Illumina MySeq and Thermo Fisher S5 in this. And as you can see that the result of both the platforms did not vary that stringently. So this is again, you know, the comparative chart of more than 1% abundant AMR genes across different platforms. So except for TET40, where you see, you know, the Illumina was giving us a higher abundance compared to Thermo Fisher platform. So we also tried, and because we are molecular biologists more, so we are a basic scientist, so we went and understand that why this artifact is created. So then we learned that for TET-O basically, you know, the length of the amplicon is only 80 base pair. So in the Illumina, you tend to have a competitive binding. So there is a more, you could say, abundance that we could get in Illumina platform and not in Thermo Fisher. And similarly, INUC gene that you see, so in that we got more reads for Thermo Fisher platform. So after that, I mean, more or less results were same. So we choose to go with both the platforms at different laboratories. Then this is a very important study that we did, which was at a pilot level in collaboration with Banaras Hindu University team. So what happens is, you know, sometimes, I mean, when you are in Gujarat, you know, Gujarat is a vegetarian state. And we think that, oh, I am not eating poultry or anything, so how my health is going to be affected with antimicrobial resistance that is present in the poultry system. I have nothing to do with it. But when we carefully look at these systems, the poultry manure is used as fertilizer in agricultural farms. And in order to understand that how from the poultry, you know, all the value chain or even the consumers are affected, then we conducted another study where we actually tried to look at how these antimicrobial resistant genes are spreading from one place to other place. So in that we set up a experiment in the field and plant. So of course, I mean, these are some of the list of the antibiotics which are heavily used. They are mixed with the feed itself and they are fed to poultry. So basically, when you look at this gene, of course, there was a very important decision taken by Indian government wherein, you know, the colistin was banned for use in any of the animal production system, you know, to just to make it safe for humans. But still, I mean, almost all type of the antibiotics which we are taking is also used for animal system. So in this, basically we designed two experiments. One was a field experiment and another one was a pot experiment. So in the field experiment, we have taken the poultry litter from both the farms, broiler as well as layer. So broilers and layers, one is used for egg production, the other one is used for meat production, two different varieties. And then from there, the field soils where it is used as a fertilizer, then from there it automatically gets, you know, absorbed into the plant root and then the plant stem. Similarly, because this was a field experiment and there could be lot of variations into that, so in a control condition also we set up the same experiment where the poultry litter was taken, added into the pot soil, the plant was grown and then the plant stem was analyzed. So from this, if you see, everything was run into the triplicates. At the end of the metagenomic analysis for the presence of antimicrobial resistance genes, we could understand that the broiler litter had shown the higher transmission of antimicrobial resistant genes compared to the layer poultry litter. And the most common antimicrobial resistance genes that we could identify from the poultry litter was the plasmid or transposon encoded chloramphenicol resistance, that is CMX, ERMX, which is rRNA methyltransferase, ERMF, plasmid mediated nucleotide transferase, and the beta lactamase from TEM98 and TEM99. If you look at the most common organisms which were abundant, that is Escherichia coli, Staphylococcus aureus, Enterococcus faecalis and Pseudomonas aeruginosa and Vibrio cholerae, and all of you know that these are either opportunistic pathogen or pathogen. And the drug classes also we have written. So now this was just a result of next generation sequencing, and many at time, you know, we fail to believe what NGS gives in metagenomics. So we needed to do validation of what we found out in next generation sequencing is also actually happening in this. So we had got two choices, either we use real-time PCR or digital PCR. And I'm sure, you know, the learned audience already knows here the basic difference, where in qPCR we get a relative CT value what is we call it as RT value. But in digital PCR, we can get absolute numbers because your sample is getting based on the platform. For example, in our lab, we have QIAGEN, QIAQT digital PCR. So the sample gets equally divided into 26,000 plates. And from that, we are detecting either absence or presence of PCR reaction. And another advantage with the digital PCR for such type of validation is because AMR genes are not abundant in soil. I mean, they are very rare. And when you are trying to detect rare things, like in cancer liquid biopsy, we are trying to identify, some of the rare changes, then, because the machine works on Poisson distribution, we get better results. So I will skip this slide. So basically for validation, we took all the 5 genes which we found predominant during our metagenomics analysis, and we designed their primers. This is just a normal PCR gel which shows the amplification optimization for all 5 genes. In this slide, I would like to highlight that if you look at the broiler liter sample, the layer liter sample, the field experiment and the pot experiment. So the first table shows the relative abundance of all, sorry, there is a pointer, I missed it. Okay, okay, okay. So here there is a relative abundance of the genes that we got through metagenomics, and in the second line you would see we got the gene copies from the digital PCR from the same samples. So let me just more simplify that for you, that here if you look at the broiler liter, you could see that there are as high as 3000 copies for CMX. So there are different copies of 5 different genes. If you look at the field soil control, absolutely 0 copies were present. Even in the field soil where the broiler liter was treated, we could not detect. So that means, the first thing is that, from the soil we could not detect those. But just after that, if you look at the field root samples and the stem samples, the AMR genes are getting enriched. That means, it is passing from soil to the final plant product through the root systems. So this is for the broiler experiment done in the field. Similarly, we got the results for the layer samples in the field. As you could see that the liter genes were also getting expressed into the stem and root system. This is a pot experiment where we proved the same thing, although the stem had a little lower abundance compared to the soil samples, and similarly for the pot. So basically, with these all experiments, what I am trying to highlight over here is when we are talking about antimicrobial resistance, it is not that it is something newly emerging. And we all know that since the discovery of the antibiotic, within few years only, the organisms are going to develop the mechanism to develop a resistance for a particular antibiotics. But after this experiment, what we need to understand is that how and what are the mechanisms where these AMR genes are migrating from one value chain to other value chain. And it may not be important today for me, as I said, that I am a vegetarian, who cares approach, but after looking at the results, it clearly gave us a message that we need to take everything in a holistic picture as we did during COVID. So during COVID also, like my lab worked on various aspects, including genome sequence, human genome sequencing. We did host genotyping study, and in that we identified tumor necrosis factor TNF-SF4 and 18 superfamily, which increases the risk of post-COVID myocardial infarction by 20%. And all of you would have seen that, people, they could recover from COVID, but then they succumb to myocardial infarctions post-COVID. Then also the wastewater based epidemiology. So again, you are detecting COVID from the sewage sample, and at least 14 days in advance you are able to predict when the next peak is going to come. So all these things are very, very important, messages where I am just trying to convey that we have to look at the picture very holistically. I don't have the data for the second program, which is a very large program on antimicrobial resistance that the state government of Gujarat has already started, because the program has just begun. And in GBRC, we are going to actually establish a repository of these AMR cultures, not only from clinical samples, but also from, animal samples like milk, the Zika and all other important parts. And we are also going to screen environmental samples using metagenomics approach to understand how the AMR pattern is migrating between different ecosystems. So with this, if we have to overcome antimicrobial resistance, not only antimicrobial resistance, but any of the threatening challenges to mankind, rather than looking into silo, we will have to look at the One Health approach, try to understand how these systems are interconnected, build capacities. I mean, it was a very good example where, during COVID, we were talking to doctors, we were talking to people from environmental background, we were talking to people from the pathology background, and microbiologists from hospitals, treating doctors, Ayurvedic doctors, and together, when we combine the strengths, I think we can tackle the great challenges of mankind. This is just a glimpse of what we have at GBRC. We have Illumina MySeq, of course Thermo Fisher S5, S5 Plus also, then NovaSeq. In bioinformatics also we have got Supermicro 112 core 3 TB RAM HPC setup, and recently we established MALDI-TOF for bacterial identification also. Our lab is a shared laboratory, so any of you want to come and use that setup, just like a book my show, you have to just click it and you can come book your machine, and then you can come and use the setup. If students are coming to use our facility, so there is a state government's provision wherein we are providing 50% discount on the consumable also. That means the 50% cost is borne by the state government of Gujarat. Thank you very much for being such a patient audience. And I would love to have questions if there are any. I don't know, the topic was quite offbeat, so.
Can somebody pass?
Very wonderful work. I was curious why there's a difference between the antimicrobial resistance genes between the broilers and the layers. I mean, I thought they came from the same field.
So basically, yeah, they are given the same feed, but the microbiome content of the broiler versus layers, if you look at it, it's pretty different. I didn't show the data over here because, so we are also parallelly doing 16S microbiome from the Zika sample, and the microbiome difference is also there. And all these genes are ultimately attributed by their microbes, so that could be one of the reasons.
And so I'm not sure if these are males and females different, or they are all females. I thought the broilers would be females.
Yeah.
And the layers are males?
Males and females both.
Achha, both. So I was just wondering if there are any sex differences in these kinds of antimicrobial resistance.
So one difference was in the 16S microbiome. Of course, we have not looked at sex-specific changes, but yeah, that's a good point. I mean, we could look into that.
Wonderful work.
Yeah. Yeah, there is one question there.
Hello. Does this study done in a region wise, or in a commonly and randomly taken sample at any places, or
no,
in a
so
region wise?
yeah, that's a very good question.
Yeah,
so
because
how
region wise is there may be a different antimicrobial resistance we are developing, in which we are more consumption, or where we are
so I'll tell you how we have done the study.
Yes, yes.
So in the first phase of the study, this study is primarily conducted in 4 countries. In India, we are doing it in Gujarat and Tamil Nadu, that is TANUVAS, Tamil Nadu Veterinary Agriculture University is doing, and also CMC Vellore. Then we have from Sri Lanka also, Bangladesh and Vietnam. And at every places we have first mapped the PDNs, that is poultry distribution networks. After mapping of the poultry distribution networks, which is based primarily on the density of the poultry farms, what we have done is, we have identified which are the shops that we are going to pick up. So we are taking an end-to-end. We are taking first the farm, then farm to the supplier, supplier to the actual retail shop, So that is how we have mapped the entire PDN. And from that PDNs we are collecting. So in this study we have got around 5 to 6 poultry distribution networks covered from all these study sites. Yeah.
I'll speak louder.
Yeah.
What is the objective of that repository which you are trying to build with this antibiotic resistance?
Yeah, that's a very good question. So we don't want to just stop at mapping AMR, because at the end of the day, I mean in Gujarat specifically our bureaucracy asks the question, so what? I mean if you have mapped the AMR from 10 different locations and 100 different systems, what is the solution? I mean if you cannot treat AMR, what is the fun of studying this? So the long term objective of the network is also going to looking for the innovative molecules or the drugs where we could treat them, and for at that time we would need the resistant organism. So that is basically the objective for making the repository.
Really impressed, and thank you so much, because in yesterday MPAI's GBM meetings we were discussing about having even the repositories of pathogens which are commonly detected, and that's well in demand by most of the hospitals, pathology labs, or even the new pathology kit developer companies which are made in India. So if you are so open and supported by Gujarat government, possibly we could also assist you with helping build that repository.
Sure, we are open for collaboration.
It is not very easy with ICMR institutes.
So we have basically 6,000 microbes, but these are not pathogens. So that repository we built it from the different environmental samples, mainly comprising of the non-pathogenic flora. But now with this project we also aim to build AMR repository.
Yes,
but
yes.
I mean we are not working here primarily on the mycology. We want to first start with the bacteria and then slowly build on it.
Yeah, morning Dr. C.G. Joshi was there, so
Yeah.
he mentioned about plans to have a BSL-4 facility. So
Yeah,
possibly
so
you are able and competent to manage even hold the repository.
Yeah,
of
so
pathogens.
state government has sanctioned 250 crores for establishing a state-of-the-art BSL-4 laboratory in Gandhinagar district. And the DPR is under finalization, so we are also actively working on implementing that project.
Congratulations, ma'am.
Thank you. Thank you so much.
Yeah.
Sorry.
Thank you.
Shall we continue for the next session? Thank you very much, ma'am, for such an interactive and such exhaustive work you are already doing. Thank you for the kind inputs. We will move forward to the next session. Our last 2 year most common COVID genomics. I'll invite Dr. Vinod Skaria. He is a principal scientist at CSRI Institute of Genomics and Integrated Biology, CSRI IGBI, Delhi. Welcome, sir. Please. Thank you.
Yeah, thank you very much. And over the next 25 odd minutes, I will sort of briefly explain what we learned from the COVID genomes from India. Before I start my talk, let me also introduce the topic, and I'm sure every microbiologist know who this is. This is Anthony von Leeuwenhoek, a scientist by not profession, by hobby, and by profession a merchant and a municipal official. Now, his claim to fame has been the mainstay of modern microbiology, and what he invented was this handheld device which we call today as a microscope. And using this microscope, he could see a lot of organisms which were not seen by the naked eye. Now, why did I put this slide? I put this slide because microbiology and observing the microbes under the microscope has been the mainstay of microbiology and even remains so.
While over the last decade and a half, there have been a different kind of revolution happening across the world. And of course, you have heard over the last 2 days about this, so I will not delve deeper. But the point is that genomics is picking pace both in throughput, in scale, not just in terms of the number of projects, but also in terms of making it really, really affordable so that everybody can afford to get genome sequences in the future. Now, why did I put these 2 slides is because microbiology is also changing very rapidly. And typically for any other outbreak that would have happened, for example, a decade ago, would have taken months, if not weeks, to get to a diagnosis, because that would involve identifying the organism by either culture, isolation and observation under an electron microscope. For example, a virus like SARS-CoV-2 would have taken weeks before it would have been identified. Now, that didn't happen in the SARS-CoV-2 outbreak, and that's largely because you can now compress all this into a very small time thanks to genomics. And with genomics, you don't even need to isolate an organism. You can actually take the sample right from the patients and sequence the organism, because they have nucleic acid, DNA or RNA. And from the sequence, you could identify the organism, and not just identify them, you could put them into the context of the molecular phylogeny and understand what kind of organism is this. So that has really, really transformed microbiology, and is increasingly going to transform microbiology. You would have heard about the AMR from the previous speaker. So multiple different applications in genomics that is changing microbiology today. Now, the basis of all of what we do is very simple. Every organism mutates, and that's the way we all evolve. Even humans do mutate. But the difference is only that the rate of mutations are different for different organisms. So RNA viruses mutate at a much higher rate compared to DNA viruses. And of course, that is the basis of all what we do in epidemiology. And pretty much an organism or a type of organism would have a quite constant mutation rate across the tree of life. Now, when you know that you have mutations, you could also place these mutations over time because they accumulate one after another. So, if you take say 8 mutations, you could place them in the context of one another. So, for example, if you have a mutation 1, mutation 1, 2 makes it a chain, and the third mutation could be 1, 2, 3, 1, 2, 4, so on and so forth. Since the mutation occurs at a very constant rate, you can sort of trace them over time, and your expectation is that if it's a random occurrence, then every single type of chain of events would have an approximately same proportion. But that's not what really happens in real life situations. You would see, for example, 1 to 4 has a much larger proportion at a particular time point, and this could largely be what we call as emergence events. Now, emergence events largely could be contributed by host factors, like for example, super spreader event. If there is a COVID positive patient in this room, I'm sure everybody would get COVID because nobody has a mask. But of course, the other possibility is that your virus could evolve and make it more transmissible. So, for example, if there is a new variant that has come in which is very more transmissible, then you would have a very large number of people in this particular room and outside this room with that particular kind of a variant. So, looking at the genome sequencing, you are essentially going to look at mutations and the chain of events and sort of gain insights on what really happened at the point of emergence. Now, when you sequence genomes, you are essentially going to sequence genomes and find out where the changes are, and by looking at the changes, you could sort of put them together because there are multiple different genomes which would share common mutations, and this is what we call as a clustering approach. And using clustering, you define a particular lineage or a clade. So, a lineage or a clade is nothing but an epidemiologically linked set of genomes which share common or unique mutations between them, nothing else. Now, some lineages could have some advantages, some would have some disadvantages, and essentially you could name them, classify them into a nomenclature, and sort of trace them over time to see what really happened to each of those clusters. And that's essentially the basis of all what we do in genetic epidemiology. Now, even more importantly, when I said that you can trace such lineages over time, since I said earlier that we have a constant rate of mutation given a particular organism, you could now go back and trace at what point in time did the emergence events happen. Or in other words, you can reconstruct a virus which caused that emergence event, and you can sort of date it in time given the number of mutations that are accumulated over time, and be able to say at what point in time did that emergence event occur. So, for example, if you have a set of variants which would emerge say a week or a couple of weeks from today, we could now trace it back to an event either epidemiologically or through using genome sequencing. Now, the other application of such timing is that it could identify cryptic transmission of pathogens, and this is one of the earliest papers from the United States, where they're looking at the genome sequencing of sequences of isolates from multiple different places. They could identify that the virus did come into the United States of America at a particular point in time, and you could sort of reconstruct that particular virus and say that the virus introduction and transmission happened at this point of time. And this is very, very important, especially when you are talking about new introductions. Now, until mid 2020, the means and methods to do large scale genomics did not happen. Right? Of course, people were doing ones and dozens of genomes, but the means and methods of doing very large scale genomes did not happen. And one such, the first methods is a COVID-seq approach, which was bought by a company called Illumina, which was a modular test which could sequence anything from around 384 to 3000 samples in 24 hours. Now, we were fortunate to be in here because we were one of the first clinical site for the validation of this particular test, where we worked with a number of states to create surveillance programs, and we could actually test this methodology out, which today is the de facto surveillance tool for SARS-CoV-2 across India and of course across the world. And coming to the early surveillance programs, we worked with multiple different states, 7 states, where we could establish a surveillance program at least a point in time to understand what are the prevalent variants which are circulating across in the population. And the choice of the states was largely because there was no genome sequencing from those states. There are of course multiple states which had some level of genome sequencing because there are multiple other organizations which were doing sequencing from there. And from the surveillance, what we realized is that we did identify a small cluster of genomes out there in purple. I'm not sure it works, yeah, in purple in here, which was distinct and different from all the other lineages out there. To put in context, you have the 2 genomes out here. This was from Kerala. These were from travelers out of Wuhan, and the earliest genomes and this COVID cases identified out of Kerala. And of course, you have this large blue cluster, which essentially is the A2A clade of the variant, and this largely is out of Europe, and it did have very specific genetic mutation called the D614G mutation, the spike protein, which made it more transmissible and therefore was spread very quickly across the world. Now, this unique purple cluster was very interesting to us, so we did follow it up across the country from our surveillance programs as well as data from other surveillance programs, and we did identify that it has a variable distribution across the country, very high proportions in states like, for example, Delhi or Telangana or Andhra Pradesh, but much smaller proportions are of course the variant did not exist in Kerala and many other states. And by timing the evolution of the virus, we could actually identify that this came out of a super spreader event, a very early super spreader event as sort of depicted in there, which suggests that from the super spreader event, this virus went across multiple different states. And of course, epidemiologically, we could link back to this super spreader event in point and time, which sort of coincides with the event. Now, of course, you could trace this virus over time, and that is the chart in the bottom panel. And you could see that this particular genetic variant did not have much of an advantage, and the early increase in cases was largely contributed because of the super spreader event or large number of introductions. And eventually, it was taken over by the most prevalent lineage in blue, which was the A2A lineage, which came out of Europe. And such genetic epidemiology can also trace a large number of outbreaks, and this is from around late 2020. Where we sort of suggest that almost all cases of SARS-CoV-2 in India came out of very large super spreader events spaced across multiple different states. It's not just one super spreader event, but multiple super spreader events almost in every one of the states, which could now be epidemiologically linked. And this is of very great importance because there are states like Kerala, which has a very large expatriate population, and everybody believes that the cases came in from the expatriates. But unfortunately, the expatriates did have to go through a much rigorous quarantine measure, typically ranging anything from 21 days to 30 days, and therefore people thought that we should stop people coming from the Middle East and other countries. So Kerala set up the genomic surveillance program in November 2020, one of the first states to create a very systematic surveillance program with the idea that you would be able to sequence 100 samples from every single district across the time point, and this was funded by the state government as well as part funded from CSIR. And over the time, to 2020 and 2021, we could offer quite elaborate guidance to the state in terms of early warning signals when a new variant emerges. And of course, Kerala was one of the first states to put in a double masking as a mandate in April 2021 when the Delta wave was emerging across the country. And of course, over time, this surveillance program has given quite elaborate insights which prepared the state into handling the pandemic. Now, of course, the other application of genome sequencing, as you know, is to understand genetic mutations and the functional implications. And one of the functional implications is in the area of diagnostics, because essentially what we do in RT-PCR is to use a set of primers which could bind very specifically to the genomic region, and therefore, any mutation in the primer binding site could adversely affect the efficacy of the particular primer. So, you could look at specific genetic mutations provided you have the primer sequences available, and that is what we did across the early isolates from across India. Each red dot is a genetic variation in the genome, and the y-axis is the variant frequency, or how frequent is that particular genetic mutation in the population. So, as you see here, there are some genetic variations which are quite prevalent in the populations. We did find around 13 genetic mutations in primer binding sites which are quite frequent in the population, which could adversely affect the efficacy of diagnostic primers. Now, of course, this information in many ways is not really applicable, because even if you tell that a particular primer has a particular genetic variation, the primer details or what primers are used in a particular kit is typically not disclosed to the public or even to the governments. So, that becomes a problem, but that is an opportunity, because as you see here, there are many regions in the genome which does not tolerate genetic variations, and therefore, that is an opportunity to build new kind of genetic testing kits which does not get affected by such genetic mutations. So, we did build one such genomic guided diagnostic test, which is today marketed by Siemens. Now, of course, you could address a lot of other biological questions or clinically relevant questions using genome sequencing, and these are essentially clinical situations where you need to differentiate between, say for example, reinfection, reactivation, breakthrough infections, or persistent infections. And genomic sequencing is extremely useful in differentiating each of them. And one such case is from Dr. Vivek Gupta, who is also in the audience. And Dr. Vivek was very instrumental in creating one of very systematic surveillance programs using RT-PCR for healthcare workers. So, in his hospital, every healthcare worker used to go through multiple rounds of RT-PCR on regular intervals, and therefore, this surveillance program enabled us to identify 2 individuals who tested positive at 2 different time points, but nevertheless have been asymptomatic, or they did not have symptoms. And this in literature is the first case of a genomically characterized case of asymptomatic reinfections, and we introduced the term asymptomatic reinfection. And how do you know that it is reinfection? Because you can sequence the genome, and if there are genetic mutations which are very different from each other, you know that there are 2 distinctly different viruses which infected each individual. So, the I1 and I2 are the 2 individuals, and E1 and E2 are the 2 episodes of infection. And this therefore becomes the first case of asymptomatic reinfections reported in literature. Now, a close similar case is what we call as reactivation of the virus, where you have the same virus, a person got infected with a particular genetic virus or a genetic variant, and after a point of time becomes RT-PCR negative, but eventually the virus turns out positive, but at the same point it is the same virus, and you can do genomic sequencing to suggest that they are exactly same genetic mutations and the same virus. And this also becomes one of the first cases of reactivation of the virus, and this is in an immunosuppressed patient worked up by Dr. S.P. Yadav from the Medanta hospital. And the surveillance programs established therefore are very crucial, because this can provide insights into early warning signals. Like for example, in this particular case, there are breakthrough infections. Of course, this is not the first case of breakthrough infection, but one of the first reports of breakthrough infections, because healthcare providers, if they were put on surveillance, could identify individuals who tested positive at different points of time despite having 2 doses of vaccine. And this is from Kerala, 6 reports of breakthrough infections which could be genomically characterized, and therefore suggest that there are some genetic variants, mostly the variants of concern, which could therefore cause breakthrough infections despite having 2 doses of SARS-CoV-2 vaccines. Now, in an epidemiological point of time, it is very important to also do some crystal gazing and identify where is the virus evolving, or what is the virus trying to do in the first place. So, largely if you space genetic variants that we know today in the two axes of transmittability to immune escape, and this is based on, of course, genetic variations and annotations, and of course, we do maintain two such databases available for SARS-CoV-2, probably the only ones available for SARS-CoV-2, which systematically catalogs genetic variations which are associated with immune escape or associated with increased transmissibility. And as you see here, as the virus is evolving today to Omicron and some variants, it has largely been sort of treading this path of increasing transmissibility and or increasing immune escape. And what we think is eventually the virus is going to attain some level of fitness in terms of a larger transmissibility plus larger immune escape, so that it can become endemic and be with us in the population probably for the times to come. But of course, the virus has an Achilles heel, because practically all these mutations in terms of transmissibility or immune escape is pretty much localized to just one protein, which is a spike protein, which is the exposed surface of the spike protein. And of course, there is a small region in the spike protein which has all these genetic mutations. And therefore, it is an Achilles heel, because not all genetic mutations are functional. The mutations which could increase the transmissibility could reduce the immune escape and vice versa. And therefore, it is a balance that the virus needs to strike on what to mutate and how to mutate, so that both of them could be maintained. So, there is only a finite set of genetic mutations that the virus can do, and the virus is over time trying to sort of gain such mutations, and we can sort of predict the trajectory of how the virus is going to evolve. Now, one of the most important thing is that surveillance is really more important because of this one single chart that I sort of say, that is essentially the delta wave. And the delta wave the first reports of the variants from which are causing the delta wave, which is Kappa, was reported from Amaravati and Yavatmal sometime in February 2021. But if you really date back the delta isolates by reconstructing the ancestor, you would see that the delta waves the first set of delta variants sort of emerged sometime in July to September 2020, and that is almost like 6 months away. And that pretty much coincided with the previous wave in Maharashtra, and that is very understandable, because when a wave of infections occur, there is parallel evolution of the virus, and that contributes to newer variants of the virus from happening. Now, this is very more important, because if you had a very systematic surveillance, so the middle panel is essentially the genome sequence at that point of time, and if you had a very systematic surveillance mechanism, you could have identified the virus very early on, and you could have instituted mechanisms and policies to stop the spread of the virus. And this is very important, because you need to have techniques for fast detection of the virus, and we were fortunate to have built one such fast methodology which works on benchtop sequences, which can handle around 48 samples in less than 24 hours, right from the sample to the report. Now, this is very important, because you could identify small outbreaks in very quick succession. We have extensively used this in India and of course across the Southeast Asian region with the WHO. For students out there, of course, there are a large number of informatic resources that you could sort of go back to understand much more about SARS-CoV-2. Now, it is incomplete to stop my talk without discussing about monkeypox, and I am sure a lot of people ask me what is new about monkeypox. So, for monkeypox, of course, genomic surveillance is key, and we do have a Hindu article today which discusses the relevance of genomic surveillance for monkeypox. But the most important thing that I am going to come to is, of course, the monkeypox outbreak in 2022 has largely been because of two clusters. One is the European cluster, which is there in yellow, which essentially was an outbreak out of Spain, which spread very quickly to multiple different countries across the world. And then there is a very small cluster that is sort of highlighted in there, and the early two genomes out of Kerala now belong to this particular cluster compared to the big cluster out there. So, we know that now that the introductions and mechanisms of transmission have been quite distinctly different from the large European outbreak versus the two cases that we have sort of identified out of Kerala. But the most surprising thing of this particular cluster, which is sort of highlighted, is that the earliest case or the earliest genome from that particular cluster was from almost a year ago. Right? That means that the virus has been in humans and transmitting very cryptically. It never went into a large super spreader event, but nevertheless has been having a low level of human to human transmission almost for a year. It has evolved, of course, over the last 1 year, We could trace the origin of the virus by calculating the time of origin, and pretty much coincides pretty close to the earliest sequence of the virus, and that was isolated from the United States of America. I think I'll stop there, but to also say that these two viruses have very distinct genomic signatures. There are around 16 genetic variations which sort of classify this virus, and therefore, it is very, very more important probably to sequence every single case of monkeypox that comes today. And today as a country, we do have the expertise, we do have the infrastructure to be able to do that, and I think it's high time we do that. Now, how do we go into the future? And the future is essentially not just genomic surveillance, but how do we tie genomic surveillance to a lot of other information which is out there across the globe. This includes, for example, news articles or information about outbreaks. How do we handle monkeypox? We know it because it was in news, there was an outbreak out there. How do we factor that in and also factor in other information about human mobility, right? And of course, genomic surveillance is important, but very more important is collaboration in this particular space, because it's not just only about genomics, but also integrating the genomic information with clinical, epidemiological, demographic, and other digital information. We have been using such digital platforms, for example, to track the bird flu outbreaks in 2022, which sort of coincides with what we call as the flyways of birds. Birds do migrate from across the world, and they migrate in a very constant path based on the geography and point in time, and essentially they take the viruses across the flyways, infecting every single country as they pass through them. Thank you very much. This was possible with a very large number of people, including very fantastic collaborators like Dr. Vivek Gupta, fantastic people in the lab, and fantastic collaborator for many years, Dr. Sridhar Shivasubbu, who did most of the NGS sequencing. And of course, funding. The initial funding came from CSIR, and much of the late funding came from multiple different organizations, including the Department of Biotechnology, the state governments of Maharashtra and Kerala, and the WHO. Thank you very much. Take questions.
Thank you. Thank you, Dr. Vinod, for such a detailed presentation on genomics in COVID and a good highlight of monkeypox as well. I think we can take a few questions if we have in this. Yes, please.
As usual, wonderful. I was curious, what's the role of environmental surveillance for both monkeypox and SARS-CoV-2? You think, I mean, like the polio, which we have been doing for years.
Yeah, absolutely right, and more relevant for monkeypox, because while monkeypox is largely at this moment a human-to-human transmission compared to a zoonotic transmission which used to happen before, what we should be really worried is the reverse zoonosis that might happen with monkeypox, because monkeypox has a wide variety of animal hosts which could now contribute to reverse zoonosis, and that's something that we might not be able to tackle, because you can always track humans, but you cannot track animals.
True. And the other question was from a diagnostic perspective, have we come up to any regions within the SARS-CoV-2 which would be unique, yes, to SARS-CoV-2, but yet, you know, not the hot spots, so that we could have a diagnostic assay which is universal now?
Absolutely. Now, there's something very interesting in here, because orthopox viruses largely has been animal viruses, infecting goats, cows, etc., etc. And now you have a human transmission and sustained human transmission. So the hotspots for zoonotic transmission, the hotspots for human transmission are completely different, and that is very useful and essential to now understand where to build your primers. We do have such regions, and the last slide was essentially for partners who are interested in discussing further. Thank you.
It was a nice explanation about the SARS-CoV-2. Just as a curiosity, you have studied lots of the variants. Then which are the genes, where the genes are located for the increasing virulence, whether it's involvement of the lung or coagulopathy or cytokine storm?
Yeah, so while we know a lot about transmission and immune escape, which is largely confined to the spike protein, unfortunately we don't know much about what are the viral factors which could contribute to the other severity of manifestations. Now, of course, there have been multiple papers which sort of put across other accessory genes, including the ORF genes and other accessory genes, including from GBRC, which has been published, right? But frankly speaking, we don't have as much understanding that we have for the spike protein for the other accessory genes. in many ways we don't even understand what those genes even do.
Okay, so if there are no other questions, thank you, sir.
Thank you very much.
We can move on to the next session. Thank you.
Thank you, chairpersons and speakers. There's an important announcement. We request the all in-house guests to please check out of the hotel rooms and to give their room keys at the reception. We move on to the last session of our program today. It's on the infectious diseases, and I invite the chairpersons, Dr. Urvesh Shah, Head of Microbiology Department, GCS Medical College, Ahmedabad, and Dr. Mitesh Suthar, Consultant Infectious Disease, Shlok ID Clinic, Ahmedabad, to please come on stage and start the session.
Thank you very much for inviting us as a chairperson for this wonderful talks. So first session is for the infectious is challenges in microbiome analysis and the use of the next generation sequencing technology in microbiology by the Dr. Sanjay Bhattacharya, who is a senior consultant in microbiology at Tata Medical Center, Kolkata. So shall we start the presentation?
Hello, good afternoon. This is Dr. Sanjay Bhattacharya. I'm a consultant in microbiology at the Tata Medical Center in Kolkata. And I would like to thank the organizers of the Molecular Pathology Association of India for giving me this opportunity to speak on this topic on the 7th of August 2022. I'm going to talk for the next 20 minutes on the challenges in microbiome analysis and the use of next generation sequencing technology in microbiology. So to begin with, these are the points that I am going to discuss during the course of my presentation. So I'm going to discuss about microbiome and its importance. So what is microbiome and microbiota? We are going to talk about the typing by, the genotyping by Sanger sequencing versus next generation sequencing. We are going to look into the microbiome analysis by the shotgun method versus 16S amplicon based method, applications of next generation sequencing in microbiology. We are also looking at the NGS workflow in microbiome analysis, equipment and other requirements for the next generation sequencing, potential problems in next generation sequencing, the difference between abundance, richness, and diversity, Shannon Diversity Index, and we would have some concluding remarks during the course of this presentation. Now, some of you may have seen this particular papers that about the treatment of drug-resistant Clostridium difficile infection with the help of fecal microbiota transplantation. And also the treatment of drug-resistant E. coli bacteremia with fecal microbiota transplantation. Now, it is also interesting to note that there have been papers on how the gut microbiome actually changes and alters during the course of chemotherapy and conditioning during the course of bone marrow transplantation. This particular figure shows the variation in the gut microbiota during the course of the bone marrow transplantation and what sort of preemptive strategies you can take to minimize the effect on the microbiome. And these strategies may include enteral nutrition, these may include prebiotics, use of probiotics, use of fecal microbiota transplantation, and also the various antibiotic strategies. So it is clear from some of these papers that microbiome analysis and the use of fecal microbiota transplantation, which is based on the concept of the microbiome analysis, is an important tool which is emerging in the field of clinical microbiology and clinical infectious diseases. So let us look at do we mean by microbiome and how does microbiota differ from the term microbiome. The term microbiota includes all microorganisms, that is bacteria, archaea, fungi, protists, and algae that are present in a given environment. That environment may be the human gut, it could be an external reservoir like a river or a pond, it could be the surface of the skin, it could be the oral flora. So it could be basically any particular environment where microorganisms are present. Whereas the term microbiome is much broader than the microbiota, and it includes not just the microorganisms, but the theater of activity. What does the microbiota do in a particular theater? So it may produce proteins and peptides, lipids and polysaccharides. It has nucleic acids in the form of DNA and RNA. It has mobile genetic elements, and it produces microbial metabolites, which have diverse functions in terms of the toxins, in terms of the organic molecules and the signaling molecules that are there. So the term microbiome is much more holistic than the term microbiota, and it includes a combination of the microorganisms and the functions that are actually enacted by the microorganisms in a given environment. Now, this particular figure shows that the microbiota is determined by various different factors. On the left-hand side, you have the factors, and on the right-hand side of this diagram, you have the various components of the body, the various compartments of the body where these microbiome are found. So the microbiome of the human body is determined by genetics, it's determined by environment, diet, lifestyle, but it is also determined by hormones and by industrial processes. It is present in the nose, mouth, lungs, stomach, colon, sexual organs, and the skin, and they have a variety of different functions in this particular parts of the body. So in the mouth, for example, it may be responsible for mucus production and the production of the antimicrobial chemicals. That is in the nose. In the mouth, it may be assist in digestion and ward off the pathogens. In the lung, it lubricates pulmonary passages. In the stomach, it is responsible for preventing gastric complications. In the colon, digestion of complex carbohydrates. In terms of the sexual organs, it is responsible for maintaining the pH and the hydrogen peroxide production to kill the microbes, and in the skin to fortify the immune system and also in the scent production. So we can see that there are a variety of different processes which are regulated by these microbiota or which are present in different parts of the body. Now, there are certain aspects of the microbiome which are known to us and certain aspects which are unknown to us. So what is known to us? We know that there are 25 phyla in the microbiome of the humans. Among these 25 phyla, there are 2,000 genera, 5,000 species, 80% metagenome mappability has been possible, and 316 million genes have been identified. So we do know a lot in terms of the phyla, genera, species, the mappability of the metagenome, and the number of genes which are responsible. But there is a lot which is also unknown. And these are the undetected unknowns or the unknown unknowns. We also do not know about the hidden taxa and the strain level diversity. 20% of the sequences do not match with the microbial genomes. And there are functional unknowns, that 40% of the genes without a match in the functional databases. So we see from this particular diagram that we do not know the function of 40% of the genes of the human microbiota, and we do not know the significance of 20% of the sequences that we get from a microbial sequence. Now, there was a time, not very long ago, and that practice is still continuing, that we used to do conventional genotyping by techniques such as polygotyping and the MIRU and the VNTR typing. This particular diagram is from the CDC's website, and it elaborates about the techniques used for genotyping Mycobacterium tuberculosis. And the two important techniques were the polygotyping and the MIRU VNTR typing. But the whole genome sequencing will provide added resolution to examining the genetic relatedness of the isolates. So by the MIRU and the VNTR typing or the polygotyping, we examined about 1% of the genome. Whereas with the whole genome sequencing, we examine about 90% of the genome. So the resolution that we get from the whole genome sequencing technology is much more than that we get from the polygotyping or the MIRU VNTR typing in next generation in the Mycobacterium tuberculosis typing. So this actually shows that how the whole genome sequencing technology using the next generation sequencing platforms is revolutionizing the resolution of the genotyping technology in microbiology. Now, this particular figure gives you the 3 generations of sequencing technology. So there was gel-based sequencing, which was known as the first generation sequencing. Then came the capillary sequencing, which was known as the second generation sequencing. And now we have the next generation sequencing, in which there are various platforms by Illumina, which is doing sequencing by synthesis. And there are other platforms as well, like the Nanopore, which is actually measuring the changes in the electrical current that is passed to a particular protein membrane. So, but it is also interesting to see that these have been the time points when these techniques and technologies were existent. So in the last 35 to 40 years, from 1980s to the current, we have had a progression from the gel-based sequencing technology to capillary-based sequencing and the next generation sequencing. But it's also interesting to note that if you look at the y-axis, the speed of the speed of sequencing in terms of the kilobases per day, there has been logarithmic rise in the speed of sequencing in terms of kilobases per day. So the gel-based sequencing was really very slow, and we could only sequence tens to hundreds of nucleotides at a time. Then came the capillary sequencing, which enabled us to sequence somewhere between 100 to 1,000 bases at a time to about 10,000 bases. But the next generation sequencing technology has taken us a few logs higher. From 10,000 kilobases per day, we are in a position to do about 10 billion bases per day. So there has been a significant rising of sequencing capability in the last 3 to 4 decades, and this is what is shown in this particular diagram. Now, when we are doing the sequencing of the microbiome analysis, we are essentially looking at 2 different approaches. Approach number 1 is a 16S rRNA amplicon sequencing, where we amplify the 16S part of the genome and then we analyze it. Whereas there is another approach, which is the whole genome shotgun sequencing, which is a much more comprehensive way of looking at the microbial genes. So there is a fundamental difference between the 16S rRNA-based amplicon sequencing and the whole genome shotgun sequencing, the whole genome shotgun sequencing being more comprehensive in terms of the read length as well as the coding analysis. So this particular table shows you the difference between the shotgun sequencing and the amplicon sequencing. The cost is low in case of amplicon sequencing, where it is high for the shotgun sequencing. Shotgun sequencing is more extensive. The NGS platforms, you can use similar types of NGS platforms. To name a few, Illumina can be used for both of them. Reference database used to use 16S database for the amplicon sequencing, whereas one needs to use the genome database for the shotgun sequencing. The resolution is up to the species or taxonomic groups in case of the amplicon sequencing, which is based on the 16S technology, whereas it is up to the subspecies level in case of the shotgun sequencing. Sorry. The output is in terms of taxonomic profiles in amplicon sequencing, whereas in shotgun sequencing, it is up to the functional profile level. The limitation is the low taxonomic resolution in amplicon sequencing and no functional interpretation, whereas in shotgun sequencing, you have taxonomic profile may be wrong if the reference genome database has low taxonomic coverage. So these are the limitations of the amplicon sequencing and the shotgun sequencing technology. Now, applications of NGS, or next generation sequencing technology, in medical microbiology include the genotyping and subtyping as is done in the SARS coronavirus and the HIV and the Mycobacterium tuberculosis, the antimicrobial resistance testing, as for example in HIV, one can also do it in case of Mycobacterium tuberculosis, the phylogenetic analysis for the Mycobacterium tuberculosis and the multi-drug resistant organisms, the taxonomic studies for novel organisms and emerging organisms, outbreak investigations, typically done in case of Mycobacterium tuberculosis or multi-drug resistant organisms, microbiome analysis, which is still a research application in microbiology, and the whole genome sequencing of microbes for the above applications. So these are some of the applications of the NGS technology in medical microbiology currently. The next generation sequencing in clinical microbiology, one can do a whole genome sequencing for SARS-CoV-2, HIV, Mycobacterium tuberculosis, and multi-drug resistant organisms. And for example, the MRSA, the VRE, the carbapenem resistant Enterobacter C, the carbapenem resistant organisms, be it Acinetobacter baumannii or Pseudomonas aeruginosa and the Candida auris. The NGS workflow, when one is doing the microbiome analysis, can be divided into two parts, the wet lab work and the dry lab work. The dry lab work is concentrating mainly on the bioinformatics part, whereas the wet lab work, it's from samples collection, the sample storage, the DNA extraction, the purification, the quantification, 16S PCR amplification and purification of the PCR products, library preparation, which includes the indexing PCR, and the library purification and quantification to tape station and the NGS using the Illumina. Whereas dry lab work involves a fast QC check, the metadata file creation, which is in the CSV format, the raw data trimming, the Shine 2 pipeline, which produces the biome file and the diversity, be it alpha diversity or beta diversity detection, and the heat map preparation and the relative abundance determination. So these are the two different NGS workflows that is seen in the microbiome analysis. The equipments, the requirements for the NGS includes the pipettes of various dimensions, the freezer of -20 and -80 degrees Celsius. We need centrifuges of 15,000 RPM, which should be a cold centrifuge operating at 2 to 8 degrees Celsius. We need a plate centrifuge, which should be operating at 5,000 RPM in cold. We need a bead beater for DNA extraction, biosafety cabinet, shaker incubator, nanodrop cuvette, and tape station. In addition, there is a requirement of the endpoint PCR system, the NGS system like Illumina MySec, laptop computers with the Linux system, the hard disk of about 1 GB size, pen drive of 10 GB, and software, which should be the KIND2 software. The potential problems associated with the next generation sequencing technology for microbiome analysis include the sample collection and sample preservation. So unless the right samples are collected at the right time from the right patient with appropriate data, we would not get the metadata that is required for data analysis. Appropriate sample collection containers and or swabs should be there, because not all swabs are suitable for all types of samples. We need the appropriate DNA extraction method. It has been seen that there is a difference in the relative abundance in kit-based DNA extraction versus manual extraction, but done by in-house methods. We have to have a pre-PCR DNA estimation and dilution. We have to have a selection of the primers, particularly the V3 and the V4 region. We need appropriate indexing, which is also known as fragmentation. Post-indexing PCR purification and quantification is necessary. And we need defragmentation of the library and stopping of the library preparation before charging into the flow cell. And finally, we also need the trimming software for this particular technology to be appropriate. So I would wind up my presentation with some key concepts. For example, this is a concept from the University of Miami about abundance, about richness and diversity. So they may appear similar, but these concepts are very different. Abundance is different from richness. Richness is different from diversity. So you have community A and community B, and you have different types of figures denoting them. For example, abundance is the number of particular individuals in a group, and you can see that there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 particular individuals, both in community A as well as in community B. That is the number of individuals in a particular community. Whereas when it comes to richness, we find that they have the same richness as well. This is the number of different types of species that is particularly available. And we can say that the number of types of species that is there in the community is 4. So you have these blackbirds, you have this kangaroo, you have this black creature over here, and you have this whitish bird over here. The same is in the case of community B. But which is more diverse? Is this community A more diverse or community B more diverse? The answer is, it is a community B which is more diverse. The way we know it is through a particular formula which is known as the Shannon Diversity Index formula. The Shannon Diversity Index is given by the letter H, which is equal to the minus of the summation of the proportion of the ith particular value into the natural logarithm of the proportion of the ith value. And you sum it up and you get the Shannon Diversity Index. So the more evenly a particular species is distributed in a given community, the greater is the Shannon Diversity Index. So I will come across two more concepts, which is alpha diversity and the beta diversity. In the alpha diversity, you can see that there are 3 communities over here, which is having an alpha value of 3, 4, and 2. 2 because there are two types of figures over here. One is a round, another one is a square. Here there are 4 types of figures. There is a round one, there is a square one, there is a triangular one, and there is a star one. And alpha is 3 over here because there are 3 types of things. One is a round, another square, and another triangle. But if you look at what is the difference in the diversity between this community, which has been having an alpha value of 4, and this community, which is an alpha value of 3. So there are actually a difference of actually 3. So because so if you combine these two, so there are actually 3 different types. So one is a star type, another one is a circle type, another one is a triangle type, which are so common between. The star is not there over here, but you have the triangle and the round type and the square type in both of them. So that gives a beta value of 3. And if I want to know what is the gamma diversity between all the 3 communities, so then we will get a figure of 6, because there are 6 types of figures which are available over here. So one is the round type, another one is the square type, another one is a triangle type, another one is a star type, and even in the what is called the square type, you have 2 different types. One is the green type, another one is the yellow type. So that gives you a figure gamma diversity of 6. So these concepts are pretty important when you are looking at microbial diversity. So to conclude my talk, next generation sequencing is a powerful tool in understanding microbiota. Next generation applications are currently in the field of microbial research rather than in routine diagnostics. It is likely that in future, once technology develops and the standards of care change, NGS technology will be increasingly used in patient care. And the current hurdles of the NGS technology include the infrastructure development and maintenance cost per sample tested, and finding clinical questions for routine applications. Thank you very much for your patience and hearing. Thank you.
Thank you, sir, for this very informative session. Now we are taking questions from audience. No. So we are moving towards next session. That is fungal genomics. Speaker is Dr. M.R. Shiva Prakash, Professor in charge, Mycology Division, Head WHO Collaborating Center and Center of Advanced Research in Medical Mycology, National Culture Collection of Pathogenic Fungi, Department of Medical Microbiology, Postgraduate Institute of Medical Education and Research, Chandigarh. Thank you, sir.
Thank you all. First of all, I would like to thank the organizer for inviting me to this wonderful conference. So I was given the topic to talk on fungal genomics. So afternoon session, that to end of the session, Sunday evening. So I thought that it will be really boring. Yesterday when I came here, I asked Dr. Nagraj Arora as well as other candidates, what would I like to talk? What you people expect from me? So I know that many of them are pathologists and microbiologists, and mainly the theme of the conference is on the healthcare and other things. So instead of going to discuss about the basic, which will help mainly the researchers who are working on pathogenesis and diagnostic and other thing, I would like to just make you understand about the diagnostic aspect of this. So what I thought is I would mainly discuss about the molecular diagnosis of the invasive fungal infection, DNA based molecular diagnosis, whether it is an sequence based or what is the current next generation sequencing. So we are really in a very infancy stage about the next generation sequencing, coming to the diagnostic aspect of the fungal infection. So that's why I have a last few slides. I will talk about the next generation sequencing utility in the mycology or during the fungal infections. So you all know about the fungal infections, why it is increasing, especially after this COVID outbreak of CAM as well as Kappa, that is COVID associated mucormycosis and COVID associated aspergillosis. Everybody got interest about the fungal infections. So fungal infection, especially in a microbiology lab or pathology lab, every day we are doing lot of fungal infection. But how far we are, if you want to really treat the fungal infection properly, then you need to identify up to the species level. So this concept is very important. What I am telling is species level, because for example, for you all know that Aspergillus fumigatus is one of the major cause of aspergillosis. But Aspergillus fumigatus is a species complex consisting of 16 species. Now even microbiologist we say only Aspergillus fumigatus. What is the clinical implication of it? Species concept, will it help in the management of the patients? For example, Aspergillus fumigatus, after 16 species, Aspergillus lentulus, if you identify, then the main drug of choice for treatment of Aspergillus is voriconazole. Lentulus, if you identify, that is resistant to voriconazole, then the patient will die. So like that we have a Fusarium species complex. So you need to identify. So what are the available methods for the diagnosis? So for example, histopathological examination. Species identification obviously we cannot do. Majority of the time what we do is an septate hyphae, aseptate hyphae, yeast, dimorphic, okay, sometimes perules and other thing, coccidioides and all we can identify. But species wise identification cannot be done. So septate hyphae, generally what you know that 80 groups, all this the list of organisms. So anything you tell it as an Aspergillus, acute angle, whatever you say, so it could be any of these organisms of 80 groups. So you cannot tell this particular species. So fungal culture, so microbiology we also have the same problem. So fungal culture, first of all the sensitivity is very low, and many of the times the samples are not sent to the microbiology lab or mycology lab. So that's why as a reference center I receive at least 50 paraffin blocks. So the patients is when there is not responding, pathologists over the countries, we are working closely with the microbiologist and pathologist. So they send us, because patient is not responding, we want to know exactly at least what species is there in the block. So what is the status of those things, I will tell you. Serology, it's not much developed, at least for galactomannan we have for aspergillosis and beta D glucan for candida, and it is not specific for candida itself. One example I can give you. So you can see that in this particular picture, so with intracellular yeast, everybody will say that okay, it is an histoplasma. So many of you as pathologists have been reporting it for many years as an histoplasma. So now when we got this particular case, so we got a culture, a mold that was looking completely different from histoplasma. So and when we tried to do the sequencing in this particular thing, we found out that it is an Emergomyces pasteurianus, it is not an histoplasma. Emergomyces, after that now it has been emerging dimorphic fungi which has been reported. Already we have reported 4 cases of emergomycosis in our center. So if you really do an molecular identification of all your block which you have identified as histoplasma, then you may find out the varied number of organisms like this. So many other dimorphic fungi similarly has been there. So this is just one example I am giving you what is the utility of an sequencing or molecular diagnostic. So application of molecular diagnosis for fungal infection are many. So you can use it, different clinical samples can be used. So for example, clinical samples such as tissue samples, whole blood samples and body fluids, from all it has been attempted, and DNA extraction is in critical state, because fungal cell wall is really very hard. So you have to hit it very hard to get the DNA outside of the fungal cell. So you have such an enzymes, as even you have to use sometime magnetic beads to break down the cell wall and extract the DNA. And luckily we have many different kits commercially available, and it has been evaluated. I will talk about our study, the use of commercial test as well as an in-house phenol chloroform extraction. So coming to the targets, so this is the most important slide you should know. So when you are going for fungal identification in your tissue or clinical sample, you need to target the one which is a multi-copy gene. So first of all, the burden within the tissue is very less, fungal in the tissues. So if you choose a single copy gene, then it will be problem. So this is the one which is most commonly found as an multi-copy gene, present in about 15 to 20 copies, which is called rDNA, and you should know the different parts of this DNA. So you have a small subunit, that is 18S, in bacteria it is 16S, and you have 5.8S, and this is an 28S, and you have an IGS, intergenic. Between the gene you have an intergenic spacer region, and in between these two genes you know ITS1 and ITS2. ITS1 and ITS2 is really very conserved to a particular species, but amongst the species there is a variation. So if you try to sequence this one, you can identify it up to the species level. So ITS1 and 2 is the most commonly used, this one. In this particular lower figure you can see that. So for example, 5.8S if you use, you can identify up to an order level. If you want to identify up to the species level, it is an ITS or IGR for some species. Even 28S and 16S is just, it is the higher level it can identify, means only up to Aspergillus it can tell Ascomycetes and other thing. Aspergillus, fumigators, war, this particular species, you can do it only by using this ITS region. So ITS is the most commonly used, and this particular gene is the one which is most commonly rDNA. So single copy genes if you are using, then you have to use an different for different purposes, for different organism, specific organism amplification you can use it. But in ITS, another main thing is they have designed a pan fungal primer. So you don't have to worry that which fungus you are suspecting. So if you use those primers, any fungus that is present within the samples, it can be amplified. Because ITS can differentiate, if you sequence it later, then you can tell that okay, this is the particular species that is present within the clinical sample. So methods used for detection, there are plenty of methods. Okay, if you use a pan fungal primer, if you get a band positivity, then you cannot tell that okay, which fungus it is. So okay, positive fungus is present. But if you do an sequencing, direct sequencing, So sequence if you analyze, then you can find out that which particular species it is. So this is the one main application of this technique. So real time PCR, again you know about the difference between the CyberGreen and TACMan, because when you know in the clinical sample, you do not know which sample, which species it is there. If you want to diagnose, you need to use a large number of probes. So that is not possible. So for example, Aspergillus species itself, at least you have an 15 species causing an infection. In Candida, you have 25 species. One probe, you know how much it may cost. So that is not problem. So instead of, that's why this CyberGreen is one of the important thing. So this is the status. So in different clinical samples such as serum as well as blood and bone sample, aspergillosis sensitivity is about 70% and specificity is varies about 70 to 100%. So this is a meta-analysis, but even 2009 analysis, even till now the same thing exists. So when you are doing an PCR for an aspergillosis especially, so this is one of the important slide. So if you do one particular PCR, so you can say that you can rule out invasive aspergillosis, especially I am talking about the serum and plasma detection. So if you do an 2 PCR because of an high specificity, so then you can tell that okay, the patient is suffering from infection. So this is very clear. And now recently UORTC MSG, who prepared the guidelines for the diagnosis of invasive fungal infection, they have clearly included PCR as one of the component or one of the criteria for the diagnosis of invasive aspergillosis. Based upon that, you can sell that it is in proven or probable fungal in aspergillosis. So coming to an commercially available, there are many available kits are present, but only limitation is you can identify the major Aspergillus species for the diagnosis. And another important thing is here you can also have an detection of an resistance also can be done based upon this. For Aspergillus fumigators, CYP51A mutation particular is there, which is resistant to an voriconazole. That thing also can be detected if you use one particular kit present here. And performance of PCR in candidiasis, people are not working much in candidiasis because of blood culture and other beta-D-glucan and other tests are there, but still people are working, and you can see that sensitivity is better compared to from the blood compared to aspergillosis, because in case of yeast you know that uniformly it is present within the sample, blood sample. So that whereas in aspergillosis usually we do not see an uniform within this one aspergillus, because the aspergillus generally invade the walls and only the free DNA can be there in the serum. So if you attempt for free DNA, then the chance of detection is better. So for Candida, again species identification may be difficult. So if you use this high resolution melt analysis, so it has been shown that you can clearly, based upon the melt curve that is present, so you can differentiate different species of Candida. So here again the commercially available test, only few mere number of Candida can be detected. For example, in our ICU candidemia study, so we had a total of 30 species of Candida causing an infection. So if you use any of this kit, so you have only few amount. So you are missing so many cases of candidemia if you do an PCR. So that is another limitation if you use this. So T2 magnetic resonance is there. This is within 2 hours after the collection of the blood sample you can diagnose. But in India we do not have till now. In European countries and USA it is there, but it can detect only 5 different species of Candida. So even Candida auris, which is causing an AVOC or multi-drug resistant, it cannot detect. So this is one of the limitation of this particular study, though it has got an sensitivity and specificity of really very high. So real-time PCR for pneumocystis, because pneumocystis is a non-cultural organism, most of the attempts for the PCR development for the fungal infection is mainly goes about this in this pneumocystis. So in pneumocystis, unlike this ITS and other targets, you can see that the targets are completely different here. So the targets which we are using is dihydrofolate synthase, beta-tubulin, major surface glycoprotein. So and you have a sensitivity and specificity, it is really very good sensitivity and specificity, and also many commercial kits are available, and you know that pneumocystis is a colonizer, hence you need to have certain cutoff. So, in this particular study we could determine that cutoff value of less than 25 is very important to diagnose. So, Mucorales PCR again after this COVID came back, everybody started buying, okay, they are asking me, calling me over where to buy this mucormycosis real time PCR kit. So, they thought that all the administrators and secretaries, they thought, okay, it is just like COVID, do an RT-PCR and diagnose the thing. It is not like that. So, I used to tell them, why you are using this one? Most of the time rhinoorbital you can diagnose by doing an histopathology, that is more than enough. Only problem is diagnosing of pulmonary mucormycosis. There we need an PCR because you cannot get the particular sample from pulmonary mucormycosis. But when you are doing PCR for this one fungus, you should always imagine that there is a problem with the colonization, and in this particular room you have plenty of mucor, you have plenty of aspergillus. So, if you are not taking care while doing an PCR, if you are doing an COVID, okay, COVID will not come from the air and enter into your sample, but fungus, any fungus, even when you are working with a paraffin block, the paraffin block itself will have, while preparation of the block, you will have lot of organism like Malassezia and many other spores can be there. If you identify that one, that will not give any answer at all. So, that is a particular certain limitations of it. And so, here when we did it with a fresh tissue, this is our own study. So, we could see that when we use the target as an ITS, it is a pan-fungal, the sensitivity was only 27, because most of them were rhinoorbital. Here we have Aspergillus spore and Candida and other thing. Whereas, when we used a Mucorale specific PCR, which is in 18S, we could 100% of the time in the fresh tissue we could identify the samples. So, another study we did it with a paraffin embedded block. So, here some of the main important points is mainly when we used a commercial kit as well as phenol chloroform index isolation. So, phenol chloroform was better than the commercial kit one. So, also the test accuracy, you can see that ITS1 we found better. So, most of the time people use ITS2. So, when you target ITS1, it was better than this one ITS2, and the thickness is very, very important. You should at least have 50 micron thickness when you are subjecting it for an DNA extraction sample. So, after 50, when we take 100 micrometer, there was no much difference in an amplification of the ITS region. So, we use this 50 micrometer, and by using a pan-fungal, you can see that many of these Aspergillus species, Candida, Histoplasma, so these were all from the blocks which was identified as an either yeast or septate hyphae within the block. So, plenty of organism, but still 36% of the samples we were unable to isolate the fungi, because paraffin itself, the formalin will degrade the DNA, and because of that the old slides cannot be, may not be successful in isolation. So, when we used a specific DNA, this one primers for Mucorales, so you can see that again we could identify many of the genus, but in many genus species wise identification was not possible, because the target which we achieve is only about 200 base pair. So, it cannot differentiate Rhizopus arises from Rhizopus homothalicus. So, that was the some challenges when we faced during this particular study. So, these are certain recommendation from this study. Lastly, the next generation sequencing, again the protocol is similar, already many people have been explained, I am not going into the detail. So, what is that? Till now fungus we have about 319 cases and 365 fungi detected by using an next generation sequencing. Majority are the Pneumocystis jirovecii and Aspergillus, Cryptococcus and Rhizopus and others. So, this particular study, just in 1 minute I will just tell you the importance of this study, what is the application of next generation sequencing. So, here they have not done the whole genome sequencing. As Dr. Sanjay was telling, they have done a targeted sequencing. So, targeted sequencing if you do here, again they have used an ITS2 as a target. As I said that ITS2, if you do NGS, then by the platform that you used is an MySeq, and these were the characteristic. Only 44 samples they have used, both autopsy as well as non-autopsy samples, and histopathologist divided classified it into septate hyphae, aseptate, posiseptate, hyphae, budding yeast and other things, and they have not taken older than 3 years block. So, because if you keep for longer years, as I said, there will be deactivation of the DNA and the possibility of amplification will be less. So, these are out of 44 sample, more than 55 species they could identify, all from 44 samples. So, what they have done here is mainly, even the problem is, even when there is a mixed infection, this particular NGS can pick up the samples. But if you do an sequencing, Sanger sequencing, which we did early in our study. So, in Sanger sequencing, if you have two fungus together, so you will get a mixed peak and you may not be able to identify the thing. So, you always, when you are doing an Sanger sequencing, you should have only one agent, then only you can identify the thing. But in case of NGS, even if you have 3 organisms, it will give it as a taxonomical unit. So, in ITS, when you blast it, taxonomical units, based on that, all these organisms can be clearly identified by using the NGS. So, in this particular study, when they have seen that less than 50 organisms, when it is there in the slide, species level discrimination was obtained with a process read as low as 6,865. So, the lowest fungal burden, even there is a 10 organism per slide, this NGS can pick up this one. So, even an highly experienced pathologist could only appreciate up to 73% correctly, whereas this NGS 100% it picked up all the isolates. So, this is my last slide, advantages, limitation. The major advantage of doing an NGS over an conventional or Sanger sequencing is it can pick up all the pathogens that is present in it. Mixed infections also can be detected, and most of the time it is an quantification, as a taxonomical unit you get the results. So, that is why you can say that okay, in your sample if you have an more number of an organisms, for example, septate hyphae, if I get an aspergillus more and alternaria as an off than that. So, I probably tell that okay, aspergillus is more important than an alternaria. So, it is an highly sensitive method, NGS. Again I am telling you, because of high sensitivity, you know that false positive results can be there due to contamination, and that is a really major concern. And so, pre-test probability means, for example, when you are giving for an NGS, you should know that okay, this is an septate hyphae and this is from an sterile sample or it is from an contaminated sample such as ball or other thing. So, if it is a sterile sample, then pre-test probability is more and identification, correct identification is always better, and detection of free cell DNA like in serum and other thing, we know now it is coming up. So, NGS is more being applied by using for this particular to detect and free cell DNA. So, in fungal just it is coming up, we have only few publications in it. The cost of this one is really an issue, as you all know, have been discussed 2-3 from the yesterday itself, and the database is another problem with the fungus. So, if we just blast it in an NCBI database, so many of the wrong identification have been deposited and you can do. So, now recently one group has come out with an 1400 species of fungal database they have. So, if they are still not open to the general, so if that is there, then we will have more chance of diagnosis, and nanopore application has become an very really helpful. So, this could be an everybody can have in the lab and can use this particular technique if you have an analysis capability in your lab. So, definitely it is possible in another 5 years most of our lab can have this method and can use this NGS for the diagnosis of fungal infection. Even in a pathology lab you can do your own identification. So, thank you very much and sorry for the delay and I took some more time. Thank you all for your kind attention.
Thank you very much, Dr. Shiv Prakash. We understand the significance of gene sequence in identification, even not only from the block, even after isolating the fungus, we sometimes ended up with the identification only at the genus level, but the genomic sequence can make possible to identify species level. Any question? Yes, Virat.
Role of blood samples.
Diagnosis of mucor PCR
Yeah.
by PCR.
So definitely there is a role of an blood samples. For example, when I say we are also working on it, So the major, now we have one kit called mucogenius. So if you want to tell, many kits may be available, but is there really necessity for the diagnosis using the blood sample? So okay, blood sample, the mucogenius kit that is available from pathognostic, it is having a sensitivity of about 70% identification, and specificity is really very high, 100%. So if you have a sample and if you have a good setup to do an PCR without contamination, you can do the thing, and especially better to do with when you have a suspicion of pulmonary mucormycosis. So rhinoorbital mucormycosis, again one thing is you do not know the cutoff and other thing. Everybody is exposed and DNA can be there. As I said, cell-free DNA can be there. So these are all not well standardized now. So what is the cutoff? You can take it as this one. Every positivity, if it is there, then you can give it as positivity. That's why I am telling, even when I do for Aspergillus or any other PCR, from the blood or other thing, from the blood sample there is no issue. If it is from an contaminated sample, just positivity will really implicate whether the patient is having the disease or not. That will be one of the major limitation. If you do it, NGS if you do, again you are doing quantification, then you can, that's why I am telling NGS has gotten really, finally all will stop doing an PCR, just a plain PCR for fungal diagnosis once this NGS has been started. They can use it mainly for this one sterile sample, but if you do balls, for example, pulmonary invasive infection is the most common one. So for pulmonary, ball sample is the one. Ball sample is not a sterile sample. In this sample, actually you can use this NGS thing. So that is the only thing. So for mucormycosis it is there, but sensitivity from doing serum is or the ball sample is up to 70%.
One more question, sir.
Yes.
Can multi-top be an alternative answer of gene sequencing identification growth of fungus?
No, that's why here you should be differentiating between multi-top function and sequencing function. Multi-top we can do it for an identification. Till now what we have is multi-top is once the culture positivity is there, from the culture rapidly you can identify. So another approach is for example in blood culture, if candida or other bacteria is there. So if you have kept it in an bactec this one. So when the signal is present, before if we have to subculture it and then next day we need to identify. But directly from that bottle you can put it onto the plate and by MALDI you can identify it by 15-20 minutes. So without doing subculture, once the beep is there, beep means, so once the organism has multiplied into the blood culture bottle, so it will provide because of the gas or the detection, it will provide a peak, that is a beep, and that sample directly you can detect. And research is going on to detect directly antifungal resistance. We are also working on it, antibacterial resistance directly from this one by using an culture. But from the clinical sample, you know that it is we are analyzing the protein only. So it is only you have to differentiate between
I am talking from growth only.
So in protein you have a clinical sample, you have many proteins. So that's why those things, fine standardization is really required. So it is still upcoming, but DNA we can amplify it and do it. But protein identification, MALDI, it is still in an infancy stage and in the research stage for directly diagnosing from clinical sample.
Thank you very much, sir.
Sir, one question. Any experience of antifungal sensitivity from growth sample by NGS method?
NGS definitely, for research wise we have plenty of papers regarding NGS this one. So even we are also doing comparing the, for example, Candida auris, so susceptible as well as resistance isolates. We are doing an transcriptomic study and trying to find out what are the variations that is present when you expose this to the azole and other thing. And some mutations which we have, common mutation, you can do it by doing a targeted sequencing. So when you compare it, for example, when I do research, so comparing Candida auris azole resistance as well as azole susceptible, so I do an whole genome sequencing and try to find out where exactly mutations are present. So that could be whether we have to knock out that gene and try to find out, okay, if you knock out that gene, it is again becoming resistance, it is getting sensitive, and if you add it again, it is becoming resistant. So this is still in the research stage, but it is not, I think another 10 years we will need to have to come directly to correlate the resistance, but for mutations and a known mutation definitely can be done. In Candida auris, in Candida albicans as well as Aspergillus, we have particular mutations, so that can be detected even by doing an Sanger sequencing. There is no need to go for completely for NGS sequencing. So targeted sequencing can be answer all your questions here.
Thank you, sir. Thank you very much.
Okay,
so now moving towards the next topic, that is on the TB genome sequencing by the Dr. Aparna Banushari. I call upon the stage, madam. She is a head growth and scientific support at the Hashtag Analytic Private Limited, Society for the Innovation and Entrepreneurship, Indian Institute of Technology, Mumbai. Madam.
Thank you. First of all, I would like to thank all the organizers and specifically MPAICON 2022 and Dr. Nagraj Arora and the team at Unipath. Thanks a lot for having me here, and I'm from Hashtag Analytics. We're a startup which is incubated in IIT Mumbai, and we provide genomic solutions. We are also supported by several organizations like the DBT as well as the SIGN and GE and Intel. So with that, I'll just start. So you know that what was the the WHO theme for 2022 World TB Day was invest to end TB and save lives. And if you all see, in 2020, TB was the 13th leading cause of death globally. Of that, Southeast Asia accounted for almost 43% of the new cases, 5 lakh new cases with multi-drug resistance. So TB has killed even more than what COVID has done. And 3.4% of the new cases and 18% of the retreatment cases have drug-resistant TB. Now, out of these, only 37%, I'm talking about the drug-resistant, 13% of those are diagnosed and 31% are initiated on the right treatment. So what is happening? Somewhere we are failing as laboratorians or as diagnosticians to give the right kind of indication that it is, you know, to give a comprehensive solution whether it is drug resistant and what are all the drugs that it is resistant to, so that we justify the theme and we justify precision medicine for all. Precision medicine has now to come to infectious disease also. So if you also see the India TB report, the National TB Elimination Program, now the whole objective of the National TB Elimination, our PM has indicated that we want to eliminate TB 2025, 5 years previous to what is the WHO date for elimination of TB. And if we have to do that, then we cannot afford to miss a single case of drug resistant TB. We cannot afford to miss a single have incomplete diagnosis, so that we are able to justify this goal of eliminating TB. Now, if you look at the National TB Elimination Program, it misses 10% of drug sensitive, but almost 50% of the drug resistant cases. So now we have to invest in equitable tools with which we will be able to eliminate TB. And for us, whole genome sequencing is the equitable tool which will be able to support in elimination of drug-resistant tuberculosis. Why? Because TB cannot be treated empirically. You need to know what is the resistance profile across the drugs which are being used, across the first line drugs which are generally or group A, group B, which I will come to the definition later. Currently what is happening, the first line drugs which are used is HREZ, which is rifampicin, isoniazid, ethambutol and pyrazinamide. Most of them, the clinicians are just basing on this, the information which is related to this. But then what about fluoroquinolones? There is almost 60% resistance to fluoroquinolones. So you need to identify all of them. And so what can be done? The current diagnostic methods are just are kind of in a way very incomplete, because they are just identifying bits and pieces. You have a test which will just identify rifampicin or resistance or isoniazid resistance and so on, and drug and culture, which is generally used for drug susceptibility testing, culture and drug susceptibility testing, which is a part of the diagnostic algorithm, will take almost sometimes up to 65 days to tell you what is the resistance profile. So till that, as such time, that patient is being treated empirically. If he is being treated empirically, there's a possibility that the treatment is being treated incorrectly also, and that will result in transmission. And we also know that tuberculosis affects predominantly the lower strata of the society and causes considerable both sacrifices and harm both to the individual as well as the economic consequences of that are very high. So it's time for precision medicine in infectious disease. And why do we need to sequence, and why do we need to have much more nucleotides that need to be done? This is the reason, because now the WHO criteria, which is the grouping has been based on what is indicated in this chart over here. So if you look for drug resistance, there are several regimens which are there for treatment of drug resistant tuberculosis. And if you look, so if there are group A drugs, group B drugs and group C, where you need to complete. So if you look at the table on your left hand side, if there is multi-drug resistance, which means resistance to either at least to isoniazid and rifampicin, you need to include all three medications from the group A, which is levofloxacin, bedaquiline, linezolid. You could add one or both medications from group B, which is clofazimine and cycloserine or terzinolone, and from group C, the list of medications which are indicated. So now we need to know what is the resistance profile, if there are any resistance across all these category of drugs, so that we are able to give a personalized and right treatment to the individual. Now, basis this, the definitions of drug resistance, if you look at the table on the right hand side, these are the definitions of drug resistance. So if you have resistance to rifampicin, isoniazid and fluoroquinolones, it's indicated as pre-XDR, whereas if you have, include also the newer drugs, group A drugs, which is bedaquiline and linezolid, then it becomes XDR. So here, and we need to, and I've also indicated the gene target, so we need to actually do a whole genome sequence. And if you see, the Mycobacterium tuberculosis genome is 4.4 MB in size, so it's not a very large genome, but as my previous as the previous speakers have indicated, and as Dr. Shiva has also indicated, that the Mycobacterium genome also is a bit difficult, because Mycobacteria as a bacilla itself is very difficult to get the DNA content out of the cell wall. So you need to, that also forms the basis of the whole genome sequencing. You need to have quality control, you need to have the right starting material in order to do a whole genome sequencing. So what exactly is whole genome sequencing? And I will not go into the details of what is next generation and what is first generation, because Dr. Shyam Bhattacharya has already spoken about that. Your whole genome sequencing is basically the analysis of the entire genomic DNA of a cell at a single time. It's most comprehensive characterization of the genome. It's a high resolution sequencing technology. It's also known by different acronyms such as whole genome next generation sequencing and massively parallel sequencing. Now, the basic workflow for whole genome sequencing remains the same in cases of TB whole genome sequencing also. You could have, it starts with the sample collection. The sample collection can be pulmonary or extrapulmonary samples. It could be BAL, it could be any of lymph node biopsies and so on and so forth. Once then post, decontamination, it's kept for a mild enrichment step. The enrichment step serves two purposes. It kind of allows, because TB, it eliminates the dead bacilli basically over a span of a few days or a week, and it allows the growth of the bacilli so that the subsequent downstream steps can be done. So then you have DNA extraction, you have the pre-sequencing preparation, you'll have the library prep, and basically then the sequencing which will be done, followed by data analysis and report generation. Now, if you look at, these are all the list of, these are the, drugs which are used in the management of TB, and these are the names of genes which are also indicated. So you have rifampicin, RPOB gene, which is involved with resistance to variants in which will be involved with resistance to rifampicin, which is, you have the gene expert. Most people who have been in TB diagnosis would know gene expert, where it identifies whether you have the Mycobacterium tuberculosis detected, not detected, and it'll also tell you whether you have resistance to rifampicin. So here, and then you have some, you have isoniazide, which will form the basis of certain of the line probe assays, which I will also discuss. But here you can look at all the genes which are there. So current diagnostic tests, what do? They kind of identify probably only certain regions in the rifampicin, RPOB gene, which is the rifampicin resistance determining region. You also, in cases of isoniazide, you only determine resistance to like a CAT-G and INH-A. But now, as information and as sciences progress, we know that there are resistance variants in other genes like the FABG1 and INH and NDH and AHPC, which is also involved with resistance to isoniazide. So if you're only going to look at CAT-G or INH, it's an incomplete solution that you're giving. So here also some of the newer drugs like bedaquiline and delamanid, these are some of the data, if you see, we are also seeing resistance which is developing to these drugs. So if we are not going to be able to identify that, and if the transmission is going to happen, then we will be left with no choice to be able to treat these patients. So it's really imperative that we do a complete or a comprehensive drug susceptibility testing for tuberculosis patients, so that we are able to give the right treatment to the right patient at the right time. Now, this is some of the data which I am sharing with you. This is a study on 50 patients which we had done, where the red indicates resistance. I'm just trying to drive home a point. Like the red is indicating resistance to so here these are the patients, the rows are the number of patients, and and the columns indicate whether resistance was there in this patient to rifampicin. Here it is to isoniazide, some of the fluoroquinolones. The green indicates sensitivity, and the blue bars indicate where the information was not available. So in this patient, you had resistance, like if you look at the patient number 3, you have resistance to rifampicin, which was indicated by the first line probe assays, which are other assays, molecular assays used in TB diagnosis. You also have INH resistance, which is there by first line LPA and fluoroquinolones, as well as you have resistance to certain second line injectables. Now, a lot of these blue regions, when we did the whole genome sequencing, this is how the entire data has changed. We have a lot of regions which are now highlighted differently. We have the complete data which is available. Now you can see that not only you have resistance, this third patient has resistance also to pyrazinamide. In addition to that is resistance to ethambutol, to the fluoroquinolones, isoniazide, and as well as streptomycin, isoniazide and rifampicin was already indicated by the other molecules. So what I'm trying to say is, if you look at compare and contrast kind of an approach, this was where the information was not available. You have regions of blue where you don't know what is happening and you're treating empirically. This is what is happening after you have you have done the whole genome sequencing. This is another small study which we had done from under the program with Lal Bagh Cha Raja, which is which is a festival which is done which is there in Maharashtra, the Ganpati festival. So we had done a small kind of initiative, and where all the presumptive most of the TB cases which were done was studied with with drug resistant with for by whole genome sequencing. Now what we're trying to tell, what I'm saying, I'll just, for lack of time, this was, now whole genome sequencing, what we can do is also be able to identify what is the lineage, and identification of the lineage plays a very important role, because some of the lineages tend to have a predilection to resistance. Like for example, the Beijing lineage. The Beijing lineage tends to gain a rather higher resistance profile. So your and resistance, once you know what is the lineage, it will also kind of help in how the transmission is taking place. So whole genome sequencing can not only identify what is the resistance profile across all the different drugs, it will not only help you identify what would be apt, but it will also be able to tell you what are the lineages and support you in terms of transmission and so on. So what we saw was a large number of cases which were kind of being treated as MDR were actually pre-XDR in these cases. And in pre-XDR, that means you even have the some of the first line drugs which will not be effective. And if you see, this is the data of the drug resistance profile, where we had in these individuals, we are also seeing resistance to bedaquiline, and this was something which is really, I'm sorry, you're seeing resistance even to bedaquiline. This was something really scary, because bedaquiline is a it is a group A drug. It is the first drug that is kind of given for multi-drug resistance individuals, and then we are seeing resistance even to bedaquiline, as well as the repurposed drug linezolid, which is there. So this is hence I'm emphasizing on the need for whole genome sequencing to be able to identify, across the entire drug resistance profile. So this is some of how the distribution was played. A significant proportion of individuals were resistant to isoniazid, rifampicin, streptomycin, and across. So coming to that, what is whole genome sequencing actually addressing? What is the incremental information that is just giving? So if you look at in the diagnostic algorithm, you actually have GeneXpert, which will tell you, like I've already indicated, whether it is MTB and whether resistance to rifampicin. But again, GeneXpert itself looks only at certain regions. So if you look at this one mutation, the I491F, this is outside the region which is targeted by the GeneXpert by the probes which are there in the GeneXpert for determining resistance to rifampicin. And if it is not detected, that means that it will not be treated, and not treated means it is going to be transmitted. So in that case, this is offering an incomplete solution. Secondly, if you look at some of the other diagnostic assays which are there, which is the first line probe assays and the second line probe assays, which will determine resistance to fluoroquinolones, the second line determines resistance to fluoroquinolones, the first line determines resistance to isoniazid and rifampicin. Again, it depends on two aspects. You have to have your wild type. You have two bands basically. It's based on the probe development. After you have your DNA, it's reverse hybridization. So you have to have your development of the probes after you have your DNA amplicons binding to it. So you have wild type and you have mutant. So you want your wild type to be not developed and you want your mutant to be developed to indicate that there is resistance. But there are certain scenarios where the wild type is also not developed and the mutant is not also developed. So what happens in such a case? In such a case, you are just assuming that it is resistance inferred, and then you further need to actually corroborate it using an alternative technology, which is either sequencing, or you need to do culture DST and wait for the results, which could be as much as 6 weeks. So here what sequencing, whole genome sequencing is also doing is able to identify actually and support in terms of failing bands for the line probe assay. I think I have only a minute, so I will also limitations of the culture in DST. There is a lot of false error rates with culture and DST. So almost, like I already said, pyrazinamide and ethambutol, which are used, they are used as the first group, first line drugs, and they have a high degree of false error rates. So again, if you're going to be dependent on results from the phenotypic methods, it will not be correct. Also, what happens is phenotypic methods systematically determine those which may actually be resistant. They may determine them as susceptible, because it's a binary cutoff. You are just using the concentrations, like it's a binary cutoff method. So there may be organisms which are just growing below the minimal inhibitory concentration that is used for determining the drug sensitivity in a phenotypic or a culture method. So you actually may think that it is sensitive, but it could be a resistant organism, because it's not like you're doing a dilution and looking at what levels your organism is resistant to. You're just using a specific cutoff and saying whether it is resistant or not. Whole genome sequencing can also determine whether there is relapse and reinfection. And I just like to touch upon what are the performance metrics, and there are several studies, but so the performance whole genome sequencing, if you look at, it's up for the sensitivity and specificity is upwards of 90% for all of the first first line drugs. For across the other drugs, it ranges from 70 to 90%, and the reason being that still phenotypic methods like culture DST is considered as a gold standard, and currently the sensitivity is being benchmarked against that. So it ranges across from 70 to 90% across the other drugs. If you look at the agreement between various as an orthogonal test, culture DST versus the versus CBNAT, which is cartridge-based nucleic acid amplification test, both for GeneXpert as well as TrueNAT. The sensitivity, the agreement is 49%. With culture and DST and LPA, the agreement has been 63%, whereas with culture DST, and this is only for those which have been tested. We're not talking about the incremental information of culture, what it gives. We're just talking about CBNAT rifampicin versus culture rifampicin and so on and so forth. And culture DST versus whole genome sequencing, the concordance is almost 93%. So, whole genome sequencing performs significantly, well in terms of sensitivity, specificity, as well as concordance. It has been there in the WHO. The WHO has indicated there is a catalog where already more than 30,000 isolates have been tested, and both genotypic phenotypic correlations have been done. So the entire technical details are available, as well as a mutation catalog, which is there available for for determining the whole genome resistance. So the question arises that if we see so much significant utility of whole genome sequencing, why is it not routinely uptaken as a part of the government? Because we that TB under the as a notifiable disease, the government takes a lot of initiatives, a lot of steps. It has the NICSHARE portal under which the individuals are registered, and treatment as well as nutrition aspects are being taken care by the government, but still why it is not being why it has not been come. What is anticipated are certain roadblocks in infrastructure, roadblocks in development as a in the bioinformatics, and that is what something which we have overcome as an we have developed the assay. We are enabling all labs to be able to do that. We don't do it ourselves, we are tech providers. We are enabling the labs to be able to do it, so that from the NGS or the data, they're able to do a report generation within a very short time, without the need for a lot of bioinformatics expertise which is there. This is just like a sample report. With that, I'll just come to one. Basically, actually everybody can benefit from whole genome sequencing. So here is just a list of patients who can actually benefit, who are categorized. those patients in whom drug resistance is suspected, patients with bacteriologically confirmed Mycobacterium tuberculosis, in whom first line has failed, in whom second line has failed, where there is a relapse, patients who have initiated antimycobacterial therapy, it's discontinued and are about to reinitiate, and patients who have an underlying predisposition that makes treatment difficult, also those who have a close contact with known MDR or XDR patients. This is just one case report, and I know Dr. Nagraj, I will just take 1 minute. So this was, I would just like to say, this was a patient who is a 30-year-old male, and patient was put on all oral longer regimen. So you know you have pyrazinamide, which is included in an all oral longer regimen. Now, and then the whole genome sequencing was seen. Somehow we got pyrazinamide inconclusive. So when we did this, when we did a deep dive into trying to understand what is the reason for it, we saw that this we are seeing a large gene, the pyrazinamide, the entire gene was deleted when we did the whole genome sequencing analysis, and then we did the bioinformatics. Now what is interesting is, if the gene is deleted, now pyrazinamide gets converted from a prodrug into an active drug. So this actually confers a advantage to the bacteria in terms of survival, and this kind of information would only be available from whole genome sequencing. So currently whole genome sequencing is addressing a lot of challenges, and we hope that it will be it will gain the importance and the traction that it requires for precision treatment in infectious disease. With that, I will conclude my talk, and thank you everybody for such a patient listening.
Thank you, chairpersons and the speakers. We now move on to the last and the most awaited valedictory function. I call Dr. Nagraj Arora to take over from here.
So finally we come to the end of the session. All good things must come to an end. And I will begin by thanking so many people who have, without whom support this meeting would not have been possible. First of all, I would like to thank Molecular Pathology Association of India, the EC members, who have been very instrumental in planning and organizing everything. We have had a lot of meetings, after which this program was finalized and we see in this particular shape. All the EC members. No meeting is complete if we do not have the right faculty. I need to thank all the eminent faculty all across the country. We have people from all across the country who have had most experts in top people in almost all areas. We have also have international faculty who we learned. So I need to thank them. Thank you so much for being here and teaching us so much. No meeting is complete without the active support of the delegates. I need to thank you all from coming from everywhere and making this a success. I think we need to give a round of applause for everyone. Thank you so much. As I already mentioned in the morning, we have had 360 registrations, almost 150 in workshops, more than 500 people online. So it is a huge success, and it is all because of you. So thank you so much, each and everyone who has been viewing it, who have been here, who have been associated with this meeting in any way. I also need to thank the sponsor companies or the friends of the MPAICON, without whom this meeting would not have been possible. There have been 22 companies who have been supporting this meeting, which include the Genes to Me, DSS, AstraZeneca, Strand, Thermo Fisher Scientific, Kusara Diagnostics, Shiva Scientific, Kaizen, SRL, Unipath, Biored, Appendoff, Biochrome, NEB, Takara, Zelle Biotech, High Media, True PCR, Medispec, Bioinnovation, One Cell Diagnostics, and MedGenome. So we have had a very, very enthusiastic support from the friends of the industry. I need to thank the organizing team at Unipath, who may not have been in the forefront, but in the back they have done a lot of hard work, in a way supporting the meeting in which it has been possible, be it Dr. Jwalant, Dr. Apurv, my team, Dr. Ekta, Dr. Spandan, Dr. Amisha, Dr. Meenu, Pooja, Toral, lot of people in various departments who have had a role in workshops and in other areas, so that we have been able to do what you have been seeing. I need to thank actively the event management team led by Rajesh Sharma ji, and I think this meeting would not have been possible without them. With the core team, you have been interacting. Rajesh was leading them. There was people, Neerav, Manan, Narayan, and Paresh. You have been, I think many of you might have met them in some way or the other. So need to thank you so much, all of you who have been, and also need to thank the team from MICE Ideas as well. Then thank you so much, the Hotel Narayani team. It has been very great organization. I don't see any major problems in organizing over here. They have been effortlessly handling all the things that we did. There were a lot of changes we did in between the sessions. So thank you so much, Hotel Narayani team and staff, for this wonderful organization. And I would come to the, I think, two things that I need to announce is the next meeting. Next meeting is to be held in SGPGI Lucknow, and Dr. Khaliqur Rahman, who is the organizing secretary, has sent a welcome message to all. He has invited you all the MPI members and the delegates to be there. So I'd request if you can look through that and be there. Even 2024, the meeting has been decided, and 2024 meeting will be in All India Institute of Medical Sciences, and Dr. Soumya Ranjan will be the organizing secretary for that. Now we come to the last part. There have been few prizes, and one of the first prizes we will take up is there was a lucky draw kept from the Medispec, and I would request the team from there to pick up those who visited that stall. There is a lucky draw for all of them. Can you please bring? And I would request Dr. Ravi Gaur sir, please, if you could just select 3 people from that, and that we will announce those names. Can you come here and pick it up, sir, please? Dr. Girish Gaur, please. Please, sir, please. Can come here, please. One more, sir.
Two
there
more.
Have been two more.
So
that got stuck. We have Dr.
Professor Rakesh Rawal. He's not here, I believe. He's
oh, right now. But we'll contact and we'll,
no problems. No problems.
It's the third one. Anyway.
No, I think it's an exchange here, right?
Dr.
Dr. Amrit, she has already left in the morning.
So we have a phone numbers and we'll contact for the third prize. Thank you so much.
Thank you so much.
All the organizers to giving us a chance to participate here.
Thank you.
Thank you all the attendees.
Thank you.
Thank you, sir.
Thank you, sir. Now for the abstracts and the oral posters, so we had received a total of 42 abstracts, and those abstracts were sent to 4 judges, Dr. P.G. Subramaniam, Dr. Manjeet Mehta, Dr. Ankit, and Dr. Hansa Goswami. So we sent blindly. It was nobody knew about those abstracts. 10 abstracts were sent each to each of the judges. Out of those 4 judges, out of those 10 abstracts, they were allotted marks, and the top 4 from each judge were put up for the oral presentation, and rest were taken up for the abstracts. So we have 3 prizes for the oral, and we have 3 prizes for the abstract. and I will announce the names of the posters. So subsequently, these posters were judged by two judges, Dr. Parimal Sarda and Dr. Soumya Ranjan Malik were the judges for these two posters. So in the first prize, we have Dr. Deepshi Thakral. Can Dr. Deepshi please come up? And I will request Dr. Mishra to please sir, can you come up please and prize. Can you come up upstairs please? A round of applause please.
So, congratulations and wish you many more in the future.
So the prizes have been very generous. These have been laptops or the tablets or the watches. So very nice prizes have been there. Thank you. Sir, please. For the second prize, we have Dr. Hunaya Bhavangiri. Dr. Hunaya Bhavangiri. For the third prize, we have Dr. Dharmesh Patel. Topic was, I think, epigenetic signaling in breast cancer. Yeah, please.
Congratulations.
Thank you, sir. One more, sir. Okay. There was an, the judges wanted to have an additional prize, and we have supported that. There's a cash prize of 2,000 rupees because of the case report. We had only 3 prizes, but judges, on request of the judges, we had to include another tie in that way. Dr. Fiona Hannah Carlos. She's here. We will contact her and give the cash prize. Thank you, sir. Thank you so much. So for the oral papers, the first prize, Dr. Amit Rawat. Dr. Usha Dave, can I request you, ma'am, can you please come up? Yeah, that is a laptop. This is the laptop.
For both of us?
So, thank you. For the second prize, please be here, ma'am. Dr. Rakesh Demde, please come up. This is a tablet. A Galaxy or a Samsung tablet, I don't know, but this is a tablet. The third prize is Dr. Bhagyashri. Dr. Bhagyashri, please. Thank you. Thank you. There was one online quiz also which was going on, and we have a winner for that, Dr. Tanima Dwivedi. She's there? Actually, she's online only. Oh. She was online. Okay, so then we have to give 2,000 rupees prize for the quiz that was there.
Thank you. Thank you.
Okay, ठीक. So that was it from my side. So thank you so much. This comes to an end. I invite you all to the next meeting in SGPGI. We get together there and meet there. So thank you all. Thank you so much. Thank you.